वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं देवस्य धीमहि
మీటింగ్ ఉంది, దాన్ని కూర్చొని నేను మీకు ఫోన్ చేస్తాను నిన్న.
ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो
Good morning, respected faculty members and dear delegates. Welcome to the sixth day of this program. Today, we will be mainly covering various topics related to different matters, mainly neuro cases. And we have with us Dr. Mani Mala Rao and Dr. Alka Gupta as our first chairperson. Dr. Mani ma'am, welcome to the program.
Thank you.
Ma'am is Director of Medical Education and Academics, a consultant in critical care. Her institute of affiliation is KIMS Hyderabad, and her areas of interest are ARDS, sepsis, fluids, and ventilation. Welcome, ma'am.
Thank you. All the best for you. You've been doing a great job.
Thank you, ma'am. We have our second chairperson, Dr. Alka Gupta, with us. Ma'am is professor with ABVIMS and Dr. RML Hospital, New Delhi. Her areas of interest are neuroanesthesia. Welcome to the program, ma'am.
Thank you. Thank you, Nidhi.
Ma'am, Dr. Mani ma'am, can you introduce the first speaker?
You have not sent anything to me.
Ma'am, this is the...
Okay. Good morning, everybody. And it's really nice to be with all of you youngsters. And this is Dr. Shilpa Agarwal, Associate Professor of Affiliation University, or the college is VMMC. And her areas of interest are pediatric anesthesia, acute pain services, and robotic urology, as the youngsters are practicing much more of robotic and laparoscopic these days, unlike in our time. And I welcome you to start the lecture. Shilpa.
Good morning, everyone. I'll be talking about enhanced recovery after surgery. I am Dr. Shipra Agarwal, Associate Professor from VMMC and Safdarjung Hospital. So we all know the perioperative period is a pretty stressful period, and the post-op period is very long, with a long and stretched convalescence period. So to fast track the recovery in the post-operative period, the concept of enhanced recovery after surgery has come into a bigger picture worldwide. So what is enhanced recovery after surgery? It is a protocolized scientific pathway to boost outcome and enhance recovery, as the name suggests. So it's also known as ERAS, or Enhanced Recovery Pathway. It's multimodal and multidisciplinary, and is most importantly evidence-based, with a constant research, education, audit, and implementation. It is interdisciplinary, with conjunction between anesthesiologists, surgeons, physicians, and nurses. So the concept was first given by Professor Kellett and Wilmer in 20th century. The first consensus guidelines were published in year 2005. Henry Kellett, he's the big man who gave us the concept and findings of ERAS in a bigger way. Now, why it makes sense to have ERAS implemented in our institutes? It basically helps to modify the physiological and psychological response to the surgery of the patient. It reduces the length of hospital stay by around 30 to 40%. It reduces the perioperative complications, the morbidities, the stress response. It improves the outcomes and expedite the recovery in the postoperative period. And most importantly, there is a great reduction in the healthcare costs, especially in a third world country like ours. So as we can see, in the preoperative period, we are at a lower level from the optimum health state. Then during the operative phase, there is a dip, and there is a pretty long post-op period. And then also, even after such a long duration, we are far below the optimum health state. Now, if we follow in the ERAS protocols, we try to bump up near the optimum in the preoperative phase itself. After a decline in the health in the operative phase, we try to shorten the post-operative phase as early and as much as possible, reaching up to the optimum health state as soon as possible. Now, there is a lot of published literature which signifies that how important ERAS has now become. So there are elements of ERAS in the preoperative, intraoperative, and postoperative period, which means that we should start at our first interaction from the patient as well. The most important thing is that it involves active patient involvement. And then after a conjunction of all the elements, there is an audit. And then again, there is restructuring so that there is improved outcome. And there should be a whole team involvement. So starting from the preoperative elements. So the preoperative element in ERAS, it starts at the first interaction with the patient. The patient should get detailed information about the procedure and the anesthesia. It will help diminish his fear and anxiety and will help us in the early post-operative recovery. The patient should be counseled, and if the patient is not able to make any decision, it should be shared. The instructions should be clear and specific, and then there should be verbal and written information, which includes the consent also. After that, the patient should be stratified as per the risk involved, which includes assessing the patient's physical, mental, and functional status. Now, it is important because 80% of the post-operative deaths occur in the high-risk group. This we can do by judiciously using a lot of preoperative scoring tools, of which ASA is the most commonly used. The others used are Possum score, Lee score, cardiopulmonary exercising test. Now, this is the tabulation of showing the various scoring tools. Like we can see the P-Possum, it includes around 12 physiological and 6 operative variables. Recommendation. So is the Lee's index, which shows the perioperative cardiac complications and again has a very strong recommendation, and so is the Shuttleworth test. The other important thing is the optimization of the pre-existing health conditions. The patients, when they come to us in the pre-anesthetic checkup clinic, must not be optimized health-wise. So we have to first identify and then optimize to as much as possible their coexisting health condition, which may include diabetes mellitus, hypertension, ischemic heart disease, anemia, and COPD. Abstinence from smoking and alcohol for a month has shown wonders if we do that in the preoperative period. Correction of nutritional deficiency, which is mainly hypoalbuminemia, is very important and should be done as per the ASPEN guidelines. As we can see that there is a very high strong recommendation of smoking cessation and medical optimization. As you can see, this diagram also evaluates the importance of optimization of nutrition, blood sugar, and smoking in the preoperative period. These patients are generally on a lot of medications. So knowing what medications are they on and optimizing the medicinal status is also very important. Rehabilitation. This is a very important concept in ERAS. This is basically educating the patient and the family, and it helps in early recovery by decreasing the anxiety and increasing the patient's satisfaction. The most important thing in prehabilitation is that it involves a lot of patient's involvement itself. The new prehabilitation includes nutrition, exercising, both physical as well as cognitive, and a no-worry state, which includes anxiety and stress reduction. This is a narrative view of prehabilitation, which includes physical exercise, nutritional therapy, a good cognition, no tobacco, and correction of anemia, as previously discussed. Now, forever decades, we know that prolonged fasting, no aspiration, a safe anesthesia. But now in ERAS, the concept has changed. We rather avoid a prolonged fasting and maintain a good hydration. Because prolonged fasting leads to increased insulin resistance, it leads to patients' discomfort and a decreased intravascular volume. So in ERAS protocol, we allow clear fluids up to 2 hours and solid foods up to 6 hours. We can give 12.5% of complex carbohydrates either at night or at 2 hours as per the volume. This will lead to decreased insulin resistance, will increase the glycogen reserves, decreased protein breakdown, and increase muscle strength. we must avoid pre-medications, especially oral benzodiazepines and long-acting opioids, as these may lead to post-operative amnesia and cognitive dysfunction. Note that patient education in the pre-operative period itself is a very best anxiolytic. Rather, we should mainly concentrate on the preemptive analgesia. So we can start the analgesics in the pre-operative period as well. We can give acetaminophen 1 gram or NSAIDs and COX-2 inhibitors if not contraindicated, or if the pain is likely to be severe, we can start the patient on gabapentinoids. DVT or deep vein thrombosis is a known complication in few surgeries. So we should aim at avoiding deep vein thrombosis by either starting on unfractionated heparin or low molecular weight heparin. We can also use bilateral sequential compression devices. Intraoperative use of thromboembolic deterrent stockings are also a must. For colonic surgeries earlier, mechanical bile or preparations were advocated because the surgeons thought that it will reduce the surgical site sepsis and infection rate. But as per the latest guidelines, there is no indication of routine mechanical bile preparation. Rather, it will lead to dehydration and electrolyte balance, and also there is no increased risk of sepsis. If you want to do a mechanical bile preparation, a phosphate enema should do well. Next, coming on to the intraoperative elements. So as per the anesthesia protocol, the basic idea is to use the shortest dose of the short-acting agents in a titrated way so that the patient awakes clear-headedly. In induction, we can use titrated doses of IV fentanyl and propofol. So we can use intermediate and short-acting muscle relaxants and aim at moderate level of muscle blockade with a TOF of around 2 to 3. We should reverse the patients when the TOF is more than 0.9. Maintenance is generally by inhalational agents, and sevoflurane and desflurane are preferred to target MAC at around 0.8 to 1 with a BIS of 40 to 60. TY is only used in high risk of patients with post-operative nausea and vomiting. Avoid using high concentrations of oxygen and use oxygen concentrations around 0.4 to 0.5. Nitrous oxide was debatable earlier because of the risks of PONV and bile distension, but now it has certainly got a weak evidence. Because of its antiemetic, analgesic, and second gas effects, nitrous oxide is advocated to be used in ERAS protocols. Antibiotics should be given 30 to 60 minutes before skin incision because it largely decreases the surgical site infections. Opioids should be avoided for as long as possible because there are severe side effects with opioid usage like nausea, vomiting, sedation, respiratory depression, and urinary retention. Advocate lung protective ventilation strategies, maintain temperature, glycemic control, and while emergence from anesthesia, maintain a minute ventilation for rapid emergence. Fluid therapy is a very important pillar in ERAS protocol. So from standard approach, we have now come to restrictive approach in ERAS. So it includes no preloading or replacing urine output, insensible or third space losses. Rather, goal-directed fluid therapy, which includes dynamic cardiac monitoring, should only be given in patients of high risk and surgeries with large fluid shift. But you have to monitor your urine output. If there is anuria, then you have to reassess your fluid therapy. As you can see in this diagram, if both the surgery and the patient profile is a low risk, then always go for a restrictive approach for the fluids. But if the surgical risk is high or the patient is at high risk, then we advocate goal-directed fluid therapy. The surgical therapies, now it's a trend of minimally invasive surgeries as well as their incisions. So laparoscopy is preferred over laparotomy, a transverse or an oblique incision over a midline incision, an endoscopic procedure over an open procedure. Nasogastric decompression should be routinely avoided. It leads to fever, oropharyngeal and pulmonary complications, and most importantly can lead to ileus in the postoperative period. Postoperative nausea and vomiting is a dreadsome complication in the postoperative period. So its prophylaxis should start in the intraoperative period only. Its overall incidence is around 20 to 30%, and its risk factors should be scored as per the APPEC scores. The approach is multimodal. If the risk is moderate, give dexamethasone and 5-HT3 receptor antagonists like an ondansetron. And if the risk is high, then use TIVA instead of inhalation and also in combination with dexamethasone and 5-HT3 receptor antagonists. Again, opioids are a big no-no. Pain is also a very important pillar in ERAS because if there is pain, the patient will have a delayed post-operative recovery. The approach is a multimodal approach. Again, we have largely come for non-opioid analgesia. So we can do it either by acetaminophen or COX-2 inhibitors or NSAIDs if they are not contraindicated. Local and regional techniques have come a long way. You can either give local infiltration, which is also known as the common wound infiltration or the surgical field block. The truncal blocks are also very important in ERAS protocol, especially in abdominal surgeries. You can give either TAP block or rectus sheath block, erectus spinae block, or quadratus lumborum block. Neuraxial analgesia by epidural or intrathecal morphine is mainly indicated for large midline laparotomies. Otherwise, they only lead to delay in ambulation, hypotension, and urinary retention and lead to delayed recovery in the post-operative period. Lastly, about the post-operative elements. Delirium is a much common problem, especially in the elderly subgroup. There can be alteration in the consciousness, orientation, and the sleep pattern. There are certain risk factors which can aggravate delirium in the post-operative period. Now, the interventions can be pharmacological or non-pharmacological. Ileus, which is transient reduction in the bowel motility, can be primary or secondary when there is a cause associated with it. Note that the incidence of the primary ileus is as high as 19% in few cases. So how can you treat ileus? So rather prevention is more important rather than treating the ileus. So what you can do, you can remove the nasogastric tubes at the earliest and the drains as well. Do enteral feeding as early as possible and discontinue IV fluids. You can also resort to sham feeding by chewing gums. So it will enhance the peristaltic movement of the gut. Early mobilization is very important. It leads to reduced skeletal muscle mass and improves respiration and oxygenation as well. In our robotic urological center, we will ask the patient to get out of bed on the day of surgery for around half to 1 hour. So the patient should be asked to be up and about for approximately 2 hours on the day of surgery and then further increasing for 6 hours consequently. For this, again, there should be no pain and there should be no catheters and drains. Nutrition, PONB, adequate analgesia, and the right discharge criteria are other important elements in the post-operative period. So now, in the nutshell, what is ERAS doing for us? It is reducing the median hospital stay, reducing the analgesia and the opioid use, no nausea, adynamic cast, and the most importantly, reducing the cost cutting. So where we stand today, we have come a long way in following the ERAS. So as you can see, there are few elements where we have almost achieved close to the 90%, which includes somewhere around, following giving carbohydrate drinks or following the DVT prophylaxis or the antibiotic prophylaxis. But majority of the elements are somewhere along the midway. So we should join hands and we should form our own institutional protocols to implement ERAS in a bigger way. So as an example, these are the ERAS elements in a cesarean section. As you can see, these are the preoperative, intraoperative, and the postoperative element so that there is enhanced recovery in the postoperative period for the mother. These are the references for your use. Thank you. I hope
Thank you, ma'am, for such a wonderful presentation.
Thank you.
Ma'am, as of now, there are no questions in the chat box.
Okay.
Alka, ma'am, can you introduce the next speaker? Alka ma'am. Alka ma'am, please unmute yourself.
I was not audible.
No ma'am, now you are audible.
Okay. So I would like to introduce Dr. Kajal Jain. She is professor in PGIMER, Chandigarh. Her areas of interest are obstetric anesthesia, trauma, critical care, and regional anesthesia. Welcome, Dr. Jain.
A very good morning to all the delegates and participants. And I want to thank the organizers for going through this marathon of 1 week long of teaching the postgraduates. And today we are going to talk on a very important topic early in the morning, and that's traumatic brain injury and its management. And since there are so many postgraduates sitting in the audience, I thought it will be useful to tell you that it is not only that we see traumatic brain injury in ICU, we see them at many other, managements of our clinical practice day to day. Like for example, I'll tell you that you may be even called to intubate a patient who has been injured and you are summoned in the casualty to intubate this patient, or it can happen that the patient has had a polytrauma, say he has got a skeletal fracture, along with that he has a moderate to severe head injury. He's cleared after 72 hours or so, and now he has come to your table for operation. So that is another scenario. And the third and the most severe one would be like you are holding the charge of an ICU, or you are managing a patient in intensive care, and what you need to know. So there will be some principles which are overlapping and some which are like very specific to these three scenarios I'm talking about. So first and foremost, let us understand what is traumatic brain injury. So basically, traumatic brain injury is defined as any alteration in the brain function or other evidence of brain pathology caused by an external force. And it is accompanied by any period of loss of consciousness, amnesia, which is not related to any other cause. It may be even having a neurological deficit, and there may be a persisting neurological mental status. So if you talk about epidemiology, mild to moderate head injury, the incidence is somewhere about 75 to 80%. Severe head injury is like little less, 5 to 15. But what is more important is the morbidity. Morbidity is about 70%. And if we look at the demographics, the males are injured more than females, and that is because males are more often on the roads than women. And on the right hand side, you can see that what is the number of accidents and deaths per 1,000 vehicles in different countries. And if you look at India, the number of deaths happening due to accidents per 1,000 vehicles is 2.5, which is fairly high. And as we had seen in the previous slide, many patients suffer head injuries. So it's very important to understand this topic. So what are the different types of injuries you see? You see like a primary injury, which could be a blunt or a penetrating injury. And there are some, this primary injury is largely irreversible. So what damage has occurred at the site of accident or before arrival to the hospital is largely uncorrectable. Now it's been done. But there are some secondary injuries which we will be highlighting little later, which we can manage and improve the outcome of the patient. When we talk about primary injury, we should know that there are basically like either there can be intraparenchymal or subdural or epidural hematomas, there can be bleeds, or there can also be diffuse axonal injury. It all depends upon the biomechanics of the injury, like how has the patient sustained the injury, whether his head moved against a moving vehicle or he hit against a stationary object, or sometimes it is like the head also undergoes a rotational injuries. In those cases where the forces are acceleration, deceleration and rotational, you will see diffuse axonal type of injury. you can imagine like how a jelly, if a jelly is shaken in a bowl, then it will have minor cracks. So that is what happens in diffuse axonal injuries. So these are the type of injuries you look at when you see a head injury patient. So how do you come to know how severe is the head injury? And we all know that it is defined by a score which is called Glasgow Coma score. So Glasgow Coma score of 3 to 8 defines a severe head injury, whereas moderate head injury falls between 9 to 12 and mild between 13 to 15. And recently we'll be talking about this in the next slide also. Glasgow P is calculated by subtracting the pupil reactivity score, that is called PRS, from the GCS. So the total score would be GCS minus P, GCS minus pupillary reactive score. So earlier on we were all seeing Glasgow Coma scale as eye-opening, none, and then to spontaneously or to speech. But now we have changed this definition and this Glasgow Coma scale, and now we call eye-opening, none, to pressure. And we say pressure when it is applied to supraorbital ridge or on the nail beds, and it is not to the sternal rubs, as it causes bruising and responses can be difficult to interpret, and even retromandibular pressures are not recommended. So verbal response is none, or to the sounds or some words, confused or oriented. Best motor response is either none, that is M1, M2 is extension, M3 is abnormal flexion, 4 is normal flexion with withdrawal, 5 is localizing, and 6 is obeying command. So it will be like E1, V1, M4. So you can come to know if the total score adds up to less than 8, then the injury is very severe. So along with that, if you just check your pupils and both pupils are reacting, the score is 2. So we saw in the previous slide that GCS P is GCS minus pupillary reactive score. So that will give you the final score. So one pupil is reacting, you get one score, and neither pupil is acting, that means 0 score. So having understood this, we must go back to understand the basics, why this is happening in the brain. So for that, we all know that there is this theory about Munro-Kelly doctrine. And Munro-Kelly doctrine states that cranium is a fixed structure. And the 3 things in the cranium, that is CSF, blood volume and parenchyma, are housed in this fixed structure. So CSF is to the volume of 150 mils and blood volume about 150 mils, and rest is the brain parenchyma about 80%, that is 1400 mils. So if any of these increases, it presses the other occupant, and that causes a pressure in the cranium, because cranium is a fixed structure. So if it's a bleed in the parenchyma, so it will occupy the brain parenchyma volume more than 1400 ml, pressing upon the blood volume or the CSF volume, and therefore patient will manifest with some signs and symptoms of raised ICP. And then we also need to understand that the autoregulation which occurs for a vast range of blood pressure, that is 50 to 150, is disturbed if the head is injured, and it impairs the dilatation, and it can cause collapse and ischemia if the blood pressures are not maintained in this autoregulatory range. So if the range goes up, then there is forced mediated dilation and increased flow and vasogenic edema. And if there is a impaired dilation, then there can be ischemia as well on the left hand side. So how you see this? You see it like this. Say this is a normal brain on the left hand side, and you can see that the autoregulatory curve is maintained over 50 to 150. However, if there is a occupying lesion, like there's a contusion with edema, then the autoregulation can be disturbed, and if the pressure keeps on increasing, the flow may decrease and it may cause further ischemia and infarction. So talking about secondary brain injury, which worsens the primary insults, are hyper and hypoglycemia, hypercarbia, hypoxia, hypotension, acidosis, and coagulopathy. So we will see that this is what we have to manage when we get the patient. So many times you would see that when we ask for neurosurgery clearance, our colleagues, they write, avoid hypoglycemia, hypercarbia, hypotension, and we do not like it. Basically, they are trying to tell us that do not worsen the primary insult, take care of the secondary brain injuries, which is very much in our hands. So, how, if this patient comes to you in trauma bay, then how do you go about it? You, as I earlier said, you have to do the primary survey like A, B, C, D, E. So you have to look for the airway, see spine stabilization, check for the breathing and ventilation, see for the circulation and disability and exposure and environmental control. These are all features of primary evaluation as per ATLS guidelines. However, there may be places where you see such a patient, say for example, this patient has got a big subdural hematoma and you can see that it is also causing a midline shift, or patient is having associated facial-maxillary injury. All these patients, they pose a physiologically difficult airway, and if you are not cautioned, then you may even raise the ICP beyond control and patient can herniate, and this can cause a mortality. So what we need to understand is that before we intubate these patients, we should have our equipment ready, like the suction should be there, oxygen, airway support equipment like laryngoscope, multiple blades, multiple size ET endotracheal tubes, stillets, and backup options, bougie should be present. So you must also choose your induction agents wisely. It is preferable to calculate the shock index, that is heart rate upon blood pressure, and if the shock index is more than 0.9, you should be very aware of it and administer dose in drugs which do not cause further fall in blood pressure. So a good choice would be ketamine or etomidate. In our setup, ketamine can be used. Earlier, we were very apprehensive about using ketamine because we all believed that ketamine raises ICP, but those fears have now been negated by a newer literature and so much of evidence suggesting that ketamine is beneficial for traumatic brain injury patients. We must also use a paralytic, and push dose of vasopressors should be available with us. Push dose of vasopressor implies NOR-ADR in the dose of 5 microgram per ml can be given to maintain systolic blood pressure above 100 mmHg or as per age, which we will see in the subsequent slide. Must also attach the patient to the monitors and note down the saturation, because peri-intubation hypoxia can again worsen the outcome of the patient. If available, end-tidal carbon dioxide should also be measured. So we must also practice doing rapid sequence induction, because all these patients are considered to be full stomach on arrival, and some of them are potentially, even aspirated. So we must do rapid sequence induction. For rapid sequence induction, don't forget the 7 P's of preparation: pre-oxygenation, pre-treatment, paralysis, as I've already explained, then correct positioning. If the patient is having C-spine issues, then we must maintain manual inline stabilization, and then after placement of the tube, we must confirm if ETCO2 is there, we must confirm with that, otherwise with surrogate measures like mist in the tube and bilateral air entry equal. Then post-intubation management strategies should be very clear to us. And having said about rapid sequence, I will say a word about delayed sequence intubation. In rapid sequence intubation, what happens is we pre-oxygenate and then we give the pre-treatment and paralysis. Whereas in delayed sequence intubation, you just change the sequence a bit. Like first you give dissociative dose of ketamine, which is classically like 0.5 to 1 mg per kg body weight. And once the patient is calm, most of the patients of traumatic brain injury are hypoxic, agitated, and they are thrashing around and they won't let you place the mask. So this concept of delayed sequence intubation has come from this problem, that these patients do not allow placement of a face mask on the face, and therefore they cannot be pre-oxygenated to get a good oxygen level. So if you do a delayed sequence intubation with a dissociative dose of ketamine prior to pre-oxygenation, you are able to attain your target. Like first you give the dissociative dose, and once the patient is calm, you pre-oxygenate, and then you give paralysis, positioning, and then finally the same sequence of events. So this is a newer concept which is being now studied, and very soon we will have it in our guidelines also. So for all this, your team should always be ready. This is my team, and this is how we send a team whenever a call for intubation from trauma triage comes for head injury patients. So after this, we all know that the patient is intubated. Now, if the GCS is less than 13, when first assessed in emergency department, or patient is GCS is less than 15 when assessed in emergency department 2 hours of injury, or there is a suspected open or depressed skull fracture or signs of base of skull fracture like hemotympanum or raccoon's eyes or battle sign, then if the patient is throwing a seizure and there is a focal neurological deficit, more than one episode of vomiting, amnesia for more than 30 minutes before impact, and all these patients need to be subjected to non-contrast CT scan. In CT scan, we will come to know the findings, whether it is like what is the primary injury, whether it's a bleed, it's a contusion, it's a hematoma, or it's a diffuse axonal injury. So that will give us insight into which patient should be sent for CT. So before you send for CT, your patient is intubated. So in the CT scan, there is a classification which is called Marshall's classification, and it gives you the extent of injury, like whether it's a diffuse injury, if there is no visible intracranial damage on CT, or cisterns are present with midline shift 0 to 5 mm, low lesion densities are present, no high density or mixed density lesion less than 25 ml. And diffuse injury grade 3 is when cisterns are compressed or absent with midline shift 0 to 5 mm, no high density or mixed density lesion more than 25 ml. However, diffuse injury is grade 4 if there is a midline shift more than 5, no high density or mixed density lesion more than 25. So this will alert you to the severity of this disease and the possibility of taking the patient into the theatre for decompression or evacuation of bleed. So when you are looking at this patient, these patients need resuscitation. So you need to stabilize these patients to prevent further increase in intracranial hypertension, and you must maintain adequate and stable cerebral perfusion pressure, which equals to mean arterial pressure minus ICP. So the CPP targets are normally kept at 60 to 70 with a mean arterial pressure of 80. When you consider ICP is more than 22 mmHg in an adult patient. So we must at the same time avoid systemic and secondary brain insults. And must also remember causes of secondary injuries, which we'll be talking about. So when we talk about fluid resuscitation, you must choose your fluids wisely. Do not infuse more than 1 liter of crystalloid. And whenever you are choosing crystalloid, it is a good idea to start with balanced salt solution and do not use hypotonic solutions or dextrose containing solutions. What about colloids? Like colloids, they have been found to be associated with increased morbidity, and there is no benefit over mortality. So this was following the SAFE trial. So it is best to avoid albumin, and Hess similarly may interfere with coagulation, so should be avoided. So as I said, 1 liter of crystalloid followed by blood and blood products in the ratio of 1:1:1. Hypertonic crystalloids can be used if patient is showing simultaneous hypotension. So you can make use of 3% sodium chloride in some situations. So what happens in intensive care management? How do we look at a patient in intensive care? Like when a patient is received in intensive care, we have to target all the secondary injuries. Like we have to maintain the temperature, sodium, plasma osmolarity, carbon dioxide, oxygen levels, fluid and pressures, and then hemoglobin, and then finally sugars. All these things have to be maintained, as this will also improve the outcome of the patient. And central to this should be done regularly at regular intervals. So these are the bedside surrogates which you have to chart, like pupils, heart rate, mean blood pressure, oxygen, carbon dioxide, and lately we are also doing optic nerve sheath diameter. On the right hand side, I have put a color coded map, which is nothing but a heat map, also called dashboard sign or a traffic signal sign. Here, if you plot these vitals, and you will come to know if your patient is in the red zone or yellow zone or green zone. Green zone means there is no danger. Patient can be monitored as per normal management strategies. But if your patient is switching between yellow to red, you need to escalate your quality of care, or you have to call your senior. So these are heat maps which are warning signs actually of a deteriorating patient. Now, head of bed elevation is very, very mandatory, because you have to raise it by 30 degrees and maintain it in neutral position. Tracheostomy tube or endotracheal tubes should not be tied very, very tight, and they should be loose around the neck. These maneuvers will ensure the patency of jugular vein and hence cerebral venous drainage, thereby decreasing ICP. If you do a steep position, you run the risk of decreasing the cerebral perfusion. Any noxious stimulus like suctioning should be avoided if you have to do without any sedation. So once you do suction, you must ensure that you give some small dose of lignocaine. Mechanical ventilation is associated, and you have to start with normocapnia if the patient's ICP is normal, or if the patient is showing very high ICP, then you can go, again you have to do the same normocapnia with a low tidal volume. So as per ABG, you have to change your ventilatory settings. You have to avoid hypercarbia, remove extra dead space, ensure sedation, and ensure synchrony. If there are any large effusions, pleural effusions or ascites, you have to get them drained. And if there are some features suggestive of ALI or ARDS, then you have to go to lung protective strategies. So for the osmotic therapy, mannitol is a good measure to reduce ICP. It creates a temporary osmotic gradient, and it can be given as 0.25 to 1 gram per kg over 15 to 20 minutes. Regular use may lead to intravascular dehydration, hypotension, prerenal azotemia, and hyperkalemia. Also, you should be very sure of your CT head findings when you start with mannitol. Coming to hemodynamic support, for hemodynamic support, we must target CPP and MAP as I've already described, and you can even use vasopressors to maintain your blood pressure. So, dopamine causes cerebral vasodilatation and increased ICP and can be used initially by peripheral line. Phenylephrine is being tested, but in TBI patient it was associated with tachycardia. In a recent study, the patients received phenylephrine had higher MAP and CPP, and then those who received dopamine and norepinephrine. Having said that, we are using norepinephrine, and we like to maintain our systolic blood pressures as dictated by the guidelines. That is more than 100 mm Hg for patients 50 to 69 years of age, more than 110 for patients with 50 to 49 years of age or over 70 years of age. So ICP more than 22 should be treated. CPP, as I said, should be 60 to 70. Seizure prophylaxis is indicated when GCS is less than 10, cortical contusion, depressed skull fracture, subdural hematoma or epidural hematoma or intracerebral hematoma, penetrating TBI, or there was a witness seizure within 24 hours of injury. We are normally using phenytoin because phenytoin is cheaper, easily available, but levopril has got a good pharmacokinetic and dynamic profile. Coagulation should be addressed very aggressively, because if there is a coagulopathy, which is called acute traumatic coagulopathy, and there is a derangement of platelets, then or coagulation, then patient can again have a secondary injury, patient can rebleed. So we target platelets at more than 1 lakh, fibrinogen more than 1 gram per deciliter, and we also like to do point of care testing using TEG or sonoclot. Supportive modulation, like temperature, should be treated. So try to keep your patient below 38 degrees centigrade and more than 36.5. So moderate hypothermia is used as a measure for refractory uncontrolled ICP, but literature is limited. And anti-ulcer prophylaxis should be started with H2 blockers, PPI and sucral fat. Invasive monitoring, if at all we are doing, the best to do is intraventricular ICP monitoring, which requires expertise and a specialized equipment. However, this is the gold standard. So indications are GCS less than 8 after reversal of sedatives that were being used, patient with risk of raised ICP under GA, or posturing or closed head injury. Jugular venous oxygen saturation is another means of knowing your regional cerebral oxygen, and the bulb and the catheter is placed at jugular bulb, which is classically at the level of mastoid, and it reflects the ratio between cerebral blood flow and cerebral metabolic rate of oxygen. Normal is 55 to 71, and sustained venous desaturation of less than 50 is the threshold for cerebral ischemia and treatment. EEG we do not do routinely, but it can help in monitoring the depth of coma and detecting non-convulsive seizure activities in pharmacologically paralyzed patients, and also during diagnosis of brain death. These patients are also at risk of deep vein thrombosis, so the low molecular weight or unfractionated heparin with mechanical prophylaxis should be started. This should be in consultation with the neurosurgeon. Normally 48 to 72 hours after injury, if there is no contraindication, is beneficial. Nutritional support should be started early. You should try to maintain the sugar levels very closely and a tight control between keeping sugars between 120 to 180 is recommended. So enteral feeding scores over parenteral nutrition, and if you are finding feeding intolerance, then metoclopramide and erythromycin may be given. Patients should be given an early tracheostomy, given that they are going to have some ICU stay. Tracheostomy helps in better pulmonary hygiene, and it also helps in weaning. So also it reduces the risks of self-extubation and then morbidity. CRASH 3 trial has given us the benefit of tranexamic acid if given early. So if the patient arrives to the trauma bay and you can administer tranexamic within 3 hours, it will have some benefit, but beyond that there is no benefit of giving tranexamic acid. So this is a management algorithm which was released in 2019 by Seattle International Severe Traumatic Brain Injury, and it's a consensus statement. This group has told us to divide the patients for the management as tier 0. Tier 0 in where you admit the patient to ICU and you do endotracheal intubation and mechanical ventilation, and as we have discussed, serial evaluations of neurological status and pupillary reactivity, head of bed elevation, analgesia, sedation and temperature management. You may also insert a central line and do enteral carbon dioxide monitoring. Consider anti-seizure medications, maintain CPP initially to more than 60. Maintain a hemoglobin more than 7 grams and avoid hyponatremia. Optimize venous return by keeping the head neutral. Arterial line for continuous blood pressure monitoring is indicated, and keep saturations more than 94 degrees. When you talk about tier 2, in tier 2, the indication is to use mild hypocapnia. Normally, we are keeping our carbon dioxide within the range of 35 to 40. But in the mild hypocapnia range, the range is between 30 to 35. In some patients, as a measure to lower ICP, neuromuscular paralysis may also be given. And in tier 3, if your patient is having refractory ICP, then you can consider the use of thiopentone or decompression. So this slide is very important, that if you are monitoring your patient and you see neuro worsening, like there is a decrease in spontaneous decrease in GCS, motor score more than 1 point, there is a new decrease in pupillary reactivity or pupillary asymmetry with bilateral mydriasis, or there is a new focal motor deficit, or there is a herniation syndrome or Cushing's triad. This requires an immediate physician response. So what you need to do is you have to immediately increase your FiO2, and then you have to do temporizing measures, like you have to hyperventilate. This is one indication where hyperventilation is indicated for a very small brief period. You can bring down the PaCO2 to 25 to 30 and then give mannitol or give propofol or thiopentone, and then call the neurosurgeon and wheel the patient out for CT scan. If the CT scan is indicating an urgent decompressive craniopathy, then the patient goes to OT. Otherwise, patient comes back and is sedated and ventilated. So this is very urgent and very important. If we miss this identification of critical neuro worsening, which you can also do in the absence of ICP monitor, then patient may have a morbidity or mortality. What is not recommended is mannitol by non-bolus continuous intra-infusion or scheduled infusion of hyperosmolar therapy, a lumbar drainage, furosemide, regular use of steroids, routine use of therapeutic hypothermia to temperatures below than 35, high dose of propofol to attempt burst suppression, decreasing PaCO2 to less than 30, routinely raising CPP above 90, and barbiturates as treatment of low brain tissue oxygen unless barbiturates are otherwise indicated, and then hypercarbia in patients who are having brain hypoxia. So with this, I end my lecture. I thank you all, and I'm ready to take any questions from the audience.
Thank you, Kajal Jain, ma'am. Ma'am, as such, there are no question in the chat box at present.
Thank you very much. And it's so nice to see Dr. Manimala, ma'am. Good morning, ma'am. And it's a warm weather for you, but we are sitting in cold weather. Thank you very much.
Dr. Manimala, ma'am, can you introduce the next speaker? Ma'am, please unmute yourself.
Welcome, Dr. Shashi Srivastav. She's professor at Sanjay Gandhi Institute at Lucknow, and her areas of interest are neuroanesthesia. Without further wasting my time, I request you to start your lecture.
Good morning to all. Today I'll be discussing about the anesthesia concern in posterior fossa tumors. There are three cranial fossas, anterior cranial fossa, middle cranial fossa, posterior cranial fossa. So now today we'll be concentrating on posterior cranial fossa. What are the boundaries of posterior cranial fossa? Anteriorly, it is clivus, petrous part of temporal bone. Posteriorly, squamous part of the occipital bone. Laterally, it is squamous and mastoid part of temporal bone. Superiorly, it is tentorial cerebelli, which is not seen in this cut. Inferiorly, it is foramen magnum and occipital bone. Next come why posterior fossa is so important. First of all, it is the largest and deepest of three cranial fossa. It contains all vital structures like cerebellum, which controls of balance and gait. Then midbrain, pons medulla, which constitute brainstem. And there are pathways for regulating consciousness and motor and sensory activities of the body. And it contains all vital autonomic centers like cardiovascular and respiratory centers. It also houses cranial nerve 3rd to 12th. Then large venous sinuses like sigmoid transfer and occipital sinus. So injury to these sinuses leads to profuse bleeding and air entrainment and air embolism. Then there is an important arterial system, which is vertebrobasilar system, supplies the posterior cranial fossa. It gets kinked during the extreme flexions of neck in various positions of posterior fossa surgery. It also contains narrow cerebral aqueduct, 4th ventricle. Pressure due to any space occupying lesion leads to obstructive hydrocephalus in these patients. So you have seen that there are so many structures in a compact space. So this has got poor compliance. Means if there is any space occupying lesion in this area, then there won't be any scope for compensation, and patient will all decompensate very soon with hydrocephalus and brain herniation. And one must remember that cranial nerve involvement is ipsilateral to the lesion and motor and sensory involvement is contralateral to the lesion. Now I come to one case scenario. There is a 19-year-old young male admitted with chief complaints of difficulty in walking, nasal regurgitation of fluids, headache and vomiting. So what all these complaints indicate towards they indicate towards some infratentorial lesion or lesion in posterior fossa. Difficulty in walking indicates to a motor and sensory problem. Nasal regurgitation of fluid indicates towards the lower cranial nerve involvement. And headache and vomiting indicates towards the increased intracranial pressure. So in sign and symptom, you should try to elicit features of raised ICP and hydrocephalus, that is headache, nausea, vomiting, drowsiness, and blood vision. Then you should look for the cerebellar signs also, dysdiadochokinesia, nystagmus, ataxia, and dysarthria. Then, as you see, there is in this patient in involvement, there is a problem with is a nasal regurgitation. So there is involvement of cranial nerve 9th and 10th. There is motor weakness and sensory involvement also. You should look for the features of brainstem compression, other cranial nerve dysfunction, like in CP angle tumor, generally 7th and 8th nerve is affected. Seizures are rare in infratentorial lesion, and if at all they are there, seizures are there, then it is because of electrolyte problems. Children, they present with listlessness, headache, vomiting, and malnutrition due to poor feeding. So how to diagnose these cases radiologically? CT scan is useful for emergency conditions like trauma and in acute hydrocephalus. MRI is the gold standard, which avoids the bony artifacts of CT scan. It also differentiates between intraaxial and extraaxial lesions. Intraaxial lesions are lesions which arise from brain parenchyma, and extraaxial lesions, they arise from meninges, skull. In MRI, you can clearly visualize the surrounding anatomical structures. This is the sagittal section of a posterior fossa lesion. This is the cerebellar tumor, and this is brainstem glioma, which is pushing the cerebellum backwards. So you can see clearly there is demarcation between this tumor and surrounding structures. This is a pineal gland tumor, though this is not exactly posterior fossa tumor, but surgeons, they approach to this tumor through superior cerebellar and infratentorial approach. So it has got all the concerns of posterior fossa surgery. Now, what are the various posterior fossa pathologies? They are congenital, like can be ulnar churning malformation, vascular like AVMs, aneurysms, neoplasms like intraaxial, ependymoma, medulloblastoma, astrocytoma, extraaxial, schwannoma, meningioma, choroid plexus papilloma. Then there can be hematoma and infarction. This is a diagram which is showing the various posterior fossa tumors in adult and children. 70% of the all childhood brain tumors, they lie in posterior fossa, and only 15 to 20% of the adult brain tumors are found in posterior fossa. Now, what are the different surgical approaches? They are midline suboccipital craniotomy. It is generally done in prone and sitting position. Paramedian suboccipital craniotomy, retromastoid suboccipital craniotomy, that is done in park bench position. Now, what are the challenges when you are doing a posterior fossa conducting a posterior fossa surgery? Then, as I told you earlier, there are so many vital structures in a confined space, so there is very less scope for compensation. So it leads to hydrocephalus and sometimes to brainstem herniation. Then we use different positions. They are odd positions, so you have to take care of that. Then there sometimes these patients present with hydrocephalus, and during the surgery there can be venous air embolism, there can be pneumocephalus, and so that's why these patients are protracted post-operative course. Now, how to evaluate these patients pre-anesthetically? Then history of clinical examination. History you have to take in detail. And the examination, you have to check for the airway, neck movements. Sometime during the atlantoaxial dislocation, the movements are restricted. So if you find this, then you have to be prepared for the difficult intubation. Then you should look for the previous surgeries like shunt placement, which increases the chances of pneumocephalus because there is drainage from the drainage of CSF and entrainment of air. Sometimes these patients are put on steroids, diuretics. If patient is on diuretics, there can be chances of dyselectrolemia. Then there is a patient's cardiorespiratory status. You should rule out for patent foramen ovale if they are planning for the sitting position. Then there is lower cranial nerve involvement also, like impaired cough and gag reflex. So you should be prepared for post-operative ventilation in these cases because this impaired lower cranial nerves leads to regurgitation, impaired coughing. So you have to keep these patients on. You have to take consent for post-operative ventilation in these patients. Then you should look for other comorbidities. And then you should look for the tumor size and vascularity. So you should be prepared for the blood loss. You should always discuss with the surgeon about the position of patients intraoperatively. Now, what are the goals of anesthesia in these patients? Is to maintain cerebral perfusion, pressure, and stable hemodynamics. There should not be any hypertension and hypotension. And whenever you are making any position, it should be proper. You should take care of all the parts of the body when positioning such patients. Then you should prevent early detection, and if there is venous embolism, you should promptly treat it. You should, if surgeon wants to do electrophysiological monitoring, then you should monitor your anesthesia accordingly. Then you should plan for the early and smooth emergence of these patients. Pre-medication, you should avoid sedatives in these patients, which leads to impairment of the you cannot assess the neurological status, and sedation leads to respiratory depression also. That will lead to hypercapnia, increased cerebral blood flow, and further increase in the intracranial pressure. Mild anxiolytics may be given if patient is not drowsy. Anti-sialogogues should be given because in prone position, there are chances of dislodgement of the endotracheal tube due to secretions. Then how to induce these patients? You should check for the consent of patient, availability of the blood products. Then you should put a venous line after giving local anesthesia. Then you should attach all the non-invasive monitors, which I think you all know about it, ECG and IBB. Then you should go for the smooth induction and intubation. It means that there should not be any hemodynamic changes during induction and intubation, because these are the intubation is a noxious stimulus. The patient might have hypertension, tachycardia, so you have to prevent it. That will further deteriorate the patient's intracranial dynamics. So you can use fentanyl, propofol, and muscle relaxant for induction. Then endotracheal tube, we generally use flaxometallic because they do neck flexion. So there are chances of endotracheal tube kinking. So we use flaxometallic tubes in these patients. Then you should check for the air entry in flex position, because in flex position there are chances of endobronchial intubation. So you should always flex the neck and check for the bilateral air entry. Because once a tube is fixed and position has been done, then there is very limited access. So we cannot do anything after that. Monitoring, routine monitoring, ECG, SpO2 and IBP, and end-tidal carbon dioxide, temperature monitoring, catheter is being put, measure the urine output. We use invasive arterial line and CVP line in these cases. Invasive arterial line gives you beat-to-beat monitoring of blood pressure, and for the we can do sampling for the arterial blood gases. CVP, because these surgeries are long-lasting, we give lot of fluids, and sometimes in sitting position, if there is air embolism, then we can aspirate air also. Spatial monitoring is done precordial Doppler, transesophageal echocardiography if they are planning for the sitting position. Then intraoperative neuromonitoring in the form of motor evoked potential, somatosensory evoked potential, brainstem auditory evoked potential. Then we can do electromyography also. Generally, seventh nerve is monitored in the CP angle tumors. Transcranial Doppler can be used to detect any arterial emboli in the cerebral circulation. We can use, then this also should be used as per guidelines nowadays to monitor the anesthesia depth. This is a picture showing the transesophageal echocardiography. This is the one way to this is being used in sitting position, as well as while putting the CVP line, you can see the tip of the CVP catheter, which should be 2 millimeter below the RA SVC junction. So you can see a white dot in this. How to maintain anesthesia in the patient? Balanced anesthesia should be a choice with inhalational agent, opioids, and muscle relaxants. Then TIVA should be used to facilitate neuromonitoring. TIVA, we can use propofol or dexmedetomidine. We are using generally propofol because we are doing a lot of neuromonitoring in posterior fossa surgery and other spine surgeries also. So what our intraoperative consideration should be maintenance of cerebral perfusion pressure, prevent and manage venous air embolism. We should preserve cardiovascular responses in these patients. If this surgeon is operating around brainstem, there can be hemodynamic changes in the form of hypertension, bradycardia, tachycardia. So you should never try to jump to treat these changes. Because otherwise you will not come to know about it, and you should in fact you should immediately inform surgeon to remove the stimulus. So you should avoid using beta blockers, anticholinergics. Fluids and glucose management. We use isotonic normal saline for the intraoperative fluid management, and balance out solutions also, because it is generally they are long hour surgeries. So lot of, if you are using only isotonic normal saline, then there are high chances of hyperchloremia and hypernatremia. So to avoid that, we intermittently use balanced salt solutions along with the isotonic normal saline. Then we should avoid dextrose containing fluids as it increases the chances of cerebral edema and causes hyperglycemia. Hyperglycemia is also concerned during the perioperative steroid administration. These patients are put on perioperative steroids, which can also lead to hyperglycemia. Blood sugar should be maintained between 140 to 180 milligrams per liter. Then we should monitor hypoglycemia in children. Urine output should be 0.5 to 1 ml per hour. Core temperature should be maintained 36 degrees centigrade. Previously, it was thought that hypothermia will decrease the cerebral metabolism and prevent the cerebral ischemia. But nowadays, it is recommended that you should use more than 36 degrees. Osmotherapy, its role is not well defined in posterior fossa surgeries. Mannitol can be given if there is brain bulging, 0.25 to 1 gram per kg. And if we are using sitting position, it may, giving osmotherapy may aggravate hypovolemia, electrolyte imbalances, and it may increase the size of pneumocephalus during the closure of dura. Because osmotherapy will do the brain volume shrinkage. Now, what are the intraoperative complications during posterior fossa surgery? There can be hemodynamic disturbances due to the change in position, when we do a changing position initially after induction, then you should always give top-up doses of anesthetic agents, opioids, because it can lead to hypertension, tachycardia, and increase the intracranial pressure further. And due to the manipulation of brainstem intraoperatively, there can be arrhythmias, hypertension. And oscillous cranial nerve stimulation, 5th and 10th, also leads to hemodynamic changes. Then there can be endotracheal tube kinking in the prone position. And when the neck is flexed, there can be accidental dislodgement of tube, disconnection from the circuit. Then, as I told you, there are large venous sinuses, so there can be heavy blood loss also if there is inadvertent injury to these sinuses. There can be venous air embolism also. Positions use a supine and with head rotated, prone position, lateral decubitus, park bench or semi-prone, sitting position. Supine with head rotation is used in CP angles tumors, but it is used rarely. Head is turned completely on one side, and due to excessive flexion and rotation, sometimes there is venous compression and increase in the ICP. So you should avoid excessive head flexion and rotation. It can lead to brachial plexus injury also. That's why you should put a pillow or any support below the contralateral shoulder. Prone position is used for midline posterior fossa tumors, craniovertebral junction lesions. Advantage is lower incidence of venous air embolism, and it is good to pediatric patients also. Disadvantages are kinking and dislodgement of endotracheal tube. That's why you should always fix it nicely before turning the patient prone. You should give anti-sialogox. There can be excessive bleeding that due to the abdominal compression. Then head should be slightly raised at the time of positioning. Then there can be peripheral nerve injuries. So they should adequately pad the shoulder, pelvis, knees and arms. Then there is, if there is any cardiac arrest in such position, then it is difficult to resuscitate these patients. Though prone resuscitation is there, but still there is difficulty in resuscitate these patients in prone position. Then another dreaded complication in these patients is postoperative visual loss. There should not be any pressure over the eyes and avoid hypotension also. Sometimes they put these in prone position, they are putting these patients on horseshoe. So if there is any pressure on the eyes, then there are chances of central retinal artery thrombosis and loss of vision. Park bench position is also known as semi-prone position. Is good for CP angle tumors. Better surgical exposure, cerebellum falls away from surgical field. Drainage of blood and CSF is there. So surgeon gets a clear field. Peripheral nerve injury can be prevented by adequate padding of the pressure points. There are chances of ventilation, perfusion mismatch, and dependent lung. This is a picture showing the park bench position. Patient is like prone, half prone. There's a dependent arm is supported sometimes there is supports on the table itself, or you can put a sling here also. This is the head, this is Mayfield, and this shoulder is taped. There is a axillary roll below the shoulder to prevent the brachial plexus injury. Pillow should be placed between two legs. Now what sitting position? Indications are posterior third and fourth ventricular tumors, pineal tumors, brainstem lesions, upper cervical spine lesions. Contraindications are absolute contraindication and relative. Absolute are ventricular atrial shunt and large patent foramen oval. Relative contraindications are extremes of age, COPD patient, hemodynamic instability, degenerative disease of the spine because you cannot flex the neck, anesthesia and surgical team not familiar with the position, severe autonomic neuropathy. This is a sitting position and OT setting in a patient who is undergoing surgery sitting position. So this is the final position, sitting position. Sorry, in the previous slide, I forgot to mention that the arterial transducer should be leveled at the level of tragus to check for the accurate cerebral perfusion pressure. This is the final sitting position. Here you see there is flexion at the hip, flexion at the knee, and there is pad between the below the knee and hip to prevent the sciatic nerve injury and common peroneal nerve injury. There is a support here also, and this is the head holders, and this is the bar which is fixed to the upper end of the table. This will actually, if there is intraoperative, if you want to straighten the table, if the bar was fixed here, then it was difficult to turn the patient in the straight position. So bar is always put on the upper edge of the table. While positioning patient in the sitting port, then you should always put the pneumatic calf pumps to prevent the pooling of the blood in the legs and prevent hypotension also. And to prevent hypotension, you should always preload these patients so that there is no hypotension when you are turning patients in the upright position. And as I mentioned earlier, during the skull pin insertion, there should be proper analgesia. Otherwise, it will lead to hypertension and tachycardia and increase in the intracranial pressure. Then patient position should be slow. We should ensure 2-finger breath space between the chin and sternum to prevent cervical cord stretching and increase in the airway pressure. Support the arms to avoid the brachial plexus stretching. Padding of buttocks, ankles, and legs should be done. Arterial line transducer at the level of external auditory meters to reflect the accurate CPP that I showed in the diagram earlier. What are the advantages and disadvantages of sitting position? In advantages are a drainage of CSF and blood. So the surgeon gets a clear clean surgical field. Better access to the midline structures, improved access to the tumor, less requirement of transfusion as there is field is comparatively bloodless. Better neurological functions because there is less damage to the surrounding structures, improved ventilation in sitting position. Then disadvantages are there. There can be hypotension, venous air embolism, tension pneumocephalus, macroclosia, quadriplegia, neurological deficits. Other less known complications are there. Venous air embolism incidence is 12 to 80%, 12% in horizontal position, 80% in sitting position. Because there is negative pressure at the operative site, and so there is development of the atmospheric pressure in an open vein when they are drilling the bone, when they are opening dura. And these veins are non-collapsible, valveless, and large venous vascular tumors and meningiomas, injury to the venous sinuses can lead to air entrainment and air embolism, chances of air embolism. Severity of the air embolism depends on how much volume is entrained, rate of air entrained, and presence of patent foramen ovale. These are the monitors to be used in sitting position specifically. I'll not go in details, but transesophageal echocardiography is the most sensitive invasive monitor, and precordial Doppler is most sensitive non-invasive monitor. So whichever is available at your center, you should use it. Then most commonly used and widely available is capnography, which is non-invasive sensitive monitoring. End-tidal nitrogen is specific for the air. So I'll talk about little bit about the end-tidal carbon dioxide, which is available in all the centers and should be used in sitting position. And in fact, we are using in all the neurosurgical cases, because all the cases, they are put in head up position. So there are chances in other cases also of air embolism. So if you find there is sudden sustained drop of end tidal carbon dioxide of more than 2 to 5 millimeter mercury, and in the absence of, if you have not changed minute ventilation of this patient, and then you find fall of EtCO2 of 2 to 5 millimeter mercury, then there should be alert of that embolism has occurred. And simultaneously, if you get the arterial PaCO2, you will find it high. Because the air embolism, it travels from right atrium to right ventricle, then to the pulmonary bed, and he creates a blockage there. So there will be fall of end-tidal carbon dioxide, and there will be increase in the PaCO2. Symptomatic dose for the hemodynamic changes is 50 ml, around 50 ml. So how venous air embolism manifests? Cardiovascular changes can be there, dysrhythmias, hypertension. And if there is large air embolism and rapid entrainment of air, then there can be acute right ventricular failure and cardiac arrest. And post-operatively, these patients present with myocardial ischemia and right ventricular failure. Pulmonary changes are hypercarbia, hypoxemia, pulmonary hypertension, pulmonary edema. And there can be perfusion defects in post-operative period. Central nervous system, there can be brain swelling. And then post-operative, these patients may present with neurological deficits. There is one term, paradoxical air embolism, which means there is passage of air into the systemic circulation via right to left intracardiac shunts or intrapulmonary transmission. So I told you, generally the air passes from right atrium to right ventricle, then to the pulmonary bed. But if there is any shunt between the right and left side of heart, then there will be direct entry from right to left side. This air will enter. So that will cause the paradoxical air embolism. Incidence of patent foramen ovale is high in general population. So it should be checked preoperatively if surgeon is planning for the sitting position. Flow across the patent foramen ovale is functional, which depends on the pressure gradient between the left atrium and right atrium. Normally, left atrial pressure is more than right atrial pressure, but it may reverse during the normal part of respiratory cycle after release of PEEP, during any episode of VAE, and in hypovolemia. So that will lead to the paradoxical air embolism. What is the treatment of venous air embolism? Prevention is important. Careful dissection should be done by surgeon. Use of bone wax continuously. Avoid hypovolemia in these patients. So you should keep the CVP on the higher side. Early detection by close monitoring. Then if VAE has occurred, then how to treat it? We should inform the surgeon immediately. Stop nitrous oxide in use. Ask the surgeon to flood field with normal saline. Jugular venous compression sometimes helps in preventing the entry of air into the internal jugular vein. But it can sometimes lead to increased intracranial pressure due to venous engorgement. Then you have CVP catheter, so you can aspirate air through that also. You should, if there are hemodynamic changes, then you should support that. If there is hypotension, start inotropes. And if needed, you should change the position of the patient and resuscitate. Post-operatively, you should prevent hypoxemia. ECG should be done to detect any myocardial ischemia. X-ray should be done. Then we should treat if any cardiovascular problems are there. Then if there cerebral arterial emboli are detected, then you should use the hyperbaric oxygen, which will dissolve these emboli. Then nitrous oxide role of nitrous oxide in posterior fossa tumors is still controversial. Nitrous oxide is itself in neurosurgical cases its use is controversial. We have stopped using nitrous oxide because now we have better anesthetic agents with us. But it can be safely used in sitting position till the end of we should stop it before the dura closure. It has been found that in sitting position also it can be used till end, but we avoid it. Actually, at our center we are not using nitrous oxide. One has to be watchful of the venous air embolism if you are using nitrous oxide, and switch it off as soon as you find that venous air embolism has occurred. Emergence in the patients. Extubation criteria is it depends on preoperative consciousness of the patient, state of lower cranial nerves, intraoperative course of the patient, brainstem handling is there or not, what is the hemodynamic stability of these patients, then temperature of the patient, because I discuss later on. Goals of extubation are smooth emergence and extubation. There should not be any hypertension, tachycardia during extubation, no straining and coughing of the tube. So use beta blockers if you find hypertension and tachycardia. When not to extubate these patients, if the patient are difficult airway, then you should keep the patients on ventilator for sometimes post-operatively and let them come out of sedation, and unless they they become responsive, should not extubate. Then preoperative perilesional edema, if there, then you should not extubate. Abnormal preoperative mental state of the patient. If patient was drowsy in the preoperative period, then you should not extubate such patients. If there are profound intraoperative vital sign changes due to the brainstem handling, then also because there are chances of brainstem edema in postoperative period, so you should not extubate. Surgical time is prolonged. There is airway edema, tongue edema, because we are using prone position, sitting position. So there are chances of macroglossia. So you should not extubate. If preoperatively gag is impaired, means there is involvement of 9th and 10th nerve, you should not extubate. In fact, you should take consent for the postoperative ventilation in the preoperative checkup itself. Then if there is temperature is less than 34 degree hypothermia, then you should not extubate. These patients not responding means there is residual anesthetic agents, there are metabolic disturbances. So you should get a ABG done and check for the electrolytes and acid base. Then operative site hematoma also leads to poor not responding to the stimuli. Then there can be tension pneumocephalus in these patients. Brainstem injury is there. Cerebral infarction also sometimes happen if there is major artery injury. Then these patients will not respond, and you have to keep these patients on postoperative ventilation and get the CT scan in the postoperative period and check for the cause. Then what are the postoperative other complications? Are pneumocephalus, hematoma, postoperative nausea, vomiting, pain, hydrocephalus. PONV is high incidence in posterior fossa tumors because there is lot of we use inhalational agents, and there are vomiting centers also in this area. So there are high chances of postoperative nausea, vomiting. Pain is also severe in posterior fossa surgeries as compared to the other areas because there is lot of muscle cutting. Then sometimes these patients develop hydrocephalus also due to the postoperative edema and hematoma formation. There can occur respiratory disorders due to the intraoperative injury to the vital centers, swallowing disorders, cardiovascular problems. Cranial nerve palsies also can be found in these patients. Peripheral neuropathies due to because we are using odd positions, so there can be injury to the peripheral nerves. Another important complication is tension pneumocephalus, which everybody should know about it. If you find this patient is drowsy, not responding to commands, or there is headache, postoperatively, confusion, agitation, and sometimes seizures also, then you should get the CT scan, urgent CT scan done. So sometimes this is air which is denting the both cerebral hemispheres, and this ridges like a mountain. So this is known as the Mount Fuji sign in the typical of tension pneumocephalus. So if you find on CT scan this, then you should treat the patients with high flow oxygen, and sometimes you need to do bar hole and aspiration of air. How to manage pain and post-operative pain in these patients? Pain is quite high due to a lot of muscle cutting. So you should treat with the scalp blocks, multimodal analgesia, NSIDs, opioids also sometimes you need to give. Scalp block can be given preoperatively, pin insertion also. Postoperative nausea vomiting is very common. In posterior fossa surgeries of long duration, treatment is prophylactic, ondansetron and dexamethasone. Postoperative mortality in these patients is due to aspiration pneumonia, due to the lower cranial nerve palsies, hematomas, edema and herniation, vascular compromise leading to infarction, cerebral infarction, and sometimes due to tumor recurrence. To conclude, it's a challenging job performing a posterior fossa surgery and giving anesthesia to these patients. We should follow the basic principles of neuroanesthesia. Positioning should be careful and safe, taking care of all the parts of the body. We should be vigilant in the intraoperative period to prevent complications, and if they occur, prompt treatment. Thank you.
Thank you, ma'am, for a wonderful presentation. Ma'am, as such, at present, there are no questions in the chat box.
Seems to be like that. Okay.
Mhm.
Go ahead with the next one.
Can you conclude the session?
It's over?
Yeah, ma'am.
I thought there was one more. Well, I think it was a good presentation from all of them about the posterior fossa tumors, the traumatic brain injury, and all this. Only if there are no questions at all for the first speaker for the vomiting at when you have a trauma in the triad, sometimes can we not switch over to ramosetron? It has got, compared to ondansetron, less side effects. Any one of them can answer.
Ma'am, Dr. Shipra has logged out after a session, as there was no question at that time.
Anyway, anybody can answer if the other two are there. Now that it is longer acting, and of course, maybe it is a little more expensive, but it is longer acting and it has got less effects on the cardiac system. So do you think why we are still having to use ondansetron? Is there anything definite about it?
Yeah, it can be used, man. It is safer, though it is expensive, but now I think everybody can afford it.
Yeah, that's what I'm saying, but it is still not in practice in anesthesia. Why? I have used it long time back.
Okay. Even we are not using it.
I think you all have to promote it, right?
Yes, definitely.
But you are still using the sitting position and you are having such a grand, so many monitors. I remember at All India Institute, we used to have no monitor. Monitor was only our blood pressure apparatus and our hand on the pulse. So that used to be monitored in sitting position. It used to be a great
Ah.
difficulty in those days. Okay.
Yeah, I know,
But
ma'am.
now we have so many.
But now, yeah, every center has got all these
Yeah.
all India Institute also they are using very
Yeah, I know.
frequently.
Now
classes.
everybody has because
Yeah,
I have
know.
used it later
But
in Nizam.
overall, use of sitting position has declined because
Decline.
now they have better positions like
Positions,
pro
pro
sometimes
and
they do in pro
semi-pro.
position because after it has got its own morbidity sitting position.
Yeah.
So its use has been declined. We are also not using very frequently this. We have used in the past, but not nowadays.
Yeah, that is
So
true.
that's the thing.
I'm
That's
just telling about
yeah.
those days.
And ma'am, there's another question. I wanted to clarify one thing. Are we using ketamine for induction? In
And-
TBI, Dr. Madam was saying we can use ketamine. Kajal Jain, Dr. Kajal Jain.
She must also have knocked out.
Because
if there is a
this
lot
new
of
concept.
hypotension, I think we can use it in a smaller dose because we don't have to go to 1 milligram per kg, but you can reduce it if there is a, hypotension, the patient is having. But otherwise, you can use the, your propofol and a little bit.
But nowadays, role of ketamine is again emerging.
Increase.
So increased, yeah.
Because it is also is very useful
Previously,
for, even seizures, even
yes.
I have published some this thing on seizures. When there are intractable seizures, you use ketamine. So there is nothing wrong in choosing some of them in a nice way, like you said, fluids, because they keep on saying don't use normal saline. We can always mix and match. You can use normal saline, you can use plasma like in a combination, even ringer lactate. There is no problem. So it is not just normal saline or plasma. This is how we all use it. But when the control studies come, it will be only this or that. So they don't say the other one. Okay, Nidhi, I think we have crossed the time. And it's nice to see all of you after a long time.
Yeah, ma'am. Good to see you after a long time. And we met in Tirupati and
yeah, because now I don't very much come to anesthesia. I'm more into the critical care, and I've also become older to travel. So I think I've done a lot of.
Yeah,
Thank
it was
you all.
my privilege.
Bless you all.
It was my privilege that you chaired
and it
this
is
session.
Nice to see all the participants and this thing all are women. It has become, anesthesia has become, I think, women's specialty, like gynecology. Very few men around. Huh?
Thank you.
Okay. See you all.
Thank you. Thank you, everyone.
Thank you, ma'am, for chairing the sessions. And it was
Nidhi.
nice having you with us.
Thank you, Nidhi. Thank you.
Thank you, Alka, ma'am.
Thank you.
Thank you.
Just a minute. Yes.
Now we have our next showcase presentation of a 3-month-old child with hydrocephalus and meningomyelocele for surgery. And we have with us Dr. Tanvi Samra as the moderator. Ma'am is Associate Professor at Department of Anesthesiology and Intensive Care, PGI MER, Chandigarh. Her areas of interest are trauma and acute care, geriatric anesthesia, biomedical innovation, and automation and artificial intelligence. We have Dr. Hariharan who is a senior resident in Department of Anesthesia and Intensive Care, ABVIMS and Dr. RML Hospital. And our presenter is Dr. Shivam Jaswal, who is a third-year postgraduate student at ABVIMS and Dr. RML Hospital. Welcome, Tanveer, ma'am.
Thank you so much. And I thank you all for this wonderful meet which you have organized. I hope it will be very, very useful for all the residents. So I think without delay, I would ask Shivam to start with the case presentation, and then we can carry on with the discussion.
Morning, everyone. Good morning, ma'am.
Good morning. So now Dr. Shivam is going to present his case presentation, which is a very, very important short case, which most of us get. So over to you, Dr. Shivam.
Yes, ma'am. Good morning, ma'am. Good morning, everyone. I am presenting a case of 3-month-old female child who is a resident of the Bihar, has been brought by parents with chief complaint of swelling over the lower back region since birth, increased head size since birth, vomiting after breastfed since 2 days. After birth, mother noticed a midline swelling over the lower back region. Since birth, the swelling was initially small in size, approximately the size of the lemon, progressively increases to the present size of the orange. Born with size head, which progressively increased to the present size. History of vomiting after breastfeeding since 2 days, which was non-villous, non-projectile in nature. History of excessive crying present. No history of fever or rash over the body. No history of the bluish discoloration of the skin. No history of recurrent respiratory tract infection or regurgitation of the feed. No history of abnormal body movements. No history of decreased leg movement. No history of tripling of urine and fecal incontinence. Antenatal history. A 32-year-old was unbooked primigravida, married to her cousin, conceived spontaneously, confirmed by urine pregnancy test. No history of iron and folic acid intake during antenatal period. No history of drug abuse or radiation exposure. Then birth history. A 2.5 kg female child was born by emergency cesarean section at 37 completed weeks under regional anesthesia in view of non-progression of the labor. The child cried immediately after birth. Neonatal history. No history of poor feeding. No history of hospitalization. Developmental milestone. Delayed milestone according to age. Social smile absent. Head lag is present. Summary. 3-month-old female child with history of swelling on lower back region with increased head size and history of vomiting since 2 days with delayed developmental milestone.
So this is the short case which has been presented by Shivam, only the history. So as most of you might have noticed is that in this Shivam has not gone into a very detailed history. Whatever he has included is just based on the presenting features, right? You can continue, Shivam. Then we will discuss the history later.
Yes, ma'am. Okay, ma'am. General physical examination. After getting consent from the parents, examination was done. The child was sitting on the lap of the mother's. Irritable, high-pitched cry, downward movement of the eyes present. No pallor, no icterus, no cyanosis. Head circumference is 50 centimeter. Length is 52 centimeter. Weight is 4.9 kg. Vital parameters. Pulse rate 140 beats per minute. Measured in right radial artery. Regular rhythm. Normal volume. No radial or radiofemoral delay. All peripheral pulses are palpable. Blood pressure 80 by 40 millimeter of the mercury in right arm in sitting position. Respiratory rate 31 beats per minute. Thoraco-abdominal type. Temperature 98 Fahrenheit measured in right axilla. SpO2 preductal and postductal saturation is 98%. Central nervous system examination. The child had an irritable, high-pitched cry, was moving all 4 limbs and opening eye spontaneously, had uniformly enlarged, thin, shiny scalp, distended scalp when is seen. Anterior fontanelle open, rhomboid, bulging and pulsatile. Posterior fontanelle close, eyeball displaced downward. Tone and deep tender reflex are normal in bilateral lower limbs. Respiratory system, trachea appears to be in midline. Chest movement appears bilaterally symmetrical on both sides. Bilateral air entry present. Normal vesicular breath sound. No added sound present. Cardiovascular system examination, S1 and S2 present. No murmur heard. Capillary filling time is less than 3 seconds. Abdomen short, no organomegaly. Local examination. A midline swelling at the level of L4 and L5, 4 into 4 centimeter, spherical in shape, smooth surface. Hair tuft present over swelling, cold on touch, cystic in nature, not fixed to underlying bony structure. Transfiltration test is positive. Airway examination, nose both nares patent, chin no obvious recession seen, mouth opening appears adequate, and peripheral venous access visible in the dorsum of hand.
So after the case presentation, what generally you are asked is about what is the tentative or provisional diagnosis you make from the history and the examination.
Ma'am, my provisional diagnosis is congenital hydrocephalus with meningomyelocele.
Now, I think instead of saying specifically that it is congenital, yes, you can be right, because the history says that the mother has been noticing it from birth. But it is much more safer if you just say that you are expecting a child with hydrocephalus and a meningomyelocele.
Yes,
instead of saying that it is congenital hydrocephalus, right? So we will use simple terms like hydrocephalus with meningomyelocele. So what are the points in the history which are justifying this statement?
Ma'am, increased head size.
Yes.
Ma'am, distended scalp veins.
Yes.
Ma'am, thin shiny scalp. And ma'am, enlarged head size in comparison to facial growth, ma'am. And
yes.
Ma'am, in the lower back region, swelling is present, ma'am, in the midline, which can be suggestive of the ma'am hydrocephalus and meningomyelocele, ma'am.
So, and you can also say that the patient has got hydrocephalus with signs of increased intracranial pressure.
Yes, ma'am.
Right. So you can say a child has got hydrocephalus with increased intracranial pressure and a meningomyelocele. So what are the things noted by you in the history which justify that the child had increased intracranial pressure?
Ma'am, child is maybe ma'am altered sensorium, ma'am history of vomiting, and history of ma'am irritability, and ma'am lethargy sometimes can be noticed, ma'am.
Yes, and the vomiting which your child has was projectile in nature, right?
Yes,
now,
yes,
do you expect any complications of meningomyelocele which you had asked in the history and which the patient has or does not have?
Ma'am, there is chances of the rupture, ma'am. If there is rupture, there may chances of the infection and chances of the meningitis may be seen.
Okay, and anything regarding the deep tendon reflexes, which you had already said that the patient is moving the limbs, there is no urinary incontinence.
Yes, ma'am. Ma'am, by history, there is no involvement of the bowel and bladder, ma'am, and fecal, no history of the fecal incontinence, ma'am, and because of the ma'am, blood supply are intact, ma'am, and no involvement of this.
Okay. Now you had also asked a cardiovascular history. You had also asked other associated histories. So why did you take this history?
Ma'am, because ma'am, these patients are more chances of the congenital anomaly, like ma'am ESD and PSD. So we can go for the ma'am. Ma'am, we take history for the sciences also, ma'am. There is a presence or not. So we can rule out the congenital anomaly associated with this or not.
Okay, so what you told me is basically a disease which is classified broadly as a myelodysplasia, right?
Yes, ma'am. Yes, ma'am.
So can you just enumerate some types of myelodysplasias which you are aware of?
Ma'am, myelodysplasia is included four types, ma'am. This may be spina bifida occulta, spina bifida cystica, anencephaly, and encephalocele, ma'am.
Okay, so your patient comes in spina bifida
cystica, ma'am,
right, where you are having meningomyelocele, right? Okay.
Yes, ma'am.
And
yes,
I will just ask you to tell me about what is the embryological defect. Just tell in 1 or 2 lines what is the embryological defect.
In this, neural tube formation is not properly due to failure of the closure in the 28 days of the intrauterine periods, ma'am. So this can lead to the formation of the.
Okay. So why did you take maternal history, antenatal history? Is there any predisposing factors in the antenatal history?
Yeah.
Which, okay.
Yes, ma'am. Yes, ma'am. Patient is not visited any antenatal history and no history of the take of the ma'am folic acid.
Okay. You can also include intake, ask specifically for intake of any teratogenic drugs,
Yes,
like
ma'am.
you have the anti-epileptics.
Ma'am, most commonly associated with ma'am anti-epileptic like sodium valproate and carbamazepines, ma'am.
Yes.
This and ma'am also seen in some patient of the hypervitaminosis and some viral infections like influenza viruses, ma'am. And sometimes it is associated with the trisomy of chromosome number 13 and 18, ma'am, low socioeconomic status and
Okay. So why your history was just telling you that there is a swelling at the lower back level, right?
Yes, ma'am. Yes,
so
ma'am.
why did you label it as a meningomyelocele? Because you just know there is a swelling.
Because in this yes, ma'am.
Yes, yes. Go on. Why did you think it was a meningomyelocele?
Ma'am, because so it may can be meningomyelocele, ma'am.
Can you hear me,
Hello.
Shivam?
Ma'am, because of the herniation of the meninges and the neural tissue is also seen, ma'am.
Yeah, so you can answer it that because out of all the myelodysplasias, this is the commonest, right?
Yes, ma'am. Yes,
So
ma'am.
whenever we are in medicine, we always think about common things first, right? So you know that the incidence of meningomyelocele is 80% and a single incidence of a meningocele is only 20%, right? So that was one reason you could have said.
Yes, ma'am.
Then you have done the various tests, which we will be discussing, the physical examination, and which was supportive of the fact that your patient has a meningomyelocele, right? So then we were talking about the various associated anomalies.
Yes, ma'am.
I had asked you during the history taking also. So
Yes,
one
ma'am.
you said was that there could be heart diseases, right?
Yes, ma'am.
And just to add on a little bit, that although because they are congenital syndromes, they could be associated heart defects, but as compared to other diseases, the congenital heart diseases are rare in a meningomyelocele, right?
Yes, ma'am.
So it is not very common to find congenital heart disease, but they have other things, like they will be having a club foot, right? It's very common to find club foot in these patients. And then generally 80 to 90% of them have a Arnold-Chiari malformation.
Yes,
so
ma'am.
can you tell me a few lines about the Arnold-Chiari malformation?
Ma'am, there is a tonsillar herniation below the foramen of the magnum. Ma'am, it is type 1. In the type 2, ma'am, caudal herniation of the brain stem and cerebral vermis, ma'am. And most commonly associated with the hydrocephalus with meningomyelocele is type 2 Arnold-Chiari, ma'am. And type 3, ma'am, occipital involvement is also seen with add of the type 2, ma'am.
Yes, you have very rightly said that it's generally the Arnold-Chiari malformation 2, which we find in this subset. Now, there are some other syndromes also which people talk about when we discuss about the case. So can you tell me what is the full form of the Vactral? We always talk about the Vactral anomaly.
Yes, ma'am. Ma'am, vertebral anomaly.
Okay.
Ma'am, anorectal malformation, ma'am. Ma'am, congenital heart, ma'am, cardiac involvement. C, ma'am, tracheoesophageal fistula, ma'am. Ma'am, renal abnormality, and ma'am, limb abnormality, ma'am.
Yes. So this was all that we are discussing about the history taking, the predisposing factors, right? And
Yes,
the
ma'am.
various associated syndromes which might be seen in this group of patients. Now then, in your case, was there any paraparesis? Was there any muscle wasting?
No, ma'am.
Okay, that is very important, right? So
Yes,
if you have, then you can summarize in the end saying that, okay, with bowel bladder involvement, okay, with cranial nerve
Yes, ma'am.
dysfunction, with tonic
Yes, ma'am.
spasms. So you should always ask about the neurological complications or the neurological clinical features which might be associated with this syndrome. Like we talked of paraparesis, any sensory symptoms, neurogenic bladder, neurogenic bowel, any convulsions, any tonic spasms which the patient might, actually the patient is a child, so it's generally the primary caregiver who's going to give you these history, right?
Yes, ma'am.
And any cranial nerve. So as you had already told me that there are certain complications also. You had
Yes,
told
ma'am.
me about a rupture. And
Yes, ma'am.
it is very important to know that a ruptured meningomyelocele is generally taken up as an emergency procedure, right?
Yes, ma'am. Yes, ma'am.
Because it causes a lot of CSF leak. Your patient had signs of raised intracranial pressures, but your patient did not have any infection. On examination, you have told that the temperature was normal.
Yes, ma'am.
And sensorium, what was the sensorium of the child?
Ma'am, moving all 4 limbs. Ma'am,
The cry.
cry. Ma'am, cry is.
Okay.
Ma'am.
Okay. So it means there was no signs of infection in your patient, right? Okay. So what do
Yes,
you
ma'am.
think will be, now your patient has got 2 different things. Your patient has got a hydrocephalus and
Yes,
your
ma'am.
patient has got a meningomyelocele.
Meningomyelocele.
So what is the management of such patients? Will you first get the hydrocephalus operated, or are you going to first get the meningomyelocele operated?
First we pop, ma'am. Hello.
Yes.
Ma'am, hydrocephalus first to be operated, ma'am.
What is the reason for that?
If we
Why do you think
first ma'am, if first we repair the meningomyelocele, and then if increase ICP, then chances of the rupture of the meningomyelocele again. So we can prefer, ma'am, first we put the ventricular peritoneal stent, after then we can go for the meningomyelocele repair.
Okay, so the only case which I told was that only when you have an isolated meningomyelocele,
yes, ma'am,
then it is operated first, and only you will find patients being operated for a simple meningomyelocele on the first or second day of life. Such patients are generally operated. If there is no hydrocephalus, then you will see the children being operated on the first day or the second day of life, because we don't want to take a chance of the rupture of the sac. And we know if rupture occurs, then infection occurs, right? And
yes,
any
ma'am.
surgery which is done within 24 hours of an open defect, it minimizes any bacterial contaminations, right?
Yes, ma'am.
Is there any role of any fetal surgery if you just have a simple meningomyelocele? So is there any role of fetal surgery?
Ma'am, in vitro we go for repair of the meningomyelocele. In the intrauterine we can put the BP shunt.
Yes, you're absolutely right that it improves the motor function. Actually, it's advantageous, but it's done in very advanced centers, right? So I will first like you to just tell me the anesthetic management of surgical repair of a meningomyelocele, right?
Yes, ma'am.
So you just tell me that if a patient comes for a meningomyelocele, so how, what all you will ask in the pre-anesthetic evaluation, and what will be your anesthetic concerns when you're doing a PSC?
Ma'am, first we go for the detailed clinical examination, and latex-free gloves should be used for the examination of the meningomyelocele. And pre-operative advice, ma'am, we NPO status, ma'am, to our for the clear fluids and for our the breast milk, and written and informed consent explained to her parents, and avoid sedatives medication. If baby is excessive crying is present, then we can go for oral midazolam and oral midazolam, ma'am.
So are you going to ask for any investigations?
Yes, ma'am. We can go for complete blood count, ma'am. CBC, allowed, ma'am, any infection and any elevated in the total leukocyte count, ma'am. We can go for liver function test, because we can go for renal function test, ma'am, and chest X-ray, ma'am.
Yeah, actually chest x-ray should only be ordered if it is required. If you think
Yes,
that
ma'am.
there is, if you think that there is any, symptom suggestive of a chest infection. Otherwise, in children, we generally avoid chest x-rays. You are absolutely correct. We should go for a hemogram. And if required, it depends upon your center, how good they are in blood grouping and cross matching. Otherwise, some people get blood grouping and cross matching before done it. All other
Yes.
investigations may or may not be done, like a liver function is not required, right?
Yes, ma'am.
You may only go for electrolyte or a TLC if you find there is infection, if there is meningitis, right? Any drug treatment the child is on, you want to see in the treatment chart during the PSC? What drugs will you be looking for in the treatment charts of the patient when you go for a PSC?
Ma'am, we can go for the phenytoin
Yes,
for
the
prophylactic
child,
use of.
maybe the child is on any anticonvulsants. So you should sometimes
Yes, ma'am.
specifically ask the parents also. They are not educated enough to give us complete answers. So you can give some leading questions and ask them whether the child is on any anticonvulsant. You can ask them whether the child is on any steroids. You can ask them whether the child is on any diuretics, right? So these drugs
Yes,
you
yes,
must
ma'am.
look. How will you assess the volume status of the child?
Ma'am, we can do a test for the capillary refilling time or capillary filling time.
What
Ma'am,
is that? How do you do it?
Ma'am, we put a pressure on the sternum for the 5 seconds. Then is a planching is occur, and we look for 5 seconds, ma'am. And after releasing, then how much time to take the refill this one, ma'am?
Normally, what it is?
Ma'am, normally is there's a 3 second, ma'am.
Okay. So do you want to use the sternum, or some people use the lower limb also?
Yes, ma'am. Some people use the sternum, and some other people use the heel of the children's, and some people use the fingertips also.
Yeah. And I just wanted to correct you. Some people, like your child has got hydrocephalus also, and your child has a meningomyelocele, right? So some people, when there is associated hydrocephalus and some amount of neurological compromise they are expecting, they might not like to give any pre-medication. And
Yes,
for
ma'am.
a child, your child is just 3 months old, if I'm not wrong, right? So for a 3 months
Yes,
old child, generally, you just pick him up in the lap and get the child in the OT. So probably I would suggest that, we would not require any pre-medication for this age group, right? 3 months old child, generally the children who are older than 1 year, they are the ones which are, difficult to handle. They have the anxiety with them. So for 3 months, there is no pre-medication required. So what monitors are you going to plan for the patient?
Ma'am, we can use precordial stethoscope, pulse oximeter, temperature monitoring, and it is CO2 monitoring, and ECG monitoring.
Okay, so
Blood pressure monitoring.
yes, and now I come to your case. Like your child had a hydrocephalus and a meningomyelocele. So do you think that your intubation is going to be a challenge?
Yes, ma'am.
Why do you think the intubation is going to be difficult?
Ma'am, because of the large size of the head, and when the pediatric care is also difficult here, ma'am. Hello.
So what are the factors which make even if the child did not have a large head, even if the child did not have a meningomyelocele, so what are the factors that are going to make your intubation difficult in pediatrics?
Ma'am, epiglottis is omega sib and floppy, ma'am, and larynx, ma'am, capillate placed होता है C3 and C4 position पे, ma'am, and subcutaneous fat is more, ma'am, and
yeah, and in spite of these anatomical differences, you should talk about the FRC in children. You should talk about their tendency to desaturate, very rapidly. You should talk about the inspiratory collapse which is there, because they do not
Yeah.
have the protection in the posterior part of the tracheal rings. They're not developed, right?
Yes,
So
ma'am.
you should talk about the anatomical differences which make them more prone to difficulty, and you should talk about the physiological factors which make them more difficulty. And definitely in your child, because the head is very large and there is a meningomyelocele, we are expecting more difficulties. So what are you going to plan? What maneuvers are you going to do so that you don't face difficulty in intubation?
Yes, ma'am.
How are you going to intubate your child then?
Ma'am, first, ma'am, proper positioning of the patient, ma'am. Baby head at the edge of the table, ma'am. Put a shoulder roll on the ma'am shoulder, and
You want to put something below the meningomyelocele?
yes, ma'am. We put a ma'am adequate size of the bolster, ma'am. Adequate size, ma'am, donuts, ma'am. So we can prevent the rupture from this, ma'am. And ma'am, we can prefer the ma'am Miller blood.
Yes, and can you have you seen people intubating in the lateral position?
Yes, ma'am. Sometime.
Yes. So generally, when the defects are very, very large, then we place the child in the lateral position, and you have an
Yes.
assistant. Yeah, you have an assistant, and the assistant is going to help to keep the head in the midline, and then intubation can be done. So because sometimes, the defect is so big, the meningomyelocele is so big that you can't even get donuts for it, right? So we know that, but when we are asking the assistant to make the head in the midline, we should be very careful that excessive rotation, excessive flexion should not be done, because then we can cause brainstem compression.
Yes.
We can cause a raise in
Yes,
ICP, right? So that is also very, very important.
Yes, ma'am.
Yeah. So what maintenance fluid? Now, fluid is also very important in pediatrics. So what maintenance fluid are you going to use in your group?
Ma'am, normal saline, ma'am.
Okay, so you do you want to use ringalactate or do you want to use normal saline? Because generally we in pediatrics, we know there's a lot of talk about the hyperchloremic acidosis. There's a lot of talk about use of a physiologically balanced solution. So would you prefer ringalactate or would you prefer normal saline?
Ma'am, both we can prefer, but ma'am, mostly we can use ma'am normal saline.
Yeah, there is differences in various institutes. I have seen that some people are very rigid. They want to use only balanced solutions, which we have is ringalactate. But if your children are adequately monitored and you are having a very good watch on the amount of fluid which you are giving, you can use normal saline. But you must always know that you have to look for hypoglycemia, which may be present in these children. So sugar levels you have to see. And if required, you might have to give 5% dextrose also. And you must have a look whether that your excessive amount of normal saline should not be causing hyperchloremic acidosis, right? Or hypernatremia in this group, right?
Yes, ma'am. Yes, ma'am.
And we do not expect a lot of blood loss in these group of patients, right? It is only if the lesion is very extensive, it's very, very big, then there is going to be blood loss. But definitely third space loss is there, right? Because they're going to open up the entire defect. So you have to replace for the third space also. Now your child has got hydrocephalus also with signs of increased intracranial pressure. So what are the points you will keep in mind for maintenance of anesthesia?
Ma'am, maintain ma'am cerebral perfusion pressure, ma'am, in the range of 45 to ma'am 55, ma'am, and avoid ma'am hypoxia, hypercarbia.
Yes.
Extreme flexion and extreme neck rotation should be avoided, ma'am.
Yes, and always make it a habit that whenever you're doing, the pediatric case, always keep an eye on the peak pressures also. Sometimes what happens is the tube gets kinked, the tube gets blocked. So excessive airway pressures are also very dangerous for the brain. So you should always have this habit of
Yes.
looking into it. Now, the most important thing which we always keep on telling you in pediatrics is that to keep the patient warm. So what should be the temperature of the operating room in such cases?
Ma'am, 26 to 28 degrees centigrade.
Yes, yes, we should always be very careful. And some surgeons, they're not comfortable with this temperature. So you should always have bear huggers and other means of warming up your child if your pediatric surgeon is probably keeping a lower temperature. Yes.
Yes,
And what
ma'am.
yes, yes, Shivam, you want to say something?
No, ma'am.
Okay, so you had talked about the uh, latex allergy. Do you want to say something about it, how relevant it is? And
Ma'am, because meningomalocele patient and hydrocephalus patient is more chances to get hospitalized. So,
yes,
ma'am, there is a chances of the latex allergy in this patient.
yes. And how does it manifest? How would you get to know that your child has got latex allergy?
Ma'am, sign up the ma'am. Patient may go ma'am bradycardia, ma'am, hypotension.
Yes. So
Ma'am,
the wheezing is always wheezing and
wheezing.
hypotension. Wheezing and hypotension are the two important, vital signs which we note whenever our patient is going to go into latex allergy. Post-operative care, anything you want to say about the post-operative care in this group of patients? Now your patient, you have reversed and you have shifted the patient in the post-operative recovery. So what all would you like?
Ma'am, always nursing in the prone position, ma'am.
Why do you want to do that?
Ma'am, chances of the rupture is more, ma'am. So we can prefer nursing the prone
Because
position,
they have
ma'am.
put
Adequate anesthesia
sutures.
should.
Yes, they have put sutures, and that's why we do not want any stain on those sutures. So you should always have the child in the prone or the lateral position. So anything else you want to say about the post-operative care? One is positioning, the other is?
Ma'am, adequate analgesia care, ma'am. Paracetamol, ma'am.
How do you give paracetamol? What is the protocol in your place?
Ma'am, we can give paracetamol before 15 minutes, ma'am. At the dose of 15 to 20 mg per kg, and we can give antiemetics, ma'am, like ondansetron before 30 minutes, ma'am. 0.1 mg per kg.
How are you giving? What are the various routes of giving paracetamol? There are different routes of giving.
Ma'am, paracetamol can be given, ma'am, oral, IV, and ma'am, transpositive, ma'am, can also be given.
Yeah, we can give it per rectal also. There was a time when lots of people were actually, talking about per rectal, and there were a lot of studies being done on per rectal, but now we have very good IV preparations also. So we are going in for the IV preparations, right?
Yes, ma'am.
So I just wanted to just a few questions, MCQ types, that what is the sunset sign? Did your child have a sunset sign?
Ma'am, it is due to the pressure on the midbrain of the tectum. So there is a downward displacement of the eyeball.
Did your child have a sunset sign positive?
Yes,
or was it?
Yes, ma'am.
Okay. What is the crackpot sign?
Ma'am, when we examine the frontotemporal, there is a sound is produced, crackling sound will produce in the percussion, ma'am.
Okay, so what does it indicate if it is positive?
Ma'am, it may be, ma'am, increase, ma'am, ventricular size, ma'am.
Very good. It is seen in children who have hydrocephalus, right? So what type of hydrocephalus was there in your child? Was it communicating or was it a non-communicating?
Ma'am, non-communicating.
Okay, so you want to say that it was because of the obstruction to flow. Yes, all neural tube defects, all cherry 2 malformations, they are basically because of the obstruction to the flow, right? Now, have you heard about of a transcranial sonography?
Yes, ma'am. Ma'am,
So if transcranial sonography is a good option of, if the fontanelle is open, right? But because your child, the anterior fontanelle in your child was closed or open?
I'm open, ma'am.
open, right? So some people would like to carry out a study and probably, do a transcranial sonography, right? And for elder children, we generally do a CT scan. Now, what is the dose of dexamethasone generally these children are on?
Ma'am, 0.1 mg per kg, ma'am.
Okay. What is the dose of mannitol?
Ma'am, mannitol can be given in the 0.25 to 1 maximum 1 gram per kg, ma'am. So
Yes.
to reduce.
Yes. And what is the
ICT,
dose
ma'am.
of Lasix which these people are generally on?
Ma'am, Lasix can be used, ma'am, 0.1 mg per kg.
Yes, it can be 0.1, it could be 0.5, it could go as high as 1 mg per kg. So
Yes,
it is
ma'am.
very important that when you see the drugs, then you should also be very careful about the doses which they are, right? And anything which you would like to give before intubation to avoid any rise in ICP?
Yeah, ma'am, we can use, ma'am, fentanyl. Ma'am, we can use
What is the
fentanyl,
dose
and we
of
can use, ma'am,
fentanyl we use?
ma'am, 2 mics per kg, ma'am.
Yes, if you are actually controlling the response to intubation, then you don't have to give this high dose of 2. Even a dose of 1 mic per kg will be good enough to prevent the
Yes, ma'am.
ICP with intubation. Any other drug which you can use to prevent the intubation response and the rise in ICP with?
Ma'am, we can use, ma'am, Xylocard, ma'am.
Very good. And what is the dose of
Ma'am,
Xylocard?
Ma'am, 0.5 to 1 mg per kg, ma'am.
Yes, you can use this, and generally it has to be given 45 seconds to 1 minute before, 1.5 minutes some people give before, so that the adequate control is there. So I would just like to congratulate Shiva. You have done your case presentation very well, and you have been able to answer most of the questions, and I don't think there are any more questions left.
Thank
So
you, ma'am.
over to you, Dr. Nidhi. So is there anything else? I don't see anything in the chat box, but anybody else would want to ask something?
Thank you, Tanveer ma'am, for such a wonderful case discussion. Ma'am, as such, there are no questions in the chat. No questions in the chat box, and you have covered every question. Thank you, ma'am.
Okay, I thank you again, Dr. Shivam, and best of luck to you, and best of luck to all the people who are listening to this postgraduate exam. And the only thing I would say is, whenever somebody asks something, don't panic. That is the take-home message, because you all know everything. Okay, so just keep practicing with your seniors, with your colleagues, of answering whatever questions are related to any case. So again, once again, I thank you, Adamal, also for giving me this opportunity. Thank you so much.
Thank you, Tanveer ma'am.
Thank you, ma'am.
Thank you, Shivam.
Thank you, ma'am.
Can we have the MCQ session now? Now we will have the first MCQ session. First question is, most sensitive invasive monitoring for venous air embolism is capnography, transesophageal echocardiography, precordial Doppler, or pulmonary artery catheter. The second question is concerning preoperative management of enhanced recovery after surgery patients, which is true. A, all patients should be nil by mouth from midnight to reduce the risk of aspiration. B, patients should receive 1 liter of intravenous fluid before induction to replace the deficit of bowel. C, mechanical bowel preparation decreases the fecal load in the bowel, thereby decreasing the risk of wound infection. And D, a preoperative carbohydrate drink can reduce thirst, hunger, and post-operative insulin resistance. Now we'll have a short tea break and we'll reassume the session at 10:25. So just go and have tea and freshen up. Then we have our next session lined up. Welcome back, everyone. Now, we have Dr. Pragati Ganju with us for chairing the next session. Welcome, ma'am.
Hello, Nidhi. And a big hello to Prashant, whom I'm going to introduce just now. He's a colleague of mine.
Doctor,
Hello.
ma'am.
So you can talk. You
Ma'am.
can. Yeah.
Yes, ma'am. Ma'am is a director, professor, and head of Department of Anesthesiology and Intensive Care, and head of Neuroanesthesia Unit. Her institute of affiliation is GB Pant Institute of Postgraduate Medicine, Education and Research, Maulana Azad Medical College, New Delhi. And ma'am's areas of interest are neuroanesthesia and neurocritical care. Welcome, ma'am.
Thank you so much, Nidhi, and the team. So I have a pleasure of introducing Dr. Prashant. He's an old colleague, an old friend of mine. He's a professor in the Department of Anesthesiology.
Namaskar, madam. Thank you so much.
Namaskar, yeah. Department of Anesthesiology and Critical Care at the Pandit BDS PGIMS at University of Health Sciences in Rohtak. And he's a neuroanesthetist and a neurocritical care physician, and has proficiency in airway management and medical education, research in COVID-19 and simulation and skill training. And he's a simulation facilitator of the level 2. And surprisingly and very pleasantly surprisingly, he's a master in business administration too. And he has a Commonwealth Fellowship in Neuroanesthesia and Neurocritical Care from Belfast, from the Royal Victoria Hospital in UK. And also he's done his PDF in Neuroanesthesia from CMC Vellore and FICCM. So welcome, Prashant, and it will be great to hear you talk on intracranial anesthetic management of intracranial aneurysm. And as we all know, and we as neuroanesthetists understand, that this is a devastating condition in all its forms, whether it just bleeds and the patient deteriorates, or the patient requires surgery of any kind, which is a high risk surgery. So I'm sure you're going to tell us the salient features and the important points to the postgraduates. Welcome, Prashant.
Namaskar. Good morning, friends. Welcome to this very important session on anesthesia for intracranial aneurysm surgery. I am Dr. Prashant Kumar, and I bring greetings from University of Health Sciences, Rohtak. I have no conflict of interest and no financial disclosure to be disclosed. The objectives kept for this session are to describe current anesthetic management goals for unruptured intracranial aneurysm. We'll also touch about ruptured or large giant intracranial aneurysm, and we'll also look at the current neuromonitoring modalities available with us. Plus, we'll also look at management options for optimization during the aneurysm clipping, as well as in case we find intraoperative aneurysm rupture. So what is aneurysm? Aneurysm is any abnormal or weak spot on a blood vessel that triggers ballooning of outward bulging of the arterial wall. So if we look at the circle of Willis, where we have a circle being formed in the cranium, and that circle has the vessels, and any of these vessels can become ballooned out, and which can be causing a weakening in the wall. Now, if we look at the epidemiology and burden, so I'll talk about only India, where we have some incidents around 6 to 16 per lakh of population, and that amounts to around 75 to 2 lakh new cases in India each year. Now, what happens, why this is symptomatic sometimes, is bulge aneurysm exerts pressure on a nerve or a surrounding tissue in the brain. And in rare cases, it might get ruptured, where we get ruptured aneurysm causing the subarachnoid hemorrhage. Generally, it is at the base of the brain, and it can be a secular aneurysm or it can be a fusiform aneurysm. Another type is lateral aneurysm. Now, it is more common with advanced age. So, age more than 50 years, females are more commonly affected. Patients with hypertension, cigarette smoking, old history of SAH, they are at more risk. Plus, if the aneurysm size are more, or we call it giant aneurysm, then these patients are at more risk. Further, aneurysm location is also important, and the posterior aneurysms are more expected to get ruptured than an anterior aneurysm. Now, anesthetic challenges, they come to these patients as these patients can come as symptomatic patients or they can come as asymptomatic patients. While if the symptomatic patients are coming, we have already talked about it, it is symptomatic because bulb aneurysm causes a pressure on the nerve or surrounding tissues. Now, anesthetic challenges can further be divided in case we get a ruptured or SAH patient, we get unruptured patient, or we can have challenges during intraoperative rupture to these patients. Further, these patients have to be looked for because we might get these patients as intubated patients. They might be intubated because of subarachnoid hemorrhage. They've got intubated in emergency when they reported. These patients might have intracerebral vasospasm because of the blood coming into the subarachnoid space and then it irritates. There is a good mechanism which you can read. Plus, we need to look for to grade the challenges as what is the grade of subarachnoid hemorrhage, and these patients very frequently has abnormal or myocardial dysfunction due to subarachnoid hemorrhage. Now, if the patient already has a hemorrhage, we need to look for some grading, and the most common grading which is used is Hunt and Hess classification, where these are grades from 1 to grade 5. And while grade 1 is asymptomatic or minimally symptomatic patient, to grade 5 is patient with deep coma. In between, grade 2 is patient coming to moderate to severe headache, some rigidity. Grade 3 patients are drowsy, confusion, and grade 4 patients have stupor or severe hemiparesis. And any serious systemic illness such as hypertension or diabetes that pushes the patient to one grade higher. Another scale which is used for and the time of admission is on the basis of CT scan. While on grade 1, there is no blood visualized in CT scan, and grade 4 has diffuse or intracerebral intraventricular clots. In between, their grade 2 has diffuse deposition, while grade 3 has localized clots or vertical layers of blood of 1 mm. Now, one very popularly used class scale for these patients' outcome is World Federation of Neurosurgeons, or that is called WFNS, subarachnoid hemorrhage scale, and it also ranges from 1 to 5, and it correlates with Glasgow Coma scale and motor deficit. So if the patient has 15 GCS, does not have a motor deficit, it is grade 1, while if has GCS of 14 to or 13 and with motor deficit, it becomes grade 3. Similarly, poor GCS with does not matter whether we have a motor deficit or not. Now, general formula for anesthetic management of unruptured aneurysm is to avoid rupture of aneurysm due to any stimulus, and any stimulus comes from intubation, Mayfield field head fixation, or craniotomy. Now, we need to maintain adequate cerebral perfusion pressure, and we also need to have control of MAP and ICP to get a good CPP. So my concerns in these patients are specific and they are pre-anesthetic. And these pre-anesthetic concerns start from pre-induction behaviors, and that include OT preparedness. OT has to be prepared before you wheel in the patient. OT should be calm. We have to have little lesser light. So I do not say we have a dark OT, but dim lights only at the places you want lights to be there so that the patient doesn't get photophobia, because bright light can stimulate these patients. Then behavior is like we need to keep little calm in theater. Do not make the routine noises what are there while you are wheeling in the patient. Theater should be very calm. No one speaks unnecessarily. And obviously, do consider the pre-medication. Pre-medication considerations can be anything depending on patient condition and your institutional practice. In my institutional practice, I give good amount of sedation to the patients unless they are very drowsy and I have a suspicion of respiratory depression, which may lead to CO2 retention. So I may use lorazepam, or you can use your midazolam as well, right? But these patients should be given a good amount of sedation unless you are worried about CO2 retention due to respiratory depression. So theater should be silent, no bright light should be there, and we need to keep calm in theater. 4 principles which guide anesthetic management are to minimize any change in the aneurysm gradient, transmural gradient, maintain adequate cerebral perfusion pressure, which we talked, and have adequate brain relaxation, and also to look for fast and smooth emergence, which is very important. To do that, what we generally do is have a arterial catheter pre-induction. So use local anesthetic, very peacefully secure an IV line, intra-arterial line, pre-induction patient. Always have large bore IV access. Standard anesthesia involves opioid and propofol, and also volatile anesthetic agents, which you might need to keep less if you have neuromonitoring facilities available in your theater. And we can also plan for burst suppression. Burst suppression decrease the impending ischemic burden on the brain from temporary occlusion of the large cerebral vessels, which surgeons do to allow relaxed clip to be put at the knee. So another thing about the temporary clipping, it is used to soften the neck and make it amenable for clipping. It minimizes risk of rupture, which are there intraoperatively. Another things which can be used for this purpose is adenosine, which can be used in bolus of 0.3 to 0.4 mg per kg. It causes transient circulatory arrest. We'll talk about this in a little bit more because you might get it as a question. I have no personal experience with any of these methods of adenosine or deep hypothermic cardiac arrest or rapid ventricular pressing. Retrograde suction decompression also, my surgeons, they do not require it, they have not done it. So during temporary clipping or permanent clipping, generally neuromonitoring is used. We are using it, and it is motor evoked potentials are more frequent. And during that time, the brain is at greatest ischemic risk, and inadvertent rupture is also possible during dissection around the aneurysm. So keep a plan to contend these devastating complications. So availability of blood products, keep adenosine for rescue if it happens, large bore intravenous access, and we generally have central venous access to these patients. So this is also recommended. If we have ruptured aneurysm or large aneurysm, so again, the principle remains same, and we go with the pre-induction arterial catheter, central venous line, because there is higher risk of rupture, and we might need hyperdynamic therapy and give a meticulous attention to hemodynamic throughout, and you need to look for what is the maintained CPP for these patients. Now, this is the image we did last month. So there is a large MCA aneurysm, and it was exposed here very nicely and then clipped. Another picture for anterior communicating artery large aneurysm here. and this was also clipped successfully. Another very small anterior communicating artery aneurysm, and you can see the patient coming with subarachnoid hemorrhage. So intraoperative monitoring, it includes standard monitoring of your ECG, blood pressure, which you have done as arterial, so it would be invasive blood pressure. Then you need to monitor end-tidal carbon dioxide, SpO2. So apart from these standard monitoring, we also have some extra modalities for aneurysm, which can be burst suppression used with EEG or SSEPs. Plus, there can be transcranial motor evoked potential or subcortical one, and these pathways have different blood supplies, so it is important to monitor these two separately. And the area to be monitored is depending on the area of the aneurysm which might be involved, and the area involved would be dependent on the blood supply to the brain area by the vessel, which we are going to touch upon. So if we remember these images, which are for the sensory and motor cerebral cortex, so the general principle is giving here is that for anterior communicating, we generally monitor bilateral tibial nerve, middle cerebral, unilateral median nerve, depending on the side, and distal ACA is bilateral tibial nerve. So generally speaking, the median nerve and tibial nerve, they are the nerves which are monitored during SSEPC. Now, when we use neuromonitoring, there are multiple studies which have shown the benefit of detecting impending neurological injury, and in that case, immediate change of surgical plan can be made. And there are studies which have shown benefit of predicting post-operative neuroclinic dysfunction, which are otherwise permanent changes. The transcranial MEP is come up in last few years, and there are studies which supports its usefulness, and it may be very useful for subcortical ischemia, perforating arteries at risk, and it can be allowed the timely intervention. But sometimes with this MEP, the patient movement can be a problem, and we need to monitor the muscle relaxation, which we need to do continuously in these patients. Generally, it is not very done with the smaller kids, so children and as well as elderly, they are not having very good results with this. There are not very no absolute contraindication, and rest are relative, and we need to look for risk versus benefit. There are chances of having epilepsy or a cortical lesion, and there can be a skull defect which can cause difficulty. In case of cardiac disease also, there can be hemiblock or AV block. So these are the images which comes for the response. And how we practically you can use it as recordings are done at the regular intervals, and then recordings after blood burst suppression is also taken out, because then there are baseline changes, and during aneurysm exposure recordings are done more frequently because you are at the greatest risk at that time. Few words about adenosine flow arrest, and I have no experience. I have already said that. But theoretically speaking, adenosine it blocks AV node. It has a very rapid onset, rapid clearance, and metabolized by RBCs and endothelium. Half-life is only 10 seconds. So this can be used to transiently inhibit the bradycardia and asystole, and then it causes coronary and cerebral vasodilation. So there is a very good use of adenosine. Now, if you are talking about adenosine, you may be asked in exam about diagnostic and therapeutic uses of adenosine, which are to terminate SVT, okay, to use in conjunction with thallium for diagnosis of coronary obstruction. It can be used for controlled hypotension in very low dose, that is 100 to 200 microgram per kg per minute. And it can be given for transient cardiac arrest for thoracic aortic stent development or cardiac arrest for cerebral aneurysm clipping, which we talked about today. So adenosine has different roles. You might be asked for it if you're. Literature is good about saying the controlled hypotension during aneurysm or transient cardiac arrest during the aneurysm surgery with adenosine. Now, when we use adenosine, there are concerns. So there can be some minor effects of flushing, chest discomfort, arrhythmias, particularly SVT, and then event of rupture adenosine can be used to treat acute hemorrhaging on priority, and there has to be routine placement of external pacing pad. Another drug which might be required is indocyanine green, which can be used for video angiography, which allows confirmation of blood flow in parent, branching, or perforating vessels, as well as assessment of the remnant aneurysm after clip application. And this is simply used with the dose of 5 ml is given as an initial dose, and which can be repeated after 3 to 5 minutes, which is the washout timing. And under the microscope, the flow can be seen during aneurysm. So to make things easy for understanding the management of anesthesia for aneurysm surgery, pre-medication is up to 2 milligram of midazolam, depending on patient's mental status, or I sometimes even have used lorazepam for patients who are otherwise fine. So the patient comes very deep and calm to theater. Always tell about some potential post-operative intubation possibilities to those patients, apart from routine monitors, arterial catheter to be done pre-induction, Foley's catheter to be done post-induction so that the patient doesn't get stimulated, and you might be using frequent SSEP or ECG monitoring. Now, goals for anesthesia: to avoid any intraoperative rupture by preventing increase in blood pressure in response to stimulus, and stimulus are intubation, pins, positioning, and skin incision. And to maintain adequate cerebral perfusion pressure, at least 70 mmHg, to prevent cerebral ischemia from brain retraction, and temporary blood vessel occlusion and vasospasm, and provide brain relaxation. So these patients should be receiving antimicrobial agents preoperatively as per your institutional policy, but they should receive it because it's generally a long surgery. Steroid is also on the surgical unit's choice, but if you have steroid used in your surgical unit for these patients, please give it intraoperatively. 1 gram up to 1 gram per kg of mannitol should be given, but also please ask for the surgeon if they want it. Then induction is standard with fentanyl 2 mic per kg prior to induction, and using the propofol as an induction agent. Don't forget to tape the eyes. Eye protection is very important. It's good if you insert esophageal temperature probe. Have one additional large bore IV line with you. Generally, in my theater, what we do, we put one extra IV bore, extra large bore IV cannula, and attaches to the line, but we do not give fluid through that line, so that we have one additional line with these patients. Patient's position will depend on the aneurysm. Generally, they are supine with some tilt depending on the location of aneurysm. Maintenance of anesthesia is, if you are using intra-op monitoring, then it should be your IV maintenance with some propofol around 100 mic per kg per minute. We can use inhalational agent, we use it in, but the only thing is we generally keep 0.5 mac for these so that they do not disturb with SSAB monitorings. We always use fentanyl infusion. While in abroad, we were using remifentanil infusion, but we are still waiting for India to get the remifentanil for past many years. Maintain muscle relaxation throughout the procedure unless we are using motor evok potential, so where the muscle relaxation is not given. Then if the patient is taking dilantin, that's a very common thing for any neurosurgical patient to come with it. We might need to readjust the dose of neuromuscular blocker because these patients, they have first pass metabolism due to increased liver enzymes. Hyperventilation is not the exact word we want to use here, but it's a moderate hyperventilation where we want to have PCO2 between 30 to 35. That is the range we want to keep. Have intermittent blood gases, hematocrit, and glucose for assessment, and do maintain euvolemia. Now, check for the availability of blood in the OR. Record all clip application on and off times in cases we are using temporary clipping. For EEG burst suppression, if we do use additional propofol, and when required, increase the propofol infusion, plus give some additional dose, maybe around 5 ml, 50 milligram of the propofol. Then at high doses, propofol may delay awakening. So at the end of the surgery, you need to be careful about it if we have used very high dose of propofol. Fentanyl infusion is generally stopped when the start closing, while propofol infusion is kept running till around 10 to 15 minutes before the end of surgery. Now, inhalational is like we generally prefer to have inhalational running till the end of surgery. And in case you are using desflurane, which you can use, you have to continue it till the surgical tapes are done. Now, after aneurysm clipping, in presence of vasospasm, we need to have relative hypervolemia, but that word is very important here, relative. So we do not have hemodilution very much, and we need to have above normal blood pressure. Now, in cases where the aneurysms have ruptured and we need to maintain it, we go for systolic of around 160. And to do that, what you need is vasopressors. So we start vasopressors for these patients. Now, when you use vasopressors for these patients, the thing is you need to have increase in the blood pressure just after the aneurysm clipping. And to do that, when you start some kind of vasopressor after the clipping, it becomes difficult to get the effect in early phase. That is delayed. So our practice is that we keep ready the vasopressor and keep it attached to the central line, and so that once the clipping is done, we need to just start the infusion. Okay. Now, choice here is NORAD, or you can use phenylephrine. I generally say that these two things are used easily. Few people, they also use dopamine, but my choice is between NORAD and phenylephrine. In general, I use phenylephrine in theater and NORAD for ICU. But since we know these patients need to be maintained post-op, so we start NORAD in theater and the same infusion gets continued in ICU. Then we also need to have care about vasospasm, which might be due to retractor pressures, and it may be because of inadequate cerebral perfusion pressure. Perioperative rupture of aneurysm, if it is there, it's a very, very nightmare thing coming up for any anesthetist in theater. So we need to maintain adequate intravascular volume, maintain cerebral perfusion pressure, and surgeon might be using temporary clip at the minute. Now, recovery is important in these patients because we want these patients to wake up early and extubate so that we can have a good neurological examination in post-op. And also for post-op, and during transfer, continue hemodynamic monitor and supplemental oxygen during transport to ICU as well as in post-op. Now, some complications which may be there, we can forget them. One is hydrocephalus, which may be because of clots coming in ventricular system. There can be intracranial hypertension. There can be vasospasm, which starts on day 3 after subarachnoid hemorrhage and peaks at around day 7 to day 10, and it continues up to day 21. Then there are chances of rebleeding, which is around 8%, and it is highest in the first 72 hours of the rupture. Patient may present with seizure. There is cardiac dysfunction because of the catecholamine surge leading to subendocardial necrosis. There can be pulmonary dysfunction. There can be electrolyte disturbance, which is very important here in terms of it can be either cerebral salt wasting syndrome or it can be SIADH. And these two can be differentiated on the status of hypovolemia in cerebral salt wasting syndrome, and in SIADH, we have euvolemia or slight hypovolemia. Then there can be endocrine disturbances, which might come as hyperglycemia or hypothalamo-pituitary dysfunction. Now, triple S therapy, as conventionally read, was aimed to achieving hypervolemia, hypertension, and hemodilution, and it was used to increase cerebral blood flow following repair of the aneurysm. In traditional method for prophylaxis and treatment of cerebral vasospasm, there are trials which question the technique, and it can be risky, especially in patients who have cardiopulmonary compromise. So volume expansion decreases cerebral oxygenation and only mildly increases cerebral blood flow, because what we get is hemodilution. So hemodynamic augmentation focus has shifted away from traditional triple H therapy towards maintenance of normovolemia and induced hypertension, which we can maintain with continuous infusion of vasopressors. Now, one word about surgery and clipping. So in an international subarachnoid trial, ISAT, which included more than 2,000 patients at 42 centers, so there was a risk of death or dependency was 24% with coiling, while it was 31% with clipping, and incidence of late rebleed was 2 to 9% with coiling, while it was 0.9% with clipping, and 58 of coiled aneurysm were completely obliterated, were 81% had completely obliterated in clipping. So in cases, the surgical clipping has a better advantage in terms of the completeness and rebleed, but there are definitely extra advantages of having clipping in these patients. Thank you very much. Thanks for listening, and I wish you all the best for your exams. Thank you. Namaskar.
Thank you so much, Dr. Prashant, for keeping it simple. I'm just very tempted because you brought in coiling in the last slide. So I'm very tempted to tell you that, to tell the PGs, just a couple of minutes I'll take, because endovascular coiling is an increasingly popular method of tackling aneurysms, and the anesthetist has a very major role. In fact, in our OT, the neurosurgeons are doing it, and we are in the same day probably doing one clipping and a coiling following that. So for the PGs, so that you don't get stumped, anybody will ask you, not necessarily during the exam, but anywhere in your life, once you step out of hospital, they'll ask you, what about aneurysm clipping? So whatever Dr. Prashant has said is right, that you open the skull, you retract the brain, go deep inside, try to locate the aneurysm. If you have problems in locating, so you proximally clamp a vessel, which is called temporary clipping, so that you can dissect around the aneurysm. Then find the aneurysm, clip the neck, and that is permanent clipping, and get rid of the temporary clipping. But this, as you can understand, is an invasive procedure. So please, students, do remember there's another way of tackling, which is increasingly popular, known as endovascular coiling, something similar to a coronary procedure, which we do for the heart. Here we go through the femoral artery, we put in a catheter. Through that, we put in coils, which enter the aneurysm. They'll completely obliterate the sac. You put in many coils inside, so that there's no blood inside the sac left, and the sac will eventually shrivel, and the aneurysm will close. So the anesthetic considerations for clipping are far different from what you have in coiling. In coiling, there's a different approach altogether. You have to heparinize the patient and the end ensure that the patient is out of the heparin, because you don't want any bleeding in the post-op. And throughout the procedure also, you have to maintain temperature, because you are giving fluids, cold fluids through for irrigation, and the procedure is short. It starts fast, it ends fast. So you have to be vigilant when you start your anesthesia, and the major difference is what Dr. Prashant said, that in clipping, you can have a major bleeding right inside. In the field, you can see the blood is coming out and it's a panic situation, and everything is going haywire. There it is so quiet, through the vessel may just, the blood may leak out of the vessel, the catheter may go in different directions, the coils may come out of the catheter through the aneurysm, it may go to the surrounding brain, and you don't know the patient is bleeding. And the effect will only come in the post-op, but you have to see the monitor. There's always a monitor in the coiling, which the anesthetist has to watch. That's a completely different chapter, and I can understand why Dr. Prashant didn't bring it, because it's too big to be accommodated in this thing. But I would request you not to get foxed if somebody is saying, what is coiling? Please say it's an endovascular procedure for tackling aneurysm, which is increasingly getting popular now, and with expert hands. Now neurosurgeons are also doing it, like in our institute, but many a times it's the interventional radiologists who are doing it. But the anesthetist remains the same. Whether you're in this OT or you're in a neurocath lab, you are the same anesthetist. You just have to change your focus and manage the cases accordingly. So just to tell the PGs. Now the chat box has some interesting questions. I'll direct them to Dr. Prashant. One is that, what about the role of deliberate hypotension in these patients, Dr. Prashant? This is from Dr. Shwetanjali Bhardwaj.
Yeah, very nicely thought of this, Shweta. The thing is about hypotension. Now we are sitting at a double-edged sword. A patient with aneurysm, if it has come after bleed, or even if it has not come after bleed, most of these patients are hypertensive, and you always have a risk of having a ischemia if you lower the blood pressure too much. So all the guidelines, whatever you follow, will not let you bring the hypotension to these patients, because that can cause a secondary ischemic incidence to the brain. The target, if the only hypotensive target for these patients would be to bring the systolic less than 160 if it is going beyond that. But no, hypotension can lead to secondary ischemic things.
Thank you, Dr. Prashant. The next question is from Dr. Alka Chandra, and she wants to know what is the incidence of undetected aneurysms which might bleed intra-op.
For my sake of understanding, I will have to reframe the question because it has two questions for me, Alkaji, because one is undetected aneurysm and one is which can bleed. So incidence of undetected aneurysm, if we are saying undetected, it is not reported. But what I have given you in the data is like 6 to 16 is the per lakh is Indian data of aneurysm which has been found in the population. So nearly something around 75 to 2 lakhs of aneurysm cases are there in India per year. So that's a big range because most of them are undetected, not reported. These are based on the patients who are getting reported. So that is why this undetected data cannot be confidently shared here. And the incidence of intra-op bleed is I'm sorry, I do not have the right figure, but what I have seen that we do around 4 to 5 clippings a month. And I think 5 to 10 cases per year. So that means I would say that out of 100 cases, maybe around 5 cases, we find that they get ruptured during the clipping time. So that might be my experience with this figure.
Thank you so much. I don't see any more questions. So thank you, Prashant. And,
thank you so much, ma'am. Maza aa gaya aapse milke itne din baad.
Sure, definitely. Same here. And thanks, organizers, for having me again. Thank you.
Thank you, sir, for such a wonderful presentation. And thank you, ma'am, for chairing the sessions.
Thank you.
Now we will have our first long case of the day. Pain medicine and at GTB Hospital, University College of Medical Sciences, New Delhi. Her areas of interest are, ma'am is in charge of advanced skill and conducted BCLS and ACLS courses. She is reviewer for various journals. She is examiner for various MD, DA and exams of various universities. And she has more than 60 publications in national and international journals. Ma'am's areas of interest are airway, resuscitation, trauma, obstetric anesthesia, and regional anesthesia. Welcome, ma'am.
Thank you, Nidhi. Thank you for that nice
have
introduction. Am I audible?
We have Dr. Yes, ma'am, you are audible.
Yes, Sandeep.
We have Dr. Sandeep Kumar, who is the Associate Professor in Department of Anesthesia, ABVIMS and Dr. RMN Hospital. Sir's areas of interest are neuroanesthesia and critical care. And we have Dr. Vishwanath, a third-year postgraduate student, who will be presenting a case of 35-year-old female with post-burn contracture planned for release of the contracture and split screen grafting. Welcome, everyone. Ma'am, now I hand it over to you to start the case.
Thank you, Nidhi. At the very outset, I would like to thank all the organizing team, all the members of all the organizing team who have given me this opportunity to be a part of their program, APPEC 22. And it will be nice to interact with students. I hope everybody participates in this. So we begin with the case presentation, and Dr. Vishwanath, you can start presenting the case now.
Thank you, ma'am. Good morning, Sujata ma'am. Good morning, Sandeep sir. Good morning, my seniors and all the viewers. Now I'm presenting my case. My case is a 35-year-old female resident of Karol Bagh, New Delhi, referred to pre-anesthesia checkup clinic from Burns and Plastic Department for evaluation of neck contracture release and split skin grafting surgery. She presented with chief complaint of post-burn scarring at lower part of chin, front and both sides of neck for 2 years. Grossly restricted neck movement with inability to look forward for last 1.5 years. Mouth opening is limited for the same duration. Now, in history of present illness, we found that patient was apparently well 2 years ago prior to the fire mishap when her pallu, which was wrapped around her neck, accidentally caught fire and while cooking at her residence. She was rescued from the side by her husband and wrapped in a blanket and taken to nearby hospital. Patient was conscious all through the incident.
So
No
Vishwanath,
yes, ma'am.
What do you think it is important to know the mode of burns or the cause of burns at this stage?
Ma'am, mode of burn or cause of burn gives us an idea about the type of burn injury happened. Like here, patient was conscious through the incident, and the patient has an incident of fire caught in her pallu. So we got to know that she had not had a inhalation injury, or it is a simple burn injury, a thermal injury. So from that, we rule out the carbon monoxide and others cause, and also that changes the treatment, acute burn management also.
Please carry on.
Yes. There is no history of singed hair, blackish sputum, hoarseness of voice, difficulty in breathing, noisy breathing at the time of burn. According to the documents available, patient sustained a grade 3 burn of her lower face, whole neck and front side of the chest with involvement of around 15% of total body surface area. Scar formation started in the neck after 5 months of burn and with gradual onset, which was gradual in onset and progressive in nature. Now patient has difficulty in moving her neck in either direction due to the scar and opening her mouth for eating and drinking, and also looking at ceiling in sitting as well as standing position. and she has difficulty in lying straight and uses around 10 centimeter pillow to lie on bed. And we also get to know that her appetite is decreased and she lost weight around 12 kg since accident. Her bowel bladder habits are normal and normal sleep-wake cycle, but she sleeps in lateral position with a pillow under her neck. And in negative history, we found that she has no history of fever, cough, and cold at present, no history of snoring, no difficulty in swallowing, no change in or regurgitation, and no history of psychiatric illness, depression, or anxiety. Now we go to the past history. There was no history of hypertension, heart disease, thyroid disorder, bronchial asthma, TB, epilepsy, or psychiatric illness. Neither there is history of trauma, blood transfusion, drug allergy, or radiation exposure neck in the past. She has no history of COVID exposure and her vaccination was complete. And hospitalization history, we found that she has no history of hospitalization except for the burn incident. Now coming to personal history, we found that she is a housewife, married for 11 years, having 2 children aged 9 years and 7 years. Both were delivered by uneventful normal vaginal delivery. She was educated up to 12th class, low socioeconomic status, consumes mixed diet, no history of addiction, and her menstrual history was regular. And in family history, there is no significant family history. Now coming to treatment history. She was managed for a week in high dependency unit and later in burns unit. No ERO intervention was needed during the hospital stay. And oxygenation was monitored by finger pulse oximetry and maintained through face masks, followed by nasal cannula and lastly in room air. She required though multiple burn dressing under sedation during this period, but no history of ICU admission or blood transfusion needed. Initially, and later on started taking liquids and she was discharged after 39 days. Now, examination was done after getting consent from the patient and after making her comfortable. Examination was done in sitting position. Patient was conscious, oriented to time, place, and person, and cooperative, and ill-nourished. Obvious burn contracture in front of neck seen and fixed flexion deformity on neck. We found pallor is present, but no cyanosis, petal edema, or lymphadenopathy. Peripheral veins are accessible, could not be accessed because of neck contracture. Weight and height 165 centimeter and is 18.4 kg per meter square.
So is this normal? Is it
In
normal?
ma'am, a lower normal, ma'am, 5 to 25 is a normal limit.
Okay. Okay, continue.
Ma'am, should I proceed?
Yes, yes, continue.
Yes. In vitals, pulse is 90 per minute, regular, good in volume and character, no radial or radiofemoral delay. All peripheral pulses were palpable. Blood pressure 120/70 millimeter of mercury, measured in right upper arm in sitting position. In respiratory rate 18 per minute and regular and thoracoabdominal in nature. Was 98% touch. Now in local examination, we found the burns area involved approximately 15% of total body surface area.
So
The
how is
patient
this, how this assessment of burns is done in acute burns? Can you tell us something about it?
Yes, ma'am. Acute burn can be measured by firstly Wallace rule of 9 method, where we take 9% for head and neck, and for upper both 9% each, and 18% we take anterior and posterior surface of trunk, and perineum is taken as 1%. And also there is another method that is Lund and Broder chart, and that is measured by taking the A and B and C, like ma'am, this letting A and C, A for head and B for thigh and C for leg. And this area can usually changes the surface amount according to the age change. And also there is method and quick measurement that is called Palmer method, where we take full hand as 1% of the patient body surface area and only the palm excluding the fingers at 0.5%.
Okay. Continue.
Okay. Now we come to again to the local examination. Nostrils appear normal. Both angles of the mouth are scarred. The lower lip is everted. The hypopigmentation noted over the neck, chest among the scar tissue. And in contracture, we found that extending from symphysis menti to anterior chest up to the nipple line, and horizontally 25 centimeter, lateral involves approximately 50% of the anterior aspect of the neck. Strong 3 visible band of scar tissue was present, and starting from mentum to upper chest. Arms and hands are free from burn contracture. We found that fixed flexion deformity is present in the neck. Forward cage is maintained. No active ulcer, sinus or fistula. But thyroid, cricoid and cricohypothyroid membrane and trachea could not be assessed due to the contracture. Now coming to the airway examination. Nose, bilateral nares are patent, right more than left, no DNS, no growth seen. Malar areas are normal. The mouth, oral hygiene we found good, but inter-incisor gap was 2 centimeters.
Is that normal? Is this
No,
inter-incisor gap?
it is below normal, ma'am.
How do you measure it? How do you measure inter-incisor gap?
Inter-incisor gap can be measured by 2 ways. Firstly, we can put a scale and may take the distance between 2 incisor, upper and lower, and that is a scale method, and 5 to 6 centimeters is normal, and less than 2.5 centimeter we found a difficult laryngoscopy, and less than 2 centimeter laryngoscopy is impossible. And another quick method is a finger test. When we ask the patient to put his or her own 3 fingers, the index, middle and ring finger, vertically in the center. And if it is 3 finger is easily accessed, so it is normal, and if it is less so, that is restricted.
Okay. Continue.
Okay. No loose teeth, artificial or buck teeth seen, no arch palate, and modified Malampati class is class 4.
So how do you assess this Malampati class?
Where now we assess the Malampati grade, it is a modified one by Samson and Young, and here it is divided into 4 classes. The class 1, where the soft palate, uvula and facial pillars are all visible, and in class 2, where the soft palate and uvula are visible, and in 3, soft palate and only the base of uvula is visible, and in 4, only the hard palate visible, soft palate not visible. And there is also a class 0 where the epiglottis is also visible.
So it is assessed in what position, at what level you will be sitting, and patient will be with what is the position of the patient?
Eye level at the patient's mouth level. So I will be sitting in facing the patient, and I will be sitting in a slightly lower position than the patient. So I can see in my patient mouth will be in my eye level.
This is important. All the student must listen to all this, because you in the exam also you might be asked to demonstrate these tests and actually show that how do you do this assessment. Okay, carry on.
And continuing with the examination of airway, we examined the temporomandibular joint. We found that upper lip bite test, the ULBT test, it is grade 2, and
How do
Caldet
you
test,
look for
it is
this?
grade B.
Yes, it is
Ma'am,
grade 2.
yes, ma'am. Even in upper lip bite test, we say the patient to protrude, they have to see the whether he or she is able to touch the upper border of the upper lip, which is called vermilion, that is class 1. If it is crossing the vermilion border, then it is class 2, and it is not able to touch the upper lip, then it is class 3. And ma'am, in Caldet test, it is grade B.
What is this test? What is this?
Ma'am, it is also called mandibular protrusion test. Here we see whether patient lower jaw, lower incisor is able to protrude over the upper incisor. If it is able, then it is a class A. It is where when lower incisor can only be just at the level of upper incisor maximum, that is class B, and when the lower incisor cannot cross the upper incisor, that is class C. And we measured horizontal length of the mandible and that of mandibular ramus, that is could not be that was difficult to palpate the landmarks because of bond contracture. And
what is the normal horizontal length of mandible and
normal horizontal mandibular ramus length? Horizontal length of mandible should be more than 9 centimeter, and the mandibular ramus length should be more than 4 centimeter. It gives us the idea of the oropharyngeal space where the tongue actually rests during the laryngoscopy. If it is less than so, it is a lexical laryngoscopy. And we done also, ma'am, finger test, where I found no crepitus or click sound.
What is this test now? Finger test? What do you?
It is also done to see the temporomandibular movement, where we put a finger in front of this and put another finger on the mastoid process and ask the patient to open their mouth in maximum. So we can insinuate our finger front of tegus easily if the temporomandibular joint is good in condition, and also can feel the clip.
Good, continue.
Now coming to the neck examination, we found that thyromental distance, hyomental distance, and sternomental distance could not be measured due to the scar tissue. Length and
what is the importance of these thyromental, and what are the normal measurements? If you can tell me about these two.
Ma'am, this thyromental distance, here we measured from the mentum to the upper border of the thyroid cartilage. Actually, it should be more than 6.5 to for a good laryngoscopy. In less so, it will be difficult laryngoscopy. And it is also called partial distance. And in the sternomental distance, ma'am, it is measured in the extended neck from the mentum to the sternal notch. And it should be more than 12.5 for a good laryngoscopy. And it is also called Sava distance. And also it from mentum to thyroid bone, and it should be also more than 6 for a good laryngoscopy. And now we see, ma'am, length and circumference of the neck also could not be measured, as landmarks could not be palpated properly. And fixed flexion.
What about circumference of the neck? What information do you get from this, and what is normal for a female patient also?
Ma'am, circumference of the neck should be measured upon the most prominent point of the thyroid cartilage with the measurement tape. And it is normal is less than 42 in male and less than 40 for female. And we found, ma'am, there is fixed flexion deformity present in the neck also. And patient is unable to touch her manubrium sterni with her chin. And neck range of movement, we measured that found that flexion is restricted and only slight extension is possible.
Okay.
And we measured that with two scale test that angulation is about 10 degrees. And
two scale test?
Ma'am, here we measure the neck movement by asking the patient to flex the maximally against the chest, and we put a scale in front of tragus, and putting the scale in the same position, we ask the patient to extend the neck maximally, and then we put another scale on top of the first scale in front of the tragus, and we measured the angle between. It should be more than 90 degrees, ma'am, in a normal neck movement. And ma'am, also if we want to assess the atlantoaxial joint movement, and there we put a scale in front of the tragus, in just like in parallel to maxilla and to the upper incisor, and we ask the patient to extend the neck, extend the head, putting the scale in same position, and put in the new position a new scale in the similar fashion from the tragus to the upper incisor, and we measured the scale between, and we found that if there is no restriction, there is grade 1, and if there is a 1/3 restriction, atlanto-occipital joint, that is a grade 2, and if it's a grade 3, there is 2/3 restriction. And if it is a grade 4, there is no restriction of the rest of the atlanto-occipital joint extension.
So here in your patient, you were not able to do this because the extension of the neck was not possible. Okay.
No, not possible, ma'am. And for Delican test, we can do another test to see that same genes, the same atlanto-occipital joint movement by Delican test also, and found the finger at chin remained lower than the finger at occipital tuberosity, and patient could not extend her neck. And ma'am, this was done by just like this. We put a finger in front of the chin, and index finger over left hand, and another right index finger we put on the occipital tuberosity, and ask the patient to extend maximally. If it is normal, then my finger in the mentum will be higher than the finger in the occipital tuberosity. If it is in the same line or lower than that, that is restricted movement. Ma'am, now we come to the respiratory system examination, and we found that nostrils appear normal, no visible pulsation, venous prominence, ulcer mass seen, and chest movement bilateral equal with respiration. Patient is not using accessory muscle for respiration. Respiratory rate is 18 per minute, regular and thoracoabdominal, and no bony abnormalities seen. In palpation, also there is no tenderness, vocal flemmitus or vocal flemmitus is bilateral equal, and in percussion found it is within normal limit. In auscultation, bilateral vesicular breath sound heard and no added sounds heard. And breath holding time was 26 seconds and single breath count 37 seconds. In cardiovascular system examination, we found that in inspection, no precordial bulging, pulsation, mass or scar or deformities. And in palpation, there is no apex bit. Apex bit is left a fifth intercostal space and no palpable thrill and heave. In auscultation, heart rate 90 per minute, S1 and S2 is audible, but there is no murmur. And in examination, we found that higher functions normal, cranial nerve impact, reflexes normal, and others motor and sensory examinations were normal. In abdominal examination, umbilicus inverted and no visible pulsation, veins prominence or scar marks seen, no organomegaly or no free fluid.
So all the other systems were normal. Okay, summarize your case, summarize.
Now in summary, ma'am, Geeta Jadhav, 35-year-old female patient with no associated comorbidities, presented with anticipated difficult airway due to post-pun contracture involving lower face, neck and anterior chest, leading to restriction of neck extension and decreased mouth opening since last 2 years.
Okay. So your diagnosis is 35-year-old female.
Female, no associated comorbidities, AAC1, presenting with anticipated difficult area planned for contracture release and splits in grafting from lower limbs in favor of post-band contracture of neck and chest, ma'am.
Okay. So you have said your patient has anticipated difficult airway. So what are the predictors of difficult airway?
Ma'am, predictors of the difficult airway, we can classify in from difficulty in mask ventilations, which we can say on mnemonics of obese, like obesity, presence of obesity, BMI more than 26 kg per meter square, and in patients of beard and elderly patient more than 55 age, snorer, and edentulous or no teeth, this can be difficult to mask ventilate. This is one. And we can enumerate is on the basis of difficulty in supraglottic airway placement, where you can see that in restricted mouth opening and obstruction or disrupted or distorted upper airway or stiff lung or injury in cervical spine or instability of cervical spine. What can be mnemonics and rods. And it is also by difficult intubation by which is we can by mnemonic of lemon. When look externally like any facial trauma or obvious abnormality in face, large tongue or beard or mustache or large incisor, and also by following the 3-3-2 rule, that inter-incisor distance by more than 3 finger breadth, hyomental distance by 3 finger breadth, and thyroid to mouth distance, or actually the fluid distance by 2 finger, and more than 3 Mallampati score and obstruction in presence of any obstruction, any growth or abscess, peritonsillar abscess or epiglottis swelling or epiglottis is seen. And in also there's a neck mobility which is limited. In case of, we can have a difficulty in intubation. Okay, and also by ma'am, this can be graded as Cormack-Lehane. When we do the laryngoscopy, we can see and we can predict the difficulty, and it is graded in 1 to 4, and which has been subdivided 2 and 3 into A and B. Where the full view of the glottis available, then it is called 1. When the partial view of the glottis, mostly the partial posterior part of the glottic opening is seen, then it is a 2A, and the arytenoid, only the arytenoid portion is seen, then it is 2B. And only the epiglottis visible but liftable, that is 3A, and only epiglottis visible but non-liftable, then 3, and neither glottis or any structures, glottic structure is visible, then it's a grade 4. And also, there is classification called POGO classification, that is called video difficulty in video laryngoscopy, where we measured the anterior commissure to interarytenoid ronch and taken as 100%, and the percentage of the glottic opening seen by video laryngoscopy is taken as the percentage score in POGO classification. And lastly, ma'am, by difficult surgical URA, we can predict that it is by bang mnemonics like bleeding tendency or agitated or neck scarring or growth in vasculature or a tumor. We can predict that is a difficult.
Okay. So what difficulty you are anticipating in your patient?
Ma'am, our patient have a very restricted mouth opening, less than 2 centimeter, and also fixed flexion deformity is present. Extension is not possible. So we cannot intubate her in a traditional laryngoscopic maneuver. Neither we can put a device. So our option, I will prefer to go for a APPEC nasal fiber optic intubation in this patient.
That is your plan of anesthesia. What anesthesia you are planning? What anesthesia technique you are going to use?
Ma'am, we will give a proper local anesthetize the local airway, and we will do the intubation with help of the patient in APPEC with mild sedation and with
Okay.
with
So
the
you're planning
preparation
awake fiber
in
optic.
mind for
Awake.
any. Yes, ma'am.
Would you like to have any pre-operative workup or any investigations you would like to have beforehand before you proceed?
Yes, ma'am. We'll like to have a routine investigation in beforehand in pre-anesthetic checkup also. That is including complete blood count, which will include the hemoglobin, platelet, and WBC count. And we also need to have a kidney function test that will tell us about urea creatinine level and the serum electrolytes, mostly the sodium and potassium level. And in liver function test, I will want to see the albumin level to rule out any kind of alteration of blood sugar and blood grouping and cross matching in anticipated blood loss and beforehand, and a routine urine investigation as per institution protocol, and 12-lead ECG and X-ray chest, X-ray chest, P and lateral, and X-ray cervical region also to see the cervical bones and also the neck positions, and if possible in advanced investigations we can ask for a USG neck.
Okay. So after you have a pre-operative workup, what advice you will give to the patient? Now your patient is planned for surgery next day. Okay. So how will
Yes,
you
ma'am.
proceed? Any pre-operative advice or anything you would like to tell to the surgeons or to the patient?
Yes, ma'am. In pre-operative advice, I will visit the patient in ward 1 day prior, and I will take a written informed consent from the patient about my awake nasal fiber optic endoscopic technique, and also I will take by institution protocol, I will take a consent for emergency tracheostomy. I will inform the surgical team and tell them about our plans, and also inform the ENT surgeon to be present in case of emergency for a front of neck access. And I will advise for a reserve PRBC and blood products in case of blood loss. And I will confirm a bed post-operative in ICU as per institution protocol. And I will counsel the patient to relieve in anxiety and for her full cooperation during the procedure. And I will advise her to take anti-aspiration prophylaxis with H2 blocker ranitidine 150 milligram at night and on the morning also. And as my patient is respiratory abnormality or comorbidities, and so I would like to have a tablet 0.25 milligram at night for relief and anxiety in the morning, and also as I want to access the nasal airways, so I will put xylometazoline nasal drop 2 to 3 drops 3 times a day, 1 day prior to the surgery for the vasoconstriction of the nose. And I will have. Yes, ma'am.
Yes, I would like to be very clear about this thing, that not all patients will be given alprazolam when you are anticipating difficult airways. So students must see that whenever you have a patient who has history of snoring or history of going into obstructive sleep apnea, so these are certain patients where you will avoid giving even sedation with the short-acting benzodiazepines. Okay. If you find your patient is very anxious, then only you will give it, because otherwise your patient can land up with, because a patient of difficult airway can land up with obstruction or can have
obstruction.
CO2 retention. Yes.
Yes.
So that is why you have to be careful depending on the age of the patient and the difficulty which you are anticipating. You will decide this, because this patient does not have any history of snoring and she just has scar tissue in front of her neck, which is thing, and there's no history of snoring, there is no history of obstructive sleep apnea, and she's a young patient. And if you feel that your patient is anxious, then only you go for drugs like alprazolam. Otherwise, in some patients of difficult airway, you will have to you will, when you consider these things, you need not go for this. You will avoid it. Wherever you are anticipating that patient will fall into obstructive sleep apnea or will have CO2 retention or can have an obstructed airway following your small dose of benzodiazepines also. Okay.
Yes,
So you said you will give xylometazoline. Why do you want to give xylometazoline?
ma'am, I want to access the nasal airway, which is highly vascular, and to improve my nasal passage and to minimize the chance of bleeding. So I will need to vasoconstrict the nasal vessels. So I will prefer to give it xylometazoline.
Okay. Any other advice you want to give?
Yes, ma'am. I will advise for the NQ advice, 9 nil per mouth advice, with 6 hours for light diet and 2 hours for liquid. And also I will ask for surgical team to put it as a fast case in the morning in OT.
Okay. So what, now your patient is prepared and next morning you are there in the OT. So how will you prepare your OT and how will you proceed on the day of surgery?
On the day of surgery, ma'am, I will first come into the OT and check the defibrillator, whether it is working or not. Next, I will see all my other my machines and monitors are functioning. I will talk.
What all monitoring you are planning to institute in this patient? What all monitoring you would like to have?
Ma'am, monitoring, I will like to have a 5-lead ECGs, and I will like to have a pulse oximeter, finger pulse oximeter. I would like to have a ETCO2 monitoring, entitled carbon dioxide monitoring. I would like to have here I would like to have at least surface temperature probe in my hand, and I would like to have a non-invasive blood pressure monitoring with me. And
saturation pulse oximeter you said?
Yes, finger pulse.
Okay.
Yes, ma'am.
This is you would like to have.
Yes, ma'am. And I will check and assemble my fiber optic instruments, and whether I will check it is functioning properly. I will have my technician ready, and I will talk to my OT staff regarding my plans of actions. And in case of any difficulty, what will be my plan B? And I'll also check for the other difficulty airway cut. And I will check for the emergency drugs in positions that will include atropine, glycopyrrolate, and that will be mephentamine, adrenaline, and lignocaine 2% in hand. And I will also see for whether others and surgical ENT surgical team is also well informed. And I will check for ma'am OT temperature also, whether it is neither too cold or not too warm. And I will then ma'am that's all ma'am. And then I will take the patient to the pre-operative area, ma'am.
Yes.
Yes, ma'am.
What will you?
In preoperative area, ma'am, I will again counsel the patient to relieve her anxiety again. Then I will, and then I'll give, and then I will give a anti-sialogogue glycopyrrolate 0.2 milligram intramuscular, at least 30 minutes prior to the OT. And after that, I will give nebulization 4% Xylocaine 4 ml for 10 to 15 minutes in sitting position, ma'am.
How this nebulization is going to help the patient? What idea you are trying to anesthetize with this?
And this nebulization will act on the upper airway, starting from the nasal nose to the nasopharynx and up to the oropharynx and posterior part of the tongue and posterior pharyngeal wall also, ma'am. That will nebulize anesthetized.
What is the nerve supply to this area?
Ma'am, to the nose and to the nasopharynx, it is by trigeminal nerve supply by greater and lesser palatine nerve and also the anterior ethmoidal nerve. And to the oropharynx, ma'am, it is supplied by the glossopharyngeal nerve.
So you want to give nebulization with lignocaine, 4%.
4%.
Okay. How much time before you are planning to take the patient in the OT?
Ma'am, at least 30 minutes before it will take around nebulization to take around 10 to 20 minutes, and my anti-glycopyrrolate will take around 30 minutes to action. In then between, I will check my every equipment or gadget and wait for the maximum anesthetizing effect for the in action, because that is primarily needed to maximize the anesthetized function, and that then I will take the patient to the OT.
Tell me something about awake intubation. Is it actually awake intubation which you are planning?
No, ma'am, it is not fully awake. So relieve the patient's anxiety and discomfort. We give a mild sedations also, like midazolam 0.5 milligram or fentanyl around 25 milligram. In this case, in a very low
Microgram,
dose,
25 and
microgram, ma'am, microgram, and in a very slow titrated manner. And we can use also, if required, we can use also a very low dose propofol or dextromethorphan also, but it will be given as a bolus also by maintenance also. And our primary role is to have the spontaneous respiration in action, and to whether patient should be able to cooperate and understand my instructions.
Yes, that is why it is called awake intubation. Your patient can follow your commands, and patient is not fully awake. Patient may be in a state of mild sedation, and you have also anesthetized the area which you are going to work by using a local anesthetic. Your spray which you have given, initially nebulization, then subsequent spray. So you can go for various technique. You can go for nerve blocks. You can go for spray as you go technique. You can also go for your intravenous sedation using any of the drugs, like you can go for dexmedetomidine, fentanyl, even propofol can be used. Okay, so you have to titrate, but use the drugs in the lower dosages, so the patient does not get anesthetized. Patient is just sedated in that state. Okay, so now you have nebulized you have given the nebulization in the preoperative area, given your glycopyrrolate you wanted to give, and now you will get the patient shifted to the OT. Following this?
Yes, ma'am. Yes, ma'am. But our in nebulization, after nebulization, I will like to anesthetize also the oropharynx also, ma'am. So oropharynx and posterior pharynx up to the vocal cord, up to the level of epiglottis also. That I will ensure it with additional 10% lignocaine spray also, ma'am. 10% that will be I will give in the tonsillar fossa, both tonsillar fossa 1 spray, and in the posterior pharynx also 2 spray. That will ensure my additional anesthetizing in the local airway. Then I will take the patient to the OT.
You can do that on the OT table also, because you have to start an intravenous cannula.
Yes,
you have to start an IV line.
Yes, yes, ma'am. Yes. Yes, ma'am. I will take the patient, then I'll secure a 18G IV cannula, and I will put my monitors in place, and I will start my procedure then.
So how are you going to perform your fiber optic intubation? Can you tell me something about it? How do you proceed with the technique?
Yes, ma'am. Then, ma'am, I will have a epidural catheter with tip cut, and I will put it in my the working channel of my fibroscope, and use at a mode of giving the local anesthetic as a spray as you go technique. This will ensure fast. Then I will take the patient to the I'll ask the patient for a cooperation again, and I will check the whether I will also already have checked the patency of nostril, and I will use the right nostril, and I will have ensured the oxygenation in between by putting a nasopharyngeal airway in the another nostril, and giving para-oxygenation simultaneously. And I will give light sedations, and I will whether I will check whether she is able to follow the command, and then I will properly lubricate I will put a 7 size around 80 tube mount with my endoscope, and fitted in the control with the control hand, and I will forward through the another nostril, And as we go, I will use lignocaine, 2% lignocaine as a spray as you go method by spraying each time, which will be around and wait for 20 to 13 seconds each after each spray to act and to anesthetize the vocal cord and beyond.
Okay. So remember, now oxygenation is very important in this patient because you achieve a longer apnea time whenever you are oxygenating a patient. So it is always
Yes, ma'am.
mandatory that you use other nostril for oxygenation, and it will help in the oral cavity itself will act as a reservoir, and patient will continue to have diffusion and will have oxygenation maintained for a longer time, even if the patient is sedated, because you might take longer to do reach the vocal cords. Okay, once you have visualized the vocal cord, what do? You said you will do spray as you go technique.
Yes, yes,
Can you tell me what is the nerve supply of the area above the vocal cords, and what is the nerve supply of area below the vocal cords?
Ma'am, above the vocal cord, it is supplied by internal laryngeal nerve, which is a branch of superior laryngeal nerve, and below the vocal cord, it is done by recurrent laryngeal nerve.
Okay. And so both are branches of vagus.
Both are branches of vagus nerve.
That is why you remember that whenever you stimulate the vocal cords or epiglottis, patient can have bradycardia or patient can have.
Yes, ma'am.
Okay. So now tell me something about, so once you have visualized the vocal cord, you said what area you would like to identify through fiber optic? How will you identify trachea? By the
cartilage ring, I will see
tracheal rings, yes.
Tracheal rings, and then I will proceed and see the carina. That will be my guideline to stop, and then I will proceed for the intubations of the process, sliding the into planning ET tube.
Okay. So after you have advanced the ET tube, you will remove the fiber optic bronchoscope immediately, or?
Ma'am, I will ensure that it is in the correct place, around 3 to 5 centimeter above the carina, and I will see the marks in proper, and then I will put it, take out the endoscope.
Okay. And connect your endotracheal tube with
the machine.
And you will proceed with the
I will ensure, ma'am, I will ensure the bilateral air entry, the chest rise, the ETCO2, to ensure that it is actually in the trachea.
So, so you finally have succeeded with your fiber optic endotracheal intubation, and you will continue with your anesthesia following this. That is what you want to say. Okay. So, and you allow the surgeon to proceed. So can you tell me something more about the nerve blocks, which can help other nerve blocks? Can you tell me something about translaryngeal block? What is it?
Yes, ma'am. By translaryngeal block, we want to anesthetize the recurrent laryngeal nerve and build trachea below the area. Below the area. Then here we ask the patient in supine posture position, ask the patient to extend maximally. Then we find out the thyroid cartilage and proceed downwards, and we find the cricothyroid notch, membrane. And then we take a 20 gauge cannula, and after properly local anesthetizing it, we put the cannula inside and check for the airway bubbles by attaching it with a water-filled syringe. And after checking it, and we put another syringe with containing around 2 to 3 ml of 2 to 4% lignocaine, and we spray it inside the trachea. And at that time, there is a cough sensation, and that can happen. Already we explain the patient for that, and with coughing, the local anesthetic further sprayed into the lower down bronchi and bronchioles and anesthetize. And thus, ma'am, we anesthetize translaryngeal way.
What about another block which is very important, which you might have, a superior laryngeal block?
Yes, ma'am.
How do you block the superior laryngeal nerve?
So for superior laryngeal block, ma'am, we find the first, in the same manner, we tell the patient to supine and keep supine position and extend the neck. and we find the hyoid bone, and finding hyoid, we find the lateral and find out the greater kernel of hyoid bone, and by keeping that 1 centimeter from down and 1 centimeter medial and 3 to 4 centimeter caudal to that is hyoid membrane. We have to pierce it, and we inside that we give around 1% glycogen of 1 to 2 ml, and at the time of doing it, we push the hyoid bone to the side we want to do maneuver by holding it in both hands.
Okay. So this supplies, the superior laryngeal nerve supplies which part you said? It supplies the anterior and posterior part of the epiglottis, as well as the laryngeal mucosa, which is there.
Laryngeal mucosa. Hearing of epiglottic fold and pharyngeal.
These are certain nerve blocks which you might be asked. Basically, you must know all the methods to anesthetize the upper airway. Okay.
Yes, ma'am.
So this can be asked in the exam, various nerve blocks. And nebulization, you are using what important thing which you have to keep in mind, how much of local anesthetic you are going to use in total, because you have used spray, you have used infiltrations, you have, so you need to keep in mind. And remember, when you're using 10% spray, it is the dose is
one spray equals to 10 milligram.
This is very important, especially if you go for, if you're using these things in children, you have to be very careful with the, so you can be asked about the local anesthetic, the maximum allowable dose, the toxicity. This can also be asked in the exam.
Yes,
so you need to be very particular, and the management of toxicity if it occurs. Okay, that is also very important. So coming back to your patient, so now you have anesthetized and now you have allowed the surgeon to proceed, and the surgeon has done his job and taken the graft from the thighs, both the thighs, and at the end of the procedure, what is your plan now? Do you plan to extubate this patient, or do you want to keep the patient intubated?
Ma'am, that depends on the surgery done by him, whether the timing of surgery, with the time duration, the amount of blood loss, and the post-extubation, the condition of patients, the vitals, and whether patient is able to maintain the full airway and fully awake, or properly we have achieved the reversal of neurovascular blocker. And if it is possible, then if it is okay, patient is otherwise in good shape, we can use try to have extubation in under awake when patient is awake extubations. And if it is not possible, then we can also put her in TPs and at least to maintain the airway. And we have always option to send him in the full with intubated. We have a ICU backup, ma'am. So we can either way we can land. We can either extubate, or that depends on the case, ma'am.
Okay. What about providing pain relief in this patient?
Ma'am, we will use multimodal anesthesia that will include the paracetamol, that will include the NSAID, and we will also use some form of opioids in form of fentanyl during the operation, and which will definitely will have a action in post-op. And in case of the whether from where the graft is taken for that area, that will be a painful area. So for that, if it is taken from thighs, we can use femoral nerve block, and if it is taken from lateral side of the thigh, we can use lateral cutaneous nerve block also.
Okay, if you are working in a place where you don't have a provision of fiber optic bronchoscope, and the surgeon wants to go for this release of this contracture, can you help the surgeon, or can you use any other technique?
Here, ma'am, we can have use the tumescent anesthesia, the local anesthesia. Here we ask the surgeon to use that local anesthesia, tumescent anesthesia, and give a incision in the tight band that is holding the neck, And when he will be doing the procedure, we will be putting the laryngoscope inside the mouth, and when the conjuncture is adequately released and we are able to see our vocal cord, then we can anesthetize, and also it will be done under mild sedation also, ma'am.
So earlier, when fiber optic was not available, we would ask the surgeon to we'll give ketamine to the patient and go for contracture release. Now you also have tumescent anesthesia available. But you have to remember that there is a lot of scar tissue, which may not be, the absorption of the local anesthetic will not take place if from the scar tissue. You need to have some vascularity from where the drug will act. Okay.
Yes.
So you have talked about pain relief, you had talked about extubation. So more or less, we have covered most of the things. You said about intramuscular, this thing. What is the intramuscular glycopyrrolate?
Yes, ma'am.
Why do we go for intramuscular glycopyrrolate? Can we give it in, because I'm going to start an IV line. So can I go for an intravenous glycopyrrolate? Because their purpose is you want to dry the secretions when you are doing the fiber optic.
Yes, ma'am. We can. Only thing that we want to give it IM to avoid the undesirable side effects like tachycardia or those things, and it can be given IV also. IV also in a reduced dose.
IV will have a shorter effect and will cause a sudden increase in heart rate as well as blood pressure. So that one needs to remember. Otherwise, if one wants to avoid intramuscular medication, one can go for intravenous. But remember that some amount of tachycardia and hypertension is likely. So we will wind up with this, and now I think we have not talked about certain things like the airway algorithm, the extubation guidelines. So Dr. Sandeep will now brief us about the management of a difficult airway case. So thank you, Vishwanath. You have done a good job. Thank you.
Thank you, Vishwanath, and I am very proud of you. You presented.
Thank you, sir.
Just I want to add a few things. Why you want to go for awake intubation in this patient, and what are the advantages of awake intubation in this patient?
Yes, he mentioned it actually.
He mentioned it.
He said that he wants
one thing I want to add, actually, there is another advantage that patient can participate in the securing the airway. See, if you ask your patient to protrude the tongue, it will give you the way to your fiber optic. That
patient
way,
remains cooperative. Even
yes.
that I said that
Patient will be cooperative.
Will cooperate. Whatever you want the patient to protrude, or patient, you will keep on talking to the patient. Yes, it's so almost over, or you protrude the tongue, which can help in your visualization of glottic opening at time of when you are close to the vocal cords or when you are trying to. Okay. Anything else you want to add?
And before giving the block, during the block, you need to aspirate. See, whenever we inject local anesthetic agent, we do aspirate, just to confirm it should not go intravascular.
Yes.
Fine. Any questions, Nidhi, which we can answer?
So there's one question in the chat box. What is the dose for tumescent anesthesia?
Sandeep, you can enlighten on this.
Vishwanath, can you do you want to answer this question?
Yes, sir. Yes, sir. It is actually done by 30 ml of around 0.5% xylocaine, lignocaine, around with is around 10 milliequivalents of bicarbonate, and that is 1:5 lakh. That is diluted form of epinephrine. And also hyalase, 1 ml hyalase is added, and it is added with around 450 ml of ringer lactate. So depending on the usage, it can be used up to 70 to 200 ml, and here the concentration, the maximum allowable limit for xylocaine is around 35 milligram per kg body weight, and above approximate 40. So there is a prolonged effect, and with a widened local anesthetic safety margin, and less chance of bleeding also, and it is effect remain around 18 hours and easy to perform.
Good. Any other question?
What is the maximum allowable dose?
For topical anesthesia, basically. what topical
Tumescent
anesthesia
you
of the airway.
mentioned, huh? For tumescent anesthesia, you just now mentioned, you can go for a.
Can we have Dr. Sandeep give his presentation now?
Very good afternoon to all of you. I am Dr. Sandeep Kumar and I am presenting my lecture on management of the anticipated difficult airway. See, if you encounter a difficult airway, you need a prior strategy and formulation before you proceed for the management of difficult airway. It is said that incident of cannot intubate situation is 0.35% and cannot ventilate intubate situation is 0.02%. Complication can be decreased by proper assessment of the airway and adherence to the management guidelines. Therefore, one should stick to one proper algorithm or guidelines. See, there are many of them available, but for the examination point of view, I have chosen difficult airway society guidelines as shown in the slide. First, in the plan A, we concentrate on the face mask ventilation and the tracheal intubation, for which we will proceed with the laryngoscopy. If we get a success, then we do a tracheal intubation, but if we fail, then we move to plan B. In this plan, we maintain oxygenation by using supraglottic airway. If the supraglottic airway insertion is possible, that we succeed in this, we have got four options: either wake up the patient, or intubate the trachea by using supraglottic device as a conduit, or proceed with the surgery with supraglottic device in situ, or go for a tracheostomy or cricothyrotomy. In case if we are not able to ventilate patient with supraglottic airway device, then we should move to plan C and concentrate on the face mask ventilation. If we get success in this, then wake the patient up, or if we are not able to mask ventilate the patient with the help of face mask, then it is a cannot intubate, cannot oxygenate type of scenario, in which immediately move to plan D, in which we do a emergency cricothyrotomy for the patient. Now, it is a scenario plan D, and it is failed intubation, failed oxygenation in the paralyzed anesthetized patient. Then one should call for help without wasting time and continue with 100% oxygen. Declare it as a cannot intubate, cannot oxygenate type of scenario, and for the plan D, in which you will plan for an emergency scalpel cricothyrotomy. The equipment needed for scalpel cricothyrotomy are scalpel with number 10 blade, bougie, endotracheal tube, cuffed one with 6 mm inter diameter for the adults. Fine. Do a good laryngeal handshake to identify cricothyroid membrane, by which we mean one should carefully palpate for the trachea in the midline of the neck, just below the thyroid cartilage. Fine. And just stabilize the trachea with the help of your thumb and index finger of the right hand. Fine. Then palpation, do a good palpation for the cricothyroid membrane and give a transverse stab incision with the help of the scalpel on the cricothyroid membrane. Turn blade through 90-degree sharp caudally, that is downward. Fine. If you after the incision, insert the bougie end, the curved end of the bougie, and the direction should be downward and caudally. Fine. And after the inserting the bougie, one should railroad the lubricated endotracheal tube of 6 mm inter diameter. After this, you should confirm the correct positioning of the tube with the help of ETCO2 or auscultation, and then fix it properly. But if the cricothyroid membrane is not palpable, fine. To make an 8 to 10 centimeter vertical incision just below the thyroid cartilage after fixing the trachea with the help of thumb and index finger carefully, and do some dissection with the help of your finger gently, and just introduce the bougie with this curved end and railroad the endotracheal tube of adequate size of 6 mm internal diameter after lubrication. Then again confirm the position with the help of ETCO2 or auscultation and fix the tube properly. Now, before jumping into the management of the difficult airway, one should have an intubation checklist to just avoid the several complications. Prepare the patient, it's important. Have a good IV access or intraosseous access as per the requirement of the patient. Optimize the position of the patient. This is very important to minimize the complications. Airway assessment is paramount importance. Identify the cricothyroid membrane, awake intubation options, whether we have, one should proceed with that. Optimal pre-oxygenation, one should pre-oxygenate patient for at least for 3 minutes consider CPAP or non-invasive ventilator support if needed, or you can go for other oxygen therapy devices also. Optimize patient states. If the patient is in shock or dehydrated, give fluid, or the patient is on iron drop, continue with that. Or patient is having abdomen distension, it can be a surgical cause also. One should put an NG tube, nasogastric tube, and aspirate out the contents and decompress the abdomen. By this, the chances of aspiration will decrease. If the patient is having no allergy, kindly avoid the concerned pharmacological agent. Prepare the equipment like you prepare the patient. Apply monitor, the standard monitor which we are going to use for this standard SpO2 monitoring, waveform ETCO2, ECG, blood pressure monitoring. All this we are going to use. One should check it before proceeding with the procedure. Check the equipment. The equipment should be properly checked thoroughly. Tracheal tube, at least one should have appropriate size tube of the concerned age of the, according to the concerned age of the patient, at least 2 of them, and one should check the cuff of the AT tube also. And direct laryngoscope, at least 2 pair with adequate size of laryngoscope blade, video laryngoscope, bougie, stellate, working suction. It is very important. Supraglottic devices of various sizes, Goodle, nasal, airways of various sizes, flexible scope, fauna test, that is a fresh cricothyrotomy set should be there. Check the check for the emergency drugs, availability of the emergency drugs. Fine. Prepare the entire team. Choose a leader who can guide the other members of the team, and who will do the intubation, or who will do the second intubation, who will give the cricoid pressure if required, drugs, who will give the drugs, monitoring, who will give monitoring, who will take care of, and who will give the mills, who will perform the cricothyrotomy. It's all decided by the team leader itself. So it's the responsibility of the team leader to ensure the distribution of work properly. And who do we call for help? This should be clear. And who is not noting the time? This is also important. Prepare for the difficulty airway according to the plan chosen, like plan A, plan B, plan D. But the preparation should be like this, and proceed with a plan. Fine. One should the team leader should communicate with the member nicely, and if you have any query, just sort it out before jumping into the procedure. Now we come to plan A. For implementation of the plan A, one should have put optimized head and neck position, pre-oxygenation at least for 3 minutes. Adequate neuromuscular blockade always help in the securing the hallway, securing the airway. Direct video laryngoscopy, maximum 3 attempts should be made. External laryngeal manipulation is helpful in case of difficult laryngoscopy or intubation. Bougie stellate should be there. Remove cricoid pressure if the operator is facing difficulties during laryngoscopy or intubation as per the requirement of the operator. And maintaining oxygenation and anesthesia is also helpful during the management. And plan B. What all we need for plan B? Second generation supraglottic devices which are recommended. Change device or size. Maximum 3 attempts can be made. Oxygenate and ventilate throughout the procedure. About plan C, if face mask ventilation is impossible, then paralyzation of the patient can help. Final attempt at mask ventilation. Use 2% techniques and adjuncts. Adjuncts, I mean to say, you can use an nasopharyngeal airway, or you can use the oropharyngeal airway. Plan D, fine. Emergency front neck access or FONA. If you are not able to mask ventilate patient properly, then immediately move to plan D, in which we are supposed to do surgical cricothyrotomy. Fine. And the preparation of a difficult airway cart. This is how a difficult airway cart look like. It has got several around 3 to 4 drawers which are properly labeled, and the sides racks are also occupied with the necessary bougie or suction catheter, and the top part of the this we use for placing of monitors for fiber optic or other screens. And that's how a difficult airway card look like. And top work surface has around 4 to 5 drawers, and it should be mobile, robust, properly logically in a logical sequence. It should be clearly labeled, easily cleaned. It should be easily cleaned also. And one should attach a proper documentation regarding all the equipments or drug which the cart is having, so that one can update it easily. Fine. here, the top of the trolley. If you talk about the top of the trolley, usually we utilize the space for keeping fiber optic or laryngoscope monitor screens. Fine. The side of the trolley are usually used to keep bougies, suction catheter of various sizes, airway exchange catheters, etc. Fine. See, all these things are arranged properly so that you can find them easily because they are properly labeled. And if you have checked and you have arranged it yourself, then you will be able to do the things nicely. About the drawer one of the trolley contain all the equipment which are used for plan A, optimize head position, bougie, alternate laryngoscope if available. See, the laryngoscope should be available at least 2 pair at least, and with various different sizes of blade. Fine. The contents are bougie, ideally on the side of the trolley, shorthand laryngoscope, McCoy blade, video laryngoscope. All these should be kept in the drawer one with proper labeling. Drawer two usually they contain plan B equipments like LMA Proceal, LMA followed by fiber optic tracheal intubation through LMA, LMA of various sizes, generation devices, intubating LMA of various sizes, airway exchange catheters, fiber optic adjoints. Fiber optic adjoints, I mean Burman airway, oversapien airway, which keeps the fiber optics in the central position when you are approaching by the oral route, and mucosal atomization devices, different types of connector, nasal sponge, lignocaine sprays, lignocaine jellies, 2% lignocaine whiskers, and still, or the related drugs which are required for fiber optic. Fine. In our institute, what we usually do, we keep them in a separate box and be well labeled, and we keep on updating it. It is easier to rotate it otherwise in various other OTs also. Fine. And then we come to drawer 3. Drawer 3 contain all the equipments of plant C, which are used in plant C, which include back mask ventilation devices, airway adjuncts, supraglottic devices. Contents of drawer 3 are face mask various sizes, oropharyngeal airway various sizes, nasopharyngeal airways of various sizes, LMA Proceal of various sizes. And about drawer 4, it contains all the equipment which we are going to use in plan D, which contains surgical cricothyrotomy sets, tracheal dilator, tracheal hook, and large bore cannula devices, bougie, soft endotracheal tube of 6-7 size. And this is the plan which we use at for the extubation. This is the algorithm by the 8-16 guidelines, which shows the extubation plan in case of anticipated difficult airway. Suppose you have you are dealing with the anticipated difficult airway, and you are able to intubate the patient, and your plan is extubation of anticipated difficult airway. Fine. It is always recommended that one should opt for awake extubation. Fine. And with all the at the time of awake extubation, one should be taking care of the extubation, the hemodynamic extubation response with the help of pharmacological drugs. Fine. Because at that time the sympathetic stimulus is so much that it may cause various complications. That's why it is recommended to use pharmacological drugs to suppress the extubation response. Deep extubation can be planned for selected group of patient only. Fine. After extubation, oxygen supplementation should be done with the help of proper oxygen therapy devices. And these are the 4 Ds and 3 S situation in which you can anticipate a difficult airway, if there is difficult mask ventilation or difficult intubation, ventilation, delayed recovery, or difficulty because of the pre-existing diseases of the patient. Keep difficult airway card ready during the extubation. Patient fully awake and obeying commands, and always extubate the patient. Your patient is fully awake and obeying commands. Fine. That way, the patient can easily protect the airway. Recruitment of the lung is, if not contraindicated, can help. And oxygen supplementation through the ETT should be given just prior to the extubation. Fine. Just to build up the FRC. Extubation should be done, always to be done over a airway exchange catheter or a fiber optic bronchoscope. And after the removal of the tube, one should consider the patient for oxygen therapy, and you can use the CPAP device or high flow nasal cannula or other oxygen therapy device as per the requirement of the patient. About the surgery itself can cause airway difficulties, and we have seen all those patients who are undergoing surgery in prone position for longer duration, or it's a oral surgery, or it's a suspected surgery related airway edema or suspected airway collapse. Fine. In all these cases, patient keep difficult airway cart ready during the extubation as told before, and consider leak test on the ventilator. Fine. And if leak test is present, then it means that the airway edema is not that much. It will not compromise the airway if you plan extubation for such a patient. Fine. Lung recruitment maneuver can be done. Oxygenation should be done just prior to extubation, and extubate over a airway exchange catheter and fiber optic bronchoscope as explained, and shift the patient for to ICU or HDU. Fine. And but if the leak test is absent, that indicate that there is significant airway edema. So you should carefully monitor the patient and delay the extubation. These kind of patients should be planned for elective ventilation. Fine. And should be continued with elective ventilation and suspected airways, airway collapse, or if you see there is delay in extubation because of the various reasons. So as per your institutional protocol, you can plan tracheostomy for such a patient later on. Fine. But you should be careful after the extubation. Monitoring is very important, because this kind of patient may need intubation also later on. Take home message: most airway complications are unanticipated and can lead to mortality. Factors which reduce complication include preparedness, assessment, planning, communication, teamwork, skill with multiple techniques, and situation awareness. With this, I thank you all, and I thank the APPEC team for giving me this wonderful opportunity. I thank my HOD for giving me this opportunity. Thank you very much for being patient listener. Thank you.
Thank you, Sandeep sir, for such a nice presentation and summarizing the topic.
Do we have any questions?
So one more question is there. What is the role of high flow nasal oxygenation? High frequency nasal oxygenation.
The role of high flow nasal oxygenation is limited as far as the APPEC fiber optic intubation is planned. See, the flow rate is around 40 to 60 liter per minute, and it is very difficult to control the flow. There will be a lot of leakage, and you will land up in a soup. Fine. But yes, there are some literatures available for this, and if you see, there are specialized masks which are available, which provide a channel through which you can go for a fiber optic in these kind of patient. But it is always advisable you can put the patient on CPAP or with higher FiO2 or higher pressure support than proceeding with a high flow nasal cannula. Fine.
Okay, and also the patient is awake here. When we're going for awake fiber optic, patient will not tolerate so much of flow. It is better to go for a routine flow only, which you can give through your main breathing anesthesia circuit, and just putting a nasopharyngeal airway in the nose, which will enrich the oxygen, because your nasopharynx is still acting as a reservoir. So it will act as a reservoir, and it will increase your apnea time. So your patient will not desaturate so rapidly. That is the advantage which you are going to get. That is our concern in this patient, because you're giving sedation also, and you're given local anesthetic. But sometimes if you take longer for actually intubating or reaching the vocal cords or to intubate, so then this can help. That is what is the purpose. So high flow does not have much role in your awake fiber optic. I think no more questions. So thank you, everyone. Thank you, Sandeep, for a nice overview.
Thank you so much for sparing time for us, ma'am. I know you are actually very busy these days, but you spared some time for us. Thank you. I thank you, ma'am, on the behalf of our whole team, ma'am. And thank you, Vishwanath, for such a wonderful presentation, beta. And I wish all of you best of luck for your exams. Do well in your exams.
Best of luck to everyone for their exams.
Thank you, sir.
Thank you.
Thank you very much.
Thank you, ma'am.
Thank you, ma'am. Thank you, Vishwanath, for such a nice case discussion. Now I'll announce the result for the MCQ, set 1 MCQs. The first MCQ was most sensitive invasive monitoring for venous air embolism. And its answer is through transesophageal echocardiography. The second question was regarding enhanced recovery after anesthesia, after surgery. Which one of these is correct? And the answer is option D, where a carbohydrate rich drink is given to the patient till 2 hours prior to the surgery. And winner for this set of quiz is Dr. Santosh Kumar, who is a postgraduate student at ABBIMS and Dr. RML Hospital. Congratulations, Santosh. Proceed with the next CV slide. Now I welcome Dr. Alka Chandra for chairing the next session. Ma'am is HOD, Head of Department Anesthesia and Critical Care at Hindurao Hospital and North Delhi Medical College, New Delhi. Her areas of interest are chronic pain management, critical care, and thoracic anesthesia. Welcome, ma'am. Ma'am, you are muted.
Okay. It's my pleasure to invite Dr. Kajal Momin for her talk on perioperative point of care ultrasound for airway and lung. She is an assistant professor, Department of Anesthesia and Critical Care at CIJA Academy of Health Sciences, Imphal, Manipur. Now, we all know that airway management is the cornerstone for patient safety in anesthesiology. Now, despite advances in airway management technology, litigation concerning airway adverse events continue to represent significant medical legal exposure to anesthesiologists. Now, since vast majority of these complications are considered predictable and avoidable. So, as an examiner, I would expect the students to know more about the clinical tests which are used to assess the difficult way and difficult intubation, like Wilson score, modified Mallampty, Sampson and Young, or Cormack-Lehan classification. However, Dr. Kajal would probably enlighten the students about ultrasound and other aspects of ultrasound. So over to Dr. Kajal.
Yeah, good afternoon, ma'am, and thank you so much for the introduction. And I thank the APPEC committee for inviting me for this talk. Thank you so much. Greetings from Manipur, and thank you, APPEC, for this opportunity to speak on perioperative POCUS for airway and lung. So POCUS is defined as a goal-directed bedside ultrasound examination which aids in diagnosis or therapeutic procedure. Compared to comprehensive ultrasound examination, POCUS detects acute, potentially life-threatening conditions where detection expedites patient care. A single or few organs are examined to answer specific clinical questions at the bedside, and it takes minutes, providing real-time clinical information. There are many applications of perioperative POCUS. Today we will discuss airway and lung. These following terms will be used throughout the course of the lecture. Coming to POCUS for airway, we begin with a case scenario. We discuss indications of airway ultrasound, the main scanning techniques, and airway ultrasound in predicting difficult laryngoscopy or intubation. So 58 years old lady of BMI 28 was posted for lap cholecystectomy. She is ASA2. Her airway is fairly fine, except that neck extension was slightly limited. Pre-oxygenation was done, followed by induction. Mass ventilation was done using two-hand technique. Injection succinylmethonium was used after confirming mass ventilation. Initial attempt at laryngoscopy was unsuccessful, and the saturation fell to 85%. Our senior anesthesiologist was called for help. The bougie manipulation was difficult, and the saturation further dropped to 70%. A supraglottic airway device was finally placed after 2 attempts, and adequate ventilation confirmed. If the case lands up in a cannot ventilate, cannot intubate situation, how confident are you of an emergency front of neck access? It has been seen that the success rate of anesthesiologists attempting to perform life-saving cricothyrotomy is unsatisfactorily low. The inability to identify the cricothyroid membrane is an important contributor. Misplacement is the most common complication when attempting the procedure. So the most well-published indications for airway ultrasound are pre-anesthetic airway evaluation to be prepared for emergency front of neck airway abscess, for elective tracheostomy, for correct localization of endotracheal tube, predicting the optimal size of endotracheal double lumen tracheostomy tubes, identification of vocal cord palsy and other pathology. There are many other uses, but we will discuss use of airway ultrasound in airway assessment. So the main scanning techniques for airway focus involve scanning the floor of the mouth and tongue, the larynx and esophagus. Longitudinal and transverse scans are done to see the floor of the mouth and tongue. Transverse scan to see the thyroid cartilage. Mid-sagittal and transverse scan to see the cricothyroid membrane and cricoid. Transverse and longitudinal scans to see the thyroid, to see the trachea, and the transverse scan to see the esophagus. In a sagittal scan, the orientation marker of the probe faces the head end of the patient, while in a transverse scan, the orientation marker faces the operator's left. Linear and curvilinear probes are used in airway ultrasound. This is a longitudinal scan over the floor of the mouth and tongue. It is done using a curvilinear probe. The marker faces the patient's head end. So on the screen, the left side is the cephalad end. The area marked in green indicates the shadow from the mentum. The area in yellow indicates the hyoid. The red indicates the dorsal surface of the tongue, while the purple indicates the muscles of the floor of mouth. This is a transverse scan over the floor of the mouth and tongue. The shadows arising from the mandible are indicated in green, while the shadow arising from the tongue in red. A transverse view of the thyroid cartilage is seen using the linear probe. Thyroid cartilage is seen as an inverted V shape. Arytenoids are indicated in yellow. The vocal cords are not visualized here. This is a mid-sagittal scan over the cricothyroid membrane and cricoid. The tracheal rings are here seen as a hypoechoic string of beads or pearls. The tracheal rings 1, 2, and 3 can be seen here. The cricoid cartilage is seen as a hypoechoic bump or hump. The thyroid cartilage here is indicated in green, the cricothyroid membrane in red, and the tissue air border in brown. This is a transverse scan over the cricoid cartilage. The cricoid is seen as an inverted C shape and hypoechoic with a posterior white lining. A transverse scan above the suprasternal notch will show the trachea as an inverted U or horseshoe highlighted by a hyperechoic air mucosa interface with reverberation artifact posteriorly. The esophagus is seen posterolateral to the trachea and it has a bull's eye appearance. There are two techniques for identification of the cricothyroid membrane. They are the longitudinal string of pearls and the thyroid airline, cricoid airline technique. The SOP is the most well-published technique. The Tucker technique is recommended for patients with very short neck or flexion deformity of the neck. Coming to the longitudinal string of pearls technique, we begin the scan just above the suprasternal notch till we see the horseshoe-shaped trachea. Then we slide the probe towards the patient's right until we see half of the trachea. Then we further change the probe to the sagittal view until we see the string of pearls appearance. The cricoid can be seen as a hypoechoic bump above the string of pearls. We can also slide a needle under the probe to mark the cricothyroid membrane. The Tucker technique is begun by identifying the thyroid cartilage. Then we move the probe caudally until we identify the cricothyroid membrane, further caudally until we see the cricoid cartilage, and then finally a little cranially till we see the center, the cricothyroid membrane. The endotracheal tube in the tube has a comet tail appearance, while in the sagittal view, it has a double line sign. An esophageal intubation will give a double track sign. Ultrasound done prior to tracheostomy gives us information about the position of the ideal tracheal interspace, the distance from the skin to the luminal air and overlying blood vessels, can be continued in real time during needle insertion, and we can use bronchoscopy in combination. It has been shown that ultrasound measurement of the subglottic diameter is superior to age-based and height-based formula. External diameter of the endotracheal tube can be assessed by measuring the air column at the cricoid level. Here we see an air column of 10.7 millimeter, which is equal to outer diameter of an 8 millimeter endotracheal tube. Nerve injuries after nerve surgeries can be assessed. Lesions on the vocal cords in pediatric patients can also be identified using airway ultrasound. There are many parameters to predict difficult laryngoscopy or intubation using airway ultrasound, but we will discuss hyoid distance ratio and tongue thickness. So the failure to visualize the hyoid bone using sublingual ultrasound predicts difficult intubation. The hyoid distance ratio is the hyoid distance in the fully extended neck to the hyoid distance in the neutral position. Patients with difficult intubation have shorter hyoid distance ratio of 1 to 1.05. In this patient, we see a hyoid distance ratio of 1.02, which indicates difficult laryngoscopy and intubation. A thick tongue is an independent predictor for difficult tracheal intubation and laryngoscopy. Increased tongue thickness more than 6.1 centimeter indicates an increased risk of difficult tracheal intubation. Tongue thickness was measured from the dorsal surface of the tongue to the submental skin. Coming to POCUS for lung, we begin with case scenarios. Why lung ultrasound is done, technique of lung ultrasound, and the 10 signs in lung ultrasound. So a 72 years old gentleman of stage 4 CKD and acute and chronic renal failure presents with dyspnea to the ER. Infusion of antigen furosemide was started with some improvement. Nephrologist recommends urgent dialysis for volume overload. The right IGV got punctured 3 times during HD catheter placement, and while finishing procedure, patient develops acute severe dyspnea. He is tachypneic and tachycardic. Jugular veins is distended, there is pitting edema, and lung sounds are difficult to hear because of noise in the ER. The DDs of this scenario can be iatrogenic pneumothorax or worsening fluid overload. In the second case scenario, a 68 years old lady is admitted to the ICU for acute exacerbation of COPD. She progressively became hypercapnic despite non-invasive ventilation. She was intubated after sedation and paralysis. Post-intubation, her breath sounds are decreased, but they are present bilaterally, and the saturation is 85% despite an FiO2 of 1. Her P peak and P plat are high. So she was manually ventilated with 100% oxygen, but there is no improvement. The DDs of this scenario can be severe aspiration, pneumothorax, suboptimal endotracheal tube placement, atelectasis, or worsening COPD exacerbation. So lung ultrasound, why is it important? It has been shown that it has a high sensitivity and specificity as compared to chest X-ray in multiple disease states. It has a diagnostic accuracy nearly equal to CT scan for acute respiratory pathology. Lung ultrasound is called pleural sonography because 90% of attributable pathology involves the pleura at some point. This is a drawing of the superficial chest wall structures and lung. A corresponding ultrasound view will show the rib with a hyperechoic border. The 2 layers of the pleura will be seen as a single hyperechoic line. The lung is not seen because air scatters sound waves. The linear and curvilinear probes are used in lung ultrasound, but low frequency phased array probe is also widely used. Lung ultrasound can be done in a supine semi-recumbent or erect position. The transducer is held like a pen with the orientation marker pointing cephalad over an intercostal space. There are 2 approaches to lung ultrasound. They are the 6-point hemithorax and the 4-point hemithorax, which is utilized in the blue protocol. There are 10 signs in lung ultrasound. We will discuss normal lung, pneumothorax, interstitial syndrome, and pleural effusion. Coming to the normal lung, with the proper transducer technique, the ribs are seen on either side of the screen. The first hyperechoic line below the rib is the pleural line. This pattern created by the 2 ribs and the pleura is known as the bat sign. The lung sliding is a shimmering or sliding of the visceral pleura against the parietal pleura during respiration, and this is best seen using the linear probe. Lung sliding means no air or fluid is interposed between the visceral and parietal pleura and the pleural surfaces are not fused. Absence of lung sliding is not specific for pneumothorax. The main utility of lung sliding is to rule out pneumothorax. Now, A-line are the most common artifacts seen in lung ultrasound. They are equidistant repetitions of the pleural line. A-lines with lung sliding means normal aeration pattern and pleura is devoid of air. It signifies absence of other pathologic ultrasound signs. A-lines without lung sliding, it may be pneumothorax or air-filled lung deep to a pleurodisc surface. Coming to pneumothorax, in the M mode in lung ultrasound, a normal lung will have a seashore sign. The chest wall is known as the sea, while the lung with the grainy appearance is the sand. In pneumothorax, what we see is the stratosphere sign or the barcode sign on the M mode. A lung point is a dynamic sign that is specific to pneumothorax. It is defined as sudden appearance of lung sliding within an area of A-line pattern. Lung point is 100% specific for pneumothorax, but unfortunately, it cannot always be localized. If the pleural layers are still adjacent to one another, then cardiac pulsation will be transmitted to the pleura by the lung. This is known as lung pulse. Small amount of motion is seen in 2D, and on M mode, T lines will be seen, which are regular rhythmic disturbances arising from the pleural line. Lung sliding and lung pulse allow us to conclude that no air or fluid is there between the visceral and parietal pleura and the pleural surfaces are not fused. Case scenario 2, the patient of COPD who was intubated. Nebulized bronchodilators were given, a chest X-ray was ordered and an urgent bedside lung ultrasound was done. On the right lung ultrasound, we saw lung sliding and an A-line pattern. In the left lung sliding is absent, but lung pulse is present and an A-line pattern. So lung pulse indicates that the visceral and parietal pleura are directly opposed, thus ruling out pneumothorax. Absence of lung sliding with presence of lung pulse in the left lung suggests right mainstem intubation. So the endotracheal tube was pulled back 3 centimeters, saturation improved to 100% and P peak reduced to 25. Later chest X-ray confirmed proper placement of the endotracheal tube. Coming to interstitial syndrome, lung rockets are the second most common artifacts seen in lung ultrasound. They are ray-like, hyperechoic, vertical and discrete, and they are pathologic when 3 or more are seen in a single rib interspace. Coming to the case scenario 1, the patient whose IJV got punctured. So multiple B lines were seen, suggesting interstitial syndrome or cardiogenic pulmonary edema. Note that B lines always move with lung sliding, thus ruling out pneumothorax. 2D echo revealed reduced left ventricular systolic function. The patient was moved to a seated position. NTG infusion was increased and NIV started. Symptoms improved while awaiting dialysis. Coming to pleural effusion. In pleural effusion, we need to identify 3 findings: anatomic boundaries, an anechoic space, and typical movement of the lung in the pleural effusion, which is known as the jellyfish sign. By anatomic boundaries, we mean the lung, the diaphragm, and the subdiaphragmatic organ, which can be the liver or the spleen, depending on the right or the left side, and the chest wall. The quad sign is a specific sign in pleural effusion. With the diaphragm out of view, the effusion will be seen to have a quadrangular space. So the quad sign is formed by the ribs, cephalid, and caudate, the parietal pleura at the top, the visceral pleura with the lung at the bottom, and the fluid in between. Now the sinusoid sign in pleural effusion is seen on M mode. In M mode, we see this sign to distinguish pleural thickening from minimal pleural effusion. So this anechoic space is the effusion, while this wavy line is the lung with the visceral pleura moving from the parietal pleura with respiration. This indicates low viscosity and 15 millimeter inspiratory distance considered safe for aspiration. The take-home message: the cricothyroid membrane can be identified by ultrasound prior to management of a difficult airway. Failure to visualize the hyoid bone using sublingual ultrasound predicts difficult intubation. A thicker tongue is an independent predictor for difficult tracheal intubation and laryngoscopy. Ultrasound should be the first choice diagnostic approach when pneumothorax is suspected intraoperatively or during initial trauma evaluation. There's only one sign, that is lung point, which is specific for pneumothorax, but there are other signs that can rule out pneumothorax at the site of ultrasound examination. They are lung sliding, B lines, and the lung pulse. Thank you.
Thank you, Dr. Kajal, for that elaborative talk. And yes, we would agree that every airway is difficult until one has actually safely secured it. So obviously, as you said, ultrasound goes a long way in detecting difficult airway as well as in detecting the various lung conditions, especially in a critically ill patients, wherein you have highlighted about the pneumothorax consolidation and other things, which definitely has got a role, and wherein you can immediately act and save the patient. So thank you so much for that talk.
Thank you, ma'am, for such a wonderful lecture. As such, there are no questions in the chat box at present.
Yeah, I would like to add that in the DNB question paper last year, they got a long theory question, 10 marks, on role of ultrasound in airway assessment. So it is important for the students to know the theoretical part to be able to answer a 10 marks question. So one has to study. And on the auscultation, yeah, they also got the sinusoid sign. That's why I included that.
Yes, it was very good. Actually, I just want to know about the probe size. Probably it was not mentioned, which is used for detecting all these structures.
Yes, ma'am. Yeah, actually, time was limited, so I had to, cut off. Ma'am, you want me to tell it?
Yeah.
The question is on the probe.
Yeah. How much hertz are used for these structures?
Yes, ma'am. When we need to see the pleural line and the lung sliding, the probe is to use the linear probe. But to see for the B lines, the pleural effusion and consolidation, we need to use the curvilinear probe. But in the many of the good books, they have mentioned that we can use the phased array, which is the cardiac probe, because it gives us the depth.
With what frequency?
Ma'am, the cardiac probe, the frequency will be 2 to 5 hertz.
Right. Okay. Thank you so much.
Thank you, ma'am.
Thank you, Kajal ma'am, for such a wonderful lecture. And thank you, Alka Chandra ma'am, for chairing the session.
Thank you so much.
Thank you. Thank you.
Thank you so much.
The next CV slide, please. Now I welcome Dr. Vinod Baladhir ma'am for chairing the next session. Ma'am is professor at ABVIMS and Dr. RML Hospital, New Delhi. And her areas of interest are fiber optic and difficult airway management and critical care. A warm welcome to you, ma'am.
Good afternoon, everyone. Thank you for your kind introduction, Dr. Nidhi. Today's session is on non-operative room anesthesia, and the speaker for this session is Dr. Ashutosh Joshi. Dr. Ashutosh is working as a lead consultant, pain service program director for pain medicine fellowship at Tech Butte Hospital, Singapore. And his areas of interest are chronic pain and regional anesthesia. Now, as you all know, he is a very dynamic speaker. I would request Dr. Ashutosh to take over the session.
Good afternoon, dear anesthesia residents. I would like to congratulate Team APPEC for this excellent comprehensive course. And thanks to Dr. M.D. Kaur, Dr. Vinod Bala, Dr. Nirja Banerjee, and Akhilesh for the kind invitation. My topic for today is non-operating room anesthesia, and this is the outline of the talk. I will go through the past year questions with emphasis on the examiner's report, followed by recent relevant publications, and lastly, how to manage a COVID-19 patient when we see them for non-operating room anesthesia. Coincidentally, when I received a call from Akhilesh, I was doing this CT-guided renal tumor biopsy and thermal ablation in the remote location. I will share some of the details of this case. He was Mr. X, who is a 70-year-old male with all age-related medical conditions such as diabetes mellitus, hypertension, and previous history of ischemic heart disease. However, the most relevant significant history was that of severe cervical spondylosis. He had been offered fusion surgery by the neurosurgeons a couple of years ago, which he declined due to the high risk associated with general anesthetic. At that time, he was quoted a high risk of cervical cord injury during the procedure itself. Now, I received a call at 7 a.m. in the morning that Mr. X has been posted for CT-guided ablation and biopsy of the renal tumor under general anesthetic. When I was made aware of the history, I got concerned for the safety of the patient. I immediately called the interventional radiologist and asked him whether this case can be done under monitored anesthesia care, as general anesthetic would be deemed quite risky. He agreed with the plan, and subsequently I spoke to the patient and made sure that he understood the risks of general anesthetic and intubation as well as positioning during the procedure itself. I explained to him about a cervical cord injury and being dependent on the ventilator for lifelong as well as bedridden. The patient declined the general anesthetic again and said that he will be agreeable to proceed under monitored anesthesia care. Thankfully, everything went okay during this 2-hour surgery, and the patient did well with TCI propofol and remifentanil. However, you can see in this image that there are a lot of other things which we should be concerned about when we do such procedures in the remote location. I have told you the risk associated with the patient, but look at the procedure itself. The surgeon is doing the procedure in a very cluttered environment. He has to squeeze his hands and body into the CT scanner to place the radiofrequency probe. There could be mishaps, such as the probe can be placed into the viscera or into the lungs, leading to catastrophic events. Similarly, with regards to the equipment, we have to make sure that there is enough lag in the monitoring cables as well as TCI infusion lines. Lastly, the environment itself is in remote location. It is cluttered, not so well lit, and we are also not familiar with the team who is operating along with us. So most commonly question asked when you are presented a scenario in the Viva would be outline the challenges associated with the remote location anesthesia. And what I would advise you is to take a step back, visualize yourself in that room, in that scenario, and you have your broad headings in your mind, which is patient-related factors, equipment, environment, and you can fill in the blanks there. A common question asked in the short answer question format is an elderly male who is going for an urgent DC cardioversion in the coronary care unit. He has broad complex tachycardia of 150 beats per minute and maintaining a systolic blood pressure of 70 mmHg. His GCS is 13/15. What are the advantages and disadvantages of providing anesthesia in the coronary care unit? What factors must be taken into consideration when you choose the anesthetic technique, and what could be the complications? Now, this is the examiner's report, and you can see less than 50% of the candidates passed. And the reason which was quoted was the omission of certain facts in the answer script, such as many candidates did not acknowledge that the advantages of doing this case in coronary care unit would be avoiding the transfer of an unstable patient to the theater. The cardiology department skills are readily available there. There is specialty equipments and drugs which are immediately available, and it allows earlier treatment to the patient. The disadvantages would be remote and unfamiliar environment, and you should also expand on the lack of capnography, anesthetic drugs, skilled assistant unavailability, and sometimes WHO checklist is not even followed in the remote location anesthesia. With regards to considerations of the anesthetic technique, an important point here would be the valid consent, as it was mentioned in the question that the patient had low GCS. We should also look at the recent investigations, the starvation status, as the airway is not secured here and it could lead to risk of aspiration pneumonia. And there is also potential need for intra and inter-hospital transfers. When you're talking about the complications, which is the last segment of the question, we should not talk only about the anesthetic complications, but also the procedural complications, which could be myocardial ischemia, pulmonary edema, burns, and electrical injury to the staff. The next few slides are the answers which I have compiled for you based on the examiner's report. I have provided the PDF format of this lecture to the APPEC team, and they will share it with you. You can read it at your own time later. The another remote location anesthesia is for the electroconvulsive therapy. When I was doing post-graduation in RML hospital, we used to go across the road to another building and provide anesthesia for ECT. So I'm sure if you are doing that, you will be able to ace this question. The questions which were asked were, what are the specific preoperative considerations for ECT? What are the physiological effects of ECT and the physical injuries which may occur during the treatment? And the patient is on lithium and fluoxetine. And what are the anesthetic implications of these agents during the ECT? Now look at the pass rate. It was only 13% pass rate, and most of the candidates failed, with more than 50% of the candidates had a poor fail. And the reasons were, many candidates did not even realize that dexamethasone could be given for ECT, and they did not appreciate that myalgia is a common side effect. Many thought that ECT could not be conducted safely in an isolated environment. The consent and the mental health issues were not in the script. Problems with patient communication and likelihood of comorbidity were totally omitted by many of the candidates. Of concern was failure to understand the significance of lithium or fluoxetine therapy, as these patients appear on routine theater lists may be taking these drugs. And very few candidates mentioned the potentiation of relaxants or volatile anesthetic agents by lithium. Now, what are the specific pre-op considerations when you are doing anesthesia for the ECT? You should appreciate that the consent may not be fully valid, as the patients are mentally challenged. It may also be difficult to obtain the medical history due to their psychiatric illness. We should also look at the comorbidities, especially the absolute or the relative contraindications for the ECT, such as significant ischemic heart disease, cardiac failure, valvular diseases, raised ICP, and intraocular pressures. Also, check for implantable cardioverter defibrillators, which if present should be deactivated, or a permanent pacemaker, which should be set in the fixed mode prior to conducting the ECT. The next question was about physiological effects of ECT, and it's a fairly easy question. It affects almost all the body parts. For instance, in airway, it can cause laryngospasm. In the respiratory system, there is risk of aspiration as the airway is not secured. With regards to cardiovascular system, there is a brief parasympathetic response followed by sympathetic response. Neurological is mainly increased intracranial pressure and increased cerebral oxygen consumption. Similarly, for the GI tract, there is increased gastric pressures risking the reflux. And you should also mention about myalgias. The physical injuries which can occur during ECT would be dental damage due to the seizures, and therefore we always place a bite block there. However, intraoral damage can still happen due to biting if the bite block is displaced or not placed properly. Fractures, musculoskeletal damage is rare since we use a very low dose of the muscle relaxant nowadays. However, when we use dexamethasone, patient may have myalgias in the postoperative period. The last question was on lithium and fluoxetine, which was very poorly answered. You should know that the lithium potentiates the effect of neuromuscular blocking drugs as well as volatile agents. It can also lead to nephrogenic diabetes insipidus if the patient is on long-term medication, and therefore you should consider the fluid status of the patient very thoroughly. And the other adverse event is that of the cardiac arrhythmias. Fluoxetine is a selective serotonin reuptake inhibitor, and therefore it can lead to serotonergic syndrome, especially if the patient is given tramadol or meperidine. The other important fact to keep in mind is that it is a CYP2D6 inhibitor, and therefore it may prevent the metabolism of codeine to morphine, and therefore no analgesic effect will be obtained if the patient is receiving codeine. This is another question on ECT which was asked a couple of years ago. Most of the questions I have answered, but I will just go through three main points here. The first is, what is the definition of remote location anesthesia? Describe three main goals of the anesthetic technique specific to ECT. And if the patient is on phenelgene, how does it affect your anesthetic management? So the Royal College of Anesthetists defines remote site as any location in which an anesthetist is required to provide regional or general anesthesia and sedation away from the main theater suite or the anesthetic department. It cannot be guaranteed that the help of another anesthetist would be immediately available, and it may be either within or away from the base hospital. What are the three main goals of the anesthetic technique specific to ECT? We want to give medications which have a rapid onset and rapid offset of consciousness so that we can assess the neurological status of the patient. There should be effective attenuation of hyperdynamic response to the electric stimulus. There should be enough muscle relaxation to prevent injury for the duration of the electrical stimulus. And our anesthetic drugs should minimally suppress the seizure activity so that the patient can get the maximum benefit. The last question was on the phenelzine. Phenelzine is a non-selective irreversible MAO inhibitor, and therefore administration of indirectly acting sympathomimetic agents such as ephedrine or metaraminol should be avoided, as these may precipitate a severe hypertensive reaction. The next best choice to treat a drop in blood pressure would be phenylephrine, which is direct acting. You can also consider adrenaline and noradrenaline. However, they are highly potent and therefore not considered as first line choice. A very common question asked is transfer of an intubated patient to the MRI, and there you're supposed to provide the continuing anesthesia care to this patient. Now, the questions commonly asked are, what do you mean by the terms magnetic resonance safe and MR conditional? What are the precautions taken to prevent burns during monitoring equipments used in the MRI scanner? List the precautions to minimize the risks associated with the MRI, and what are the contraindications to an MRI scan. Again, this was very poorly answered, and it was mentioned in the report that despite the fact that many candidates will have accompanied patients to the MRI scanner, knowledge of the specific precautions needed to prevent harm during such a procedure was poor. Points were lost by concentrating on the difficulties of anesthesia in a remote location, which, whilst important, were not what was asked for. While compiling the answer of these questions, I have gone through this recent publication published in Anesthesia 2019, which are the guidelines for the safe provision of anesthesia and magnetic resonance units. So MR safe means those devices which pose no MR related hazards to patient or staff when used according to instructions, and they can be used in any MR setting. Whereas MR conditionals are these equipments which poses no MR related hazard in a specified MR environment under specific conditions. Now, these are the precautions which one should take to prevent burns in the patient whilst in the MRI room. You should check all the equipments prior to use, and there should be no breach in any insulating surfaces that risk metal contact with the skin. We should use fiber optic cables for ECG, pulse oximeter, so that we can eliminate the use of electric current and induction currents, which can lead to potential burns. Telemetric monitoring is highly advisable as it eliminates the induction currents. While using the ECG leads and electrodes, they should be of high impedance and MR safe. Do not allow cables to coil or cross each other, and always use a foam insulating pad between the leads and the patient's skin. Now, how do we minimize the risks associated with MRI? Now, thankfully, when you go to a facility where the MR is available, they have a checklist, and the staff will routinely go through the checklist very religiously. And the most important concern is the presence of ferromagnetic objects within or outside the patient body, which should be removed prior to the procedure. The other factors would be ear protection, and we commonly use ear mufflers while the patient is in the MRI scanner, as it can be very noisy there. Make sure that is sufficient length for your monitoring equipments and breathing circuits. The airway should be secured meticulously, as eventually there would be inaccessibility of the airway once the procedure starts, or prefer to use telemetric monitoring. And then you can talk about other issues with remote site anesthesia, such as senior staff support available and the staff is oriented to the facility. Sometimes there is a contrast-induced MRI, for instance, gadolinium, and you should look at the estimated GFR of the patient, and if it is less than 30 mils per minute, you should avoid contrast in these patients as they are at risk of nephrogenic systemic fibrosis. Do not repeat contrast within the 7 days. Avoid in pregnancy unless absolutely necessary. And you should always be aware about anaphylaxis happening there, and you should have all the drugs, for instance, adrenaline, etc., readily available. The contraindications to MRI is mainly the presence of metal from top to bottom in any part of the body, and it could be easily ruled out by using the checklist. Another question on MRI, which was again not very well answered. We have gone through most of the parts except for what magnetic field strength are typically used in the MRI scanner, what is the fringe field and its significance, and the last question is on the helium quench. So the most machines operate at 1.5 Tesla, the range is 0.5 to 3 Tesla. The fringe field is the peripheral magnetic field, which is outside the magnetic core. It is delineated as a safety boundary. This smaller field is usually described in gauze. The fringe field may cause interference in the electronic devices, and no patient or staff member should pass the 5G boundary without undergoing an MRI safety check. Anesthesia should always be induced outside the 5G contour and adjacent to the scanner. This permits availability of standard equipment if required at induction of anesthesia. Now, helium is used close to around 1,000 liters to keep the superconductors cool. In the event of emergency shutdown of the magnetic field, the helium expands to a gas, which is known as quenching, and it should be vented out of the scan room quickly to prevent a hypoxic mixture for all the personnel and the patient. There are various sites where you may be asked to provide non-operating room anesthesia. The other common ones are OGD, ERCP, colonoscopy, etc. and it could be asked in any permutation and combination during your Viva exams. So my advice to you is to talk to your surgeons and have a basic idea of what are the steps involved in the various surgical procedures. Now, moving on to the recent guidelines, the Royal College of Anaesthetists UK just published the guidelines for the provision of anesthesia services in the non-theatre environment. These guidelines mainly concern about providing effective, safe, and well-led services in your hospital. You should go through this document, but if you don't have time, I have just compiled the major points which were emphasized in this report. So they talk about provision of an oxygen source, suction source, scavenging system, monitoring devices, resuscitation equipments, electrical supply, adequate space, building safety standards, and post-anesthesia care standards. And you can apply these in your exams and in your practice. Now, another interesting publication is on the safety of the non-operating room anesthesia, a closed claim update published in 2017 in the anesthesiology clinics. Now, closed claim database is a structured collection of the closed anesthesia malpractice claims in the US. I would just go through the key points of this update. So the NORA claims most of the mishaps occurred in the gastrointestinal suites as compared to other places, and most of the cases were being conducted under monitored anesthesia care as compared to the general anesthetic. The most common complications in these malpractice claims was that of death as compared to the operating room claims, as well as aspiration pneumonitis. The mechanism of injury in the NORA claims as compared to operating room claims was respiratory events, which were inadequate oxygenation and ventilation. And on going through these claims, the authors claimed that the most of the cases were due to the substandard care and could have been prevented by better monitoring. So a key take-home message from this closed claim update is that we should also inculcate a practice of audit in our department, come out with solutions, and do a repeat audit to complete the cycle. This is also an interesting publication in a British Journal of Anesthesia, where the authors talk about morbidity, mortality, and system safety in the non-operating room anesthesia. It's a narrative review, and over 30 publications were screened while writing this review. The authors used a system engineering initiative for patient safety, and all the risk factors were clubbed into 5 major broad headings, which were issues with the tools and technology, issues with organization, issues with physical environment, issues with staff or person, and issues with the task. And they also came up with the strategies to mitigate these risks. So if you have time, you can go through the paper. Otherwise, going through these tables would be useful. Now, adding to the complexity of non-operating room anesthesia is the stress of managing COVID-19 patients. As the COVID-19 pandemic evolves, we will see more and more patients with infectious disease coming for non-operating room anesthesia procedures. While tackling such questions, you can formulate your answer into pre-procedural phase, procedural phase, and post-procedural phase. In the pre-procedural phase, you should have an effective screening tool such as patient having fever more than 38, running nose, sore throat, myalgias, anosmia, a recent history to high-risk countries, and any close contact which has turned positive for COVID-19. All these patients, if they have a single ear, should go for PCR swab or ART nowadays. And if the result is positive, it should be communicated to the anesthesiologist as well as surgeon to prepare the necessary medications, equipment, as well as PPE. While transferring these patients to the facility, use the lowest traffic route, reinforce transportation policies to all the staff. The COVID-19 patient should wear a surgical mask at all the times. Use oxygen supplementation using low flow nasal cannula under the face mask, or you can use oxygen face mask, and healthcare workers should don the droplet PPE. Ideally, the room where you're doing this procedure should have negative pressure environment, but if not, add in high efficiency particulate filter to reduce the viral load in the room. You can discuss with the engineering team about the airflow exchanges. All unnecessary equipment should be removed to prevent contamination. Disposable plastic sheet should be draped over all necessary equipments. Medication, airway equipment, and invasive monitoring should be prepared in advance. And usually there should be a runner outside the room who can help you in getting any other miscellaneous equipments or drugs if required. Now, this is a simple flow chart which just states that if the procedure is not necessary, you should defer the case. If it's an AGMP procedure, meaning aerosol generating medical procedure, then the staff should wear full PPE, which includes a hat, eye goggles, N95 mask, PAPR, gown, and boots. During the intra-procedural phase, only necessary personnel should be involved. There should be a strong communication between the team. There should be continual assessment of the oxygenation, ventilation, and circulation of the COVID-19 patients. Be extra cautious when using sedative medications for symptomatic COVID-19 patients, and follow the ASA fasting guidelines, as there may be risk of aspiration pneumonia. During the post-procedural phase, recover the patient in the procedure room itself. The non-infected patients should be removed from the waiting area prior to the transfer of the COVID-19 patient. Use low traffic route. Healthcare workers involved in the transport to don PPE, and they have to doff the PPE appropriately after the procedure as well. Terminal cleaning of the procedure room is of utmost importance. Unused disposable equipments should be discarded, and reusable items can be sterilized based on the hospital policy. So to summarize, we went through the past year questions, and I gave you the examiner's report as well, so that you don't commit the same mistakes again. We went through 3 recent relevant publications which are useful in understanding the subject, and then how to manage the COVID-19 patients when they come for non-operating room anesthesia. Thank you once again for your attention, and all the best for your exams. Have a good day.
Thank you so much, Dr. Ashutosh, for such an excellent presentation. I hope all the PGs must have benefited from this talk. Thank you so much. All the best to third year PGs. Thank you.
Thank you, Dr. Ashutosh, for such a wonderful presentation. And thank you, Vinod ma'am, for chairing the session. We
Thank you
have
so
a pleasure. We are really pleased to have you with us. Thank you, ma'am.
Thank you, Professor Vinod. Ma'am, you can call me Ashutosh only. You have to call me Ashutosh only. Hello. Can you hear me?
Can we have the MCQs now? Now we have the second set of MCQs. The first question is, name the sign which is seen on the M mode of lung ultrasound. The options are curtain sign, seashore sign, sinusoid sign, and quad sign. The next question, please. You anesthetize a patient for elective DC cardioversion of atrial fibrillation. Which of the following has the least influence on transthoracic electrical impedance? First is obesity. Second is emphysema. Third is pedal position. Fourth is repeated shocks. And fifth is electrode surface area. Now we'll proceed for the lunch break and we'll reassemble at 1:40 p.m. श्रेया तूने स्क्रीन शेयरिंग की हुई क्या बेटा? Welcome back, everyone. Now we'll start the second long case of the day. We have with us Dr. Asha Tyagi. Welcome, ma'am.
Thank you. Thank you so much.
Ma'am is Director Professor at UCMS and GTB Hospital, New Delhi, and her areas of interest are critical care, mechanical ventilation, obstetric anesthesia, sepsis, research methodology, including biostatistics. We have with us Dr. Nang Sujali Chopu, who is the Associate Professor in the Department of Anesthesia at ABVIMS and Dr. RML Hospital, New Delhi. Her areas of interest are neurosurgical anesthesia and pediatric anesthesia. Both of these, ma'am, will be moderating the cases, and we have with us a third-year PG, Dr. Shreya Garg, who will be presenting the case for 15-year-old with kyphoscoliosis and restrictive lung disease posted for corrective surgery. Over to you, ma'am.
Right. So, am I audible?
Yes, ma'am.
Right. So, good afternoon, Shreya. And would you like to proceed with the presentation?
Yes, ma'am.
Please.
Ma'am, can you hear me?
Your volume is not good. Barely can I hear
is
you.
Is it better now, ma'am?
Yeah, kind of better. Yes.
Ma'am, should I start?
Please.
Good afternoon, everyone. I'm presenting the case of a 15-year-old male, Arav, resident of Patel Nagar, Delhi, presented with the chief complaint of progressive deformity of the chest and back since 4 years and pain in the lower back since 2 years. The history is given by the child and the child's mother and seems to be reliable. The apparently well 4 years ago when the child's mother noticed a deformity in the back which was progressively increasing, did not correct on lying down and bending forward, and used a pillow in the upper back to help him lie down. There is history of pain in the lower back since last 2 years, which was progressively increasing, non-radiating, dull aching in character, not associated with any other joint pain, aggravated by long distance walking, and relieved by taking rest and sometimes required painkiller. There is also history of shortness of breath on exertion since 6 months. The child is able to perform daily routine activities, is unable to walk to school and has to take rest at every 100 meters approximately and is relieved on rest. There is no history of cough, fever, wheeze, chest pain, palpitation, dizziness. There is no alteration in bowel and bladder habits. There is no history of sensory or motor deficit, no history of limping or gait abnormality, no history of trauma, no history of weight loss or evening rise of temperature. There is no history of frequent hospitalization, chest infection, swelling of limbs, abdominal distension, breathlessness on lying down, or breathlessness after sleeping for a few hours, or has to get up in the middle of the night to catch breath.
Right. So, Shreya, if I can stop you here. I'm not able to see your slides. Are your slides visible to others?
Ma'am.
No, ma'am. We can't see your slides.
Ma'am, I'll just check once again.
Okay. And even if you can't project, don't worry about it. If someone can help you out, please. Dr. Nidhi?
Yes, ma'am.
All right. It doesn't matter. Let's take it as an exam case scenario. You're able to read it off the slides. So this is for the other.
Ma'am, is it visible now?
Yes. Yes. Now I can see it. Could you go back to your first slide, initial starting?
Yes, ma'am.
Okay, so you have a 15-year-old child, first thing, and you're saying that there's a deformity and there is pain. So the
yes, ma'am.
deformity started first and then the pain came in. Now
Yes.
you was trying to describe something about the deformity, that it's not getting corrected on bending and it is, he needs a pillow to kind of prop himself up. So which part of the thorax or abdomen on the back do you expect this deformity to be if he needs a pillow?
Ma'am, this deformity might be on the thorax, which is not allowing him to lie down comfortably on the bed.
Yeah, right. So thorax or lumbar, maybe a loss of the lordotic curve also.
Yeah.
Now you're saying that this is progressively increasing, then you've gone on to describe the kind of pain and you have described the kind of deformity. Next slide. For associated, you have tried to tell us that he has dyspnea.
Yes, ma'am.
So what is dyspnea?
Ma'am, dyspnea is an abnormally unpleasant awareness of one's own breathing, which the patient perceives as a difficulty in breathing.
Right. So it's an abnormal perception of your breathing, right? And it is uncomfortable. This dyspnea came in just 6 months back, and you were trying to tell us something about when it gets precipitated, when it disappears. So based on this, can you tell me how severe the dyspnea is?
Ma'am, on the basis of the Medical Research Council, the grading for the dyspnea is grade 3.
Okay, what does that mean? Grade 3 dyspnea means?
Ma'am, according to the Medical Research Council, the dyspnea can be graded into 5 grades ranging from 0 to 4, wherein 0 is there is no limitation of the physical activity. In grade 1, the patient is walking, develops dyspnea on walking up a slight hill. On grade 2, there is the patient has dyspnea on and walks at a lower pace than the peers on the same ground level. On grade 3, the patient develops dyspnea within 100 meters, and in grade 4, the patient has dyspnea on doing regular activities like bathing or dressing or stepping out of the house.
Right. So do you think this is a severe dyspnea or it's just a mild dyspnea?
Ma'am, it's a severe dyspnea.
Right. So severe dyspnea is the third thing. You said it is relieved on rest, and then you were trying to tell me something about that he does not have it when he lies down. What were you looking for?
Ma'am, if he had any orthopnea on lying down, if he had any difficulty on breathing and lying down, to rule out any cardiac involvement, ma'am.
Okay, so orthopnea, you're trying to say is specific to cardiac causes.
Yes, ma'am.
And something about getting up from sleep, you were saying?
Ma'am, paroxysmal nocturnal dyspnea.
So your patient has neither. Your patient has neither. He just has dyspnea with that deformity. Okay,
Yes.
why did you ask for a history of cough and wheeze?
Ma'am, these patients, since they have dyspnea, and these patients, I'm suspecting a deformity which can cause a restriction in the lung function of the patient. So they have inability to cough out their secretions. That is why they can have chest infections, which can lead to cough and wheezing.
No, deformity of where are you suspecting? What is your diagnosis for the deformity?
Ma'am,
sorry?
Ma'am, kyphosis. Ma'am, kyphosis.
Kyphosis. Okay, so you're based on just this little history, you're trying to say maybe a thoracic kyphosis because he needs that pillow or something, right? So a thoracolumbar kind of kyphosis. Is there any other deformity of the spine that can occur besides kyphosis?
Ma'am, scoliosis also can occur.
What are kyphoscoliosis?
Ma'am, kyphosis is the exaggerated posterior curvature of the spine. And a thoracic spine, and scoliosis is defined as the lateral curvature of the spine along with the rotational component due to various etiologies.
Okay, so maybe without seeing your patient, you are saying that probably this could be a kyphoscoliotic kind of a picture. That is why you've taken a history of cough. Why have you taken alteration in bowel bladder habits? Why is that important?
Ma'am, they can be sensory involvement. In the lower, because of the compression of the nerve roots, it can cause involvement in the sense of the sensory involvement.
So any neurological deficits is what you are looking for.
Might be alteration in the bowel and bladder habit.
Right. So neurological deficits.
Yes.
Okay. Next slide, please.
Yes.
You also talked about gait abnormality. Is the gait can it be abnormal if it's kyphoscoliosis?
Yes, ma'am, it can be abnormal.
What kind of gait do you expect?
Ma'am, a limping kind of gait, because the patient will have a feeling of
I'm
a prolonged,
sorry,
of a longer.
Shreya,
Yes, ma'am.
your voice audio is not very good.
Ma'am, is it better now?
Kind of. It just goes into complete periods of no sound or echo. Okay, let's
yes.
try it now.
Yes, ma'am.
Right. So we were trying to say, so gait abnormality, you expect a kind of a limping gait, otherwise not much of an abnormality. Why are you looking for weight loss and evening rise of temperature?
Ma'am, to rule out any tuberculosis feature, which can affect the spine of the patient as well.
Okay, so what are the causes of kyphoscoliosis that you know of?
Ma'am, they can be idiopathic, non-idiopathic, or congenital causes. Idiopathic is a huge, and idiopathic further on the basis of age of onset can be divided into infantile, juvenile, or adolescent. And
Commonest is which one?
Ma'am, commonest is adolescent.
Okay. So your patient would fit into which one if it was idiopathic?
Ma'am, adolescent.
Is that commoner in males or females?
Ma'am, it is more common in females.
Okay. And what are the other causes besides idiopathic?
Ma'am, they can be non-idiopathic causes like neuromuscular disorders. They can be spinal Duchenne muscular dystrophy, or cerebral palsy, or spinal muscular dystrophies like Friedreich's ataxia or syringomyelia, and mesenchymal disorders also like Ehlers-Danlos syndrome or Marfan syndrome. They can be trauma or neurofibromatosis.
Right. So does tuberculosis feature anywhere in the causes?
Yes, ma'am. Tuberculosis, ma'am, infectious causes also.
So that is why you looked for weight loss and evening rise of temperature, probably. Okay.
Yes.
And why are you asking for chest infections, frequent hospitalizations?
Ma'am, if the disease had been at an earlier onset, then the child must have was unable to cough out the secretion, so must have had chest infection or has to visit the hospital for the same. If the lung disease was severe, then he could have had right-sided involvement, right-sided heart involvement as well, which can lead to pedal edema or abdominal distension or orthopnea in the ending.
Okay, so in other words, you're trying to tell me the repercussions or complications of kyphoscoliosis. So which two systems are you talking about? Respiratory and cardiovascular?
Yes, ma'am.
So in respiratory, what is the pathology that occurs, or what is the defect that occurs, disease?
Ma'am, a restrictive lung disease kind of pattern occurs in the respiratory system.
And why does that lead to this right heart failure or right heart affliction?
Ma'am, because of the restrictive lung disease, the patient develops hypoxemia in the later stages as the disease progresses, which causes increase in the pulmonary vascular resistance and causes right-sided hypertrophy and can result in right-sided heart failure.
Okay, so why do they develop hypoxia? You said that's the beginning, right? Hypoxia, pulmonary vasoconstriction,
Yes,
PAH, right heart changes. So why do they develop hypoxia?
Ma'am, they have they have a decrease in the vital capacity. They have a decrease. They have a decreased. All the lung volumes and capacities are decreased. So after after the severe disease progresses, they are unable to. I mean,
normally, how is the ventilation and perfusion in the lung matched to each other? Are they equal? Is one more? Is one lesser?
Ma'am, it depends on the regions. It is more, the ventilation is more in the upper part of the lungs.
Overall, let's say VQ ratio, if you were to have, then it is normally matched?
Normally 0.8 to 1, then normally ventilation perfusion ratio is 0.8.
Okay, so if your ventilation far exceeds your perfusion, what do you call it?
Ma'am, wasted ventilation.
And the reverse, if there's too much of perfusion, shunting.
Shunting.
So what happens in restrictive lung disease to your VQ ratios and why?
Ma'am, the VQ ratios, ma'am, they decrease.
Okay. So that means these
Ma'am,
patients have a lot of VQ mismatch, and that is the reason for the hypoxia.
Yes,
Correct?
ma'am. Yes,
Okay.
ma'am.
Any other reason why you would have wanted to take this history of chest infection and hospitalizations? Any cause of kyphoscoliosis?
Ma'am,
How will you know it's a congenital kyphoscoliosis?
ma'am, if it was present since birth, then the mother will give history that it was present since birth. So
okay, and
also,
can it be associated? Yeah.
And also, ma'am, congenital, if the child has congenital, then during the developmental stages, to correct the kyphoscoliosis, there is serial casting. One of the method of treatment is the serial casting, full body casting.
Based on history, when will you suspect that it was congenital, besides what you said? Will it be associated with other congenital defects?
Yes, ma'am.
Which ones?
Ma'am,
is it more associated with, let's say, a meningomyelocele or spina
Yes,
bifida?
Yes,
and
ma'am.
do you think congenital heart diseases can occur in when
Yes.
it's a syndromic child? So if it is a right or a left sided shunt lesion,
Yes.
in which one do you get frequent hospitalizations and chest infections? Left to right, right to left?
Ma'am,
Lots of
right,
blood.
left.
You're not
Yes,
audible
ma'am.
again, right? So that is why you're looking for a history of hospitalization and chest infections also. It may be a pointer. Okay, next slide, please.
Ma'am, birth and developmental history. The child was born of full-term normal vaginal delivery and cried immediately after birth, and there's no history of an ICU admission. The child has normal developmental milestones and is fully immunized till date. There is no history of tuberculosis, bronchial asthma, drug allergy, previous surgery, or any anesthetic drug exposure. Personal history, the child has a good appetite and has regular bowel and bladder habit, has a normal sleep pattern with sometimes few interruptions in sleep due to inappropriate positioning. The child has an average academic performance in school, but is unable to participate in school sports activities. The child belongs to the lower middle class family according to modified Kuppuswamy scale.
What is the modified Kuppuswamy scale?
Ma'am, it is a scale it is a scale which utilizes the family as a whole to assess the socioeconomic status. It takes into account three things: occupation of the head of the family, education of the head of the family, and the total monthly income of the family. And the score ranges from 0 to 29, and 26 to 29 is upper, 15 to 25 is considered upper middle, 10 to 15 is lower middle, 5 to 10 is upper lower, and less than 5 is lower.
Okay, go on.
The family history, there is no history of diabetes mellitus, hypertension, tuberculosis, or musculoskeletal deformities in any of the family members.
Which particular musculoskeletal deformities are specially linked with kyphoscoliosis?
Ma'am, Marfan syndrome can be there, which can be familial. And
or any muscle dystrophy?
Ma'am, Friedreich's ataxia, or ma'am, Duchenne muscular dystrophy.
Duchenne's. Okay, go on.
Treatment history, the patient is intermittently on painkiller for pain relief since 2 years, is using braces for the last 1 year, is on calcium and vitamin D3 therapy since 2 months, and has been advised for corrective surgery.
Okay.
Then ma'am,
For the
examination.
examination. So if I was to ask you to give me a differential diagnosis based on just the history, you said a deformity in the back, which you haven't examined as yet, but he can't use a pillow, doesn't get corrected. It's associated with dyspnea, but grade 3, correct?
Yes,
and there seems to be no obvious cause for this so-called deformity. No congenital diseases, normal vaginal delivery, normal milestones, no musculoskeletal disorder. So your tentative diagnosis?
Ma'am, kyphoscoliosis.
Okay.
And
Cause?
Ma'am, idiopathic cause.
Right. So most probably an idiopathic kyphoscoliosis, adolescent onset.
Adolescent, yes, ma'am.
So accordingly, in the systemic examination, I know we have prepared slides, but what will be the most relevant findings you want to tell me from this examination?
Ma'am, in the general physical examination, first I would like to say that the child is comfortably sitting in bed, but with the support of a pillow in the upper back. The nutritional status is good. He has a BMI of 21 kg per meter square. There is no pallor, icterus, cyanosis, clubbing, or pedal edema. The METs are less than 4, and there are no signs of raised JVP. There is no muscle wasting seen.
Okay, so first thing you say it's a good nutritional status, but the BMI is 21. What is the normal BMI?
Ma'am, normally it's 18. Ma'am, normally it is 18.5 to 24.9.
Okay, but it doesn't look seem to have a nutritional deficiency.
Yes, ma'am.
Is that possible with a kyphoscoliosis? Would you like to rule that out?
Yes, ma'am.
Why?
Ma'am, because if the general condition of the patient is sick, then the patient will not have a good nutritional status, will not consume good meals.
Okay. Why are you looking for this raised JVP pedal edema?
Ma'am, because they can be right-sided heart failure. So I'm really looking for pedal edema or raised JVP.
Okay. Why did you look for muscle wasting?
Ma'am, again, they can be neuromuscular. There have been a neuromuscular disorder, so the muscle wasting can be there.
Okay. Go on.
The vital parameters, the temperature is normal, 98 Fahrenheit, and is afebrile to touch. The pulse rate is 90 per minute in the right radial artery, regular in rhythm, normal in volume and character with no radial or radiofemoral delay, and all the peripheral pulses are palpable. The blood pressure is 110 by 60 millimeter of mercury as measured in left arm in the sitting position. The respiratory rate is 24 per minute, regular, abdominothoracic pattern, and is not using any accessory muscles for respiration.
At 15 years of age, what is the normal respiratory rate you expect?
Ma'am, 12 to 18 per minute.
So this is slightly high?
Yes, ma'am.
Your patient is tachypnic?
Yes, ma'am.
Okay. What is the difference between tachypnea and hyperventilation?
Ma'am, in tachypnea, there is increased rate of respiration, whereas in hyperventilation, there is an increased rate and depth of respiration to meet the metabolic demands.
Right. So as a result, hypocapnia is more likely to be seen when there is hyperventilation. Fair enough. So, and heart rate, what is the normal you expect at this age?
Ma'am, 80 to 100 per minute.
Okay. So this is normal. He's not tachycardic. Okay.
Yes,
next slide. Next.
Then, ma'am, airway examination. There is no obvious abnormality found on airway examination and no anticipated difficult airway.
Okay.
Ma'am, then examination of the spine. It is done in the standing position, and the general appearance on inspection reveals a left side shoulder and scapula is at lower level than the right shoulder. The left side pelvis is at a higher level than the right side. Cage is prominently on the left side and posteriorly on the right side. The lateral margin of the left side trunk is more curved than the right side.
Okay, so just a moment. Go back to this slide. Whatever you're trying to describe, based on the fact that the left side shoulder is lower, pelvis is higher, okay, and the rib cage is more prominent anteriorly on the left, is this going to be a left or a right-sided scoliosis?
Ma'am, it's going to be a right-sided scoliosis.
You mean convexity is on the right?
Convexity is on the right side, yes, ma'am.
Okay, so right-sided scoliosis. Next slide.
Ma'am, on inspection from the front, the trachea is in the midline. There is crowding of ribs on the left side lower rib region. There is no indrawing of chest and sternum and no sternal prominence. From the side, there is kyphosis present in the thoracic region. From the back, the head position and hair is in the midline. There is no short neck. Scoliosis is present with the curvature of spine, which has a convexity on the right side. The extension of deformity is from the thoracic to the lumbar region. The curve is fixed. Scoliosis is compensated, and a rib hump is present on the right side.
Okay, so all these are changes in the posture are attributed to the kyphosis or the scoliosis?
Ma'am, scoliosis.
Okay, So all of this, the scapula, the pelvis, the lower limb,
Yes, ma'am.
the rib cage deformities, everything is because of scoliosis. And you're saying it's a thoracolumbar scoliosis. Correct? Okay. Next slide. Go on.
Yes, ma'am. Yes, ma'am. Swelling other than scoliosis present. There are no scars and sinuses, and the nasal cleft is in the midline. On palpation, the local temperature is normal. There is no tenderness. The deformity extends from T5 to L2 level. Muscle spasm is absent, and there is no distant swelling. Respiratory system examination. On inspection, there is crowding of ribs on the left side and a convexity towards the right side. The trachea is in the midline, and there is bilateral chest expansion is unequal, with left being more than right. On palpation, the confirmed inspectory findings are confirmed. The vocal fremitus is normal in all regions, and on percussion, it is resonant on all lung fields. On auscultation, normal vesicular breath sounds are heard in the more so in the left than the right. There are no added sounds. On bedside pulmonary function test, the single breath count is 30.
Why are you looking for added sounds on chest auscultation? What are you trying to rule out?
Ma'am, if there is any presence of infection,
so
which
you
can
would
cause
get
crepitations or wheeze.
Okay.
Or bronchi, ma'am, on the auscultation.
Are these patients more prone to have any infections or wheezes?
Yes, ma'am, chest infections, because they're unable to cough out the secretions that they have. So they are more prone to infection, chest infections.
Okay. Why are they unable to cough out? Why does
because the respiratory muscles, they become, ma'am, these patients, the peak expiratory flow rate is decreased. So they are unable to cough out the entire, all the secretions in the basal region, which can cause chest infections.
So irrespective of whether it's neuromuscular or idiopathic kind of scoliosis, either way their coughing capacity is going to be decreased. Okay. So based on these bedside pulmonary function tests, you think a single breath count of 30 is normal?
No, ma'am. Normally is more
normal?
than 40.
More than?
40, ma'am.
Okay. And breath holding time?
Ma'am, normally it is more than 25 seconds.
Okay. So you're trying to tell us that there is a derangement in PFTs also, bedside PFTs.
Yes, ma'am.
Next slide.
Cardiovascular system.
No, before this. So in your respiratory system, you've just done some bedside PFTs and they are kind of not normal. So would you like to get any other pulmonary function test in this particular patient where you're suspecting kyphoscoliosis to kind of have a diagnosis and grade the severity of the disease?
Ma'am, I would like to get a spirometry done for...
Which spirometry? Timed or non-timed spirometry?
Ma'am, timed spirometry.
Okay. And what will you see in that? To diagnose RLD?
Ma'am, the peak expiratory flow rate and the peak expiratory flow rate and ma'am, the vital capacity. Yeah.
How do you diagnose a restrictive lung defect based on your timed spirogram?
Ma'am, we can see the vital capacity, ma'am. If it is less than 80%, if it is 70 to 80%, it is mild. If it is 60 to 70%, it is considered moderate. If it is 50 to 60%, it is considered moderately severe. If it is 35 to 50%, it is severe, and less than 35% is considered very severe.
Right. So for grading, you can use the forced vital capacity. Once you have a timed spirogram, it is a forced vital capacity, right?
Yes.
It's time dependent. And what happens to the FEV1 and FVC in RLDs?
Ma'am, the FVC reduces. However, the FEV1 by FVC ratio is either normal or slightly increased.
So both FEV1 and FVC normally decrease. That's what you're trying to tell us.
Yes,
if you were to construct a flow volume loop, would it have a right shift or a left shift? Can you draw it on the slide? Do you have a pen marker?
Yes.
Do you know how to use that? You had said you do when I asked you. Yes. So please draw one flow volume loop. A normal.
Yes, ma'am.
Go ahead. Go ahead. Okay, it's not able to draw. Fine. Just tell me whether there'll be a rightward shift or a leftward shift.
Ma'am, there will be a leftward shift of the flow volume loop with a decrease in the peak expiratory flow rate, with a decrease in the height in the of the expiratory limb.
Right. So height means that the flow rates are dropping, correct? Left shift means when you go to the left of the loop, are you going towards the TLC or are you going towards the residual volume?
Ma'am, towards the TLC.
TLC. So is the total lung capacity going to increase in RLD?
No, ma'am, it is going to decrease in RLD, ma'am.
So should there be a leftward shift or a rightward shift?
Ma'am, rightward shift.
Okay, good, good. Go on, next. The next system which you examine, cardiovascular?
Yes, ma'am. Ma'am, on inspection, the chest wall is asymmetrical in shape. Precordium is normal in shape. Apical impulse is not visible. There is no engorgement of superficial veins. The JVP appears to be normal. The carotid pulsations are not visible. On palpation, the apex beat is present in the fifth intercostal space, just medial to the left midclavicular line. No parasternal heave or appreciable thrill in the area. On auscultation, normal S1 and S2 are present. Rate with a heart rate of 84 per minute, regular and no missed beats. No murmur or added sounds heard.
So nothing abnormal in the cardiovascular system. What all were you expecting or wanted to rule out? What could you have found on inspection, auscultation of CVS? What abnormalities?
Ma'am, if they would have been right-sided involvement of the heart, then a loud P2 component on auscultation, a loud P2 component of the second heart sound would have been heard. Also, these diseases, these deformities commonly associated with, can be associated with mitral valve prolapse. So because of that, a click murmur could be heard on auscultation.
So mitral valve prolapse, when you get a click, which area is it best heard in?
Ma'am, in the mitral area.
Is it systolic or diastolic?
Ma'am, it is systolic.
Okay, so do you hear it with your bell or your diaphragm? Is it a high frequency or a low frequency sound?
Ma'am, it's a low frequency sound and we hear it with the bell of the stethoscope.
A click is also a high frequency, which is heard with the diaphragm only, right? So what are the symptoms that will make you suspect that there is a mitral valve prolapse? Is it asymptomatic? Is it symptomatic normally? MVP?
Normally it is asymptomatic.
If there are symptoms, what do you expect?
Ma'am, dyspnea on exertion and...
No. MVP classically can have just a little chest pain maybe, right? And otherwise not anything much unless it gets associated with a mitral regurgitation.
Yes.
So fine, you wanted to rule out PH, so a loud P2, you looked for a click in the mitral area for MVP. Anything else that can go wrong with the CVS because of a kyphoscoliosis?
Ma'am, right-sided heart failure, right ventricular hypertrophy can happen.
Good. And can these patients have DCMP if it is a neuromuscular and congenital?
If it's a neuromuscular disorder, then they can be cardiomyopathies also. And if there is Marfan syndrome, they can be aortic or mitral valve insufficiencies as well.
Right. So there's so much you have ruled out. You're saying all this is not present. Okay.
Yes.
Next slide.
Ma'am, abdominal examination is unremarkable and there is no abnormality detected.
Tell me specifically one thing you have looked for in the abdominal examination of this patient. And why? Which organomegaly?
Ma'am, hepatomegaly specifically.
Why?
Because ma'am, right-sided heart failure can lead to hepatomegaly.
Okay. Next.
Ma'am, the central nervous system, the higher mental functions of the patient are normal. The cranial nerve examination is normal. Speech is normal and there is no sensory or motor deficit.
Why is it important to look for any neurological deficit in the lower limbs in this patient? Why do you want to examine? Let the surgeon do it.
Ma'am, because ma'am, intraoperatively there can be neurological, the spinal cord will be tampered with, which can lead to a neurological deficit in these patients.
So you want to establish?
established that there is no neuromuscular deficit before the surgery, and it is not because of any anesthetic agent.
So you just want a baseline neurological function so that you can look for post-operative neurological deficits, right? Okay.
Yes, ma'am.
And of course, these patients can have neurological deficits pre-op. Next, please.
Ma'am, summary. 15-year-old male presented with progressive deformity of chest and back, pain in the lower back, and associated with dyspnea on exertion, is using bracing and also an intermittent painkiller, likely to be a case of right-sided, progressive, adolescent idiopathic type of dorsolumbar kyphoscoliosis.
Okay. So according to you, your patient is likely to have restrictive lung disease or no?
Yes, ma'am.
What are the reasons you are saying so?
Ma'am, because there is a kyphosis. Ma'am, because there is a kyphosis which limits the thoracic cage to expand fully, and hence there's a decrease in the vital capacity, which causes a restrictive lung disease pattern. And
so you suspect that he has restrictive lung disease because there is dyspnea?
Yes, ma'am. Also, there is dyspnea.
Okay. What are the other factors which increase the chances or severity of restrictive lung disease in kyphoscoliosis? All patients of kyphoscoliosis will not have RLD, right?
Yes, ma'am.
So who are the patients who are likely to have RLD? What does it depend on? If someone has 2 vertebrae involved versus someone has 10?
Ma'am, if the number of segments, depending on the age of onset, if there is younger the age of onset, then more severe will be the disease.
Yes,
and
early onset of disease. Second, what else?
Number of segments involved. If more the number of segments involved, more will be the severity of the disease.
Okay.
And if more the disease is more towards the cephalad area, then more severe will be the disease. And also, if there is any association with neuromuscular disorders, that will also cause a more restrictive lung disease. And ma'am, the Cobb's angle, ma'am, if more the Cobb's angle, more will be the restrictive lung disease.
What Cobb's angle do you expect RLD to occur? More than how much?
Ma'am, more than 60 degrees, usually the restrictive lung disease component occurs.
How much is normal?
Normally, ma'am, it is less than 10 degrees.
At what angle do you want to operate these patients?
Ma'am, more than 40 degree.
Why? Why do you want to operate kyphoscoliotic spines?
Ma'am, for the same reason, if there is further progression of the disease, it will cause a restrictive lung disease, and further, if it progresses, it can cause alveolar hypoventilation and respiratory failure, which can also result in right-sided heart involvement and right-sided heart failure.
At what angles, more than how much Cobb's angle do you expect heart changes to occur? Right heart changes. Okay.
Ma'am, more than 100 degree.
Okay, fair enough. Go on. So based on this differential diagnosis, you have established a kyphoscoliotic, which is most probably thoracolumbar. You are saying it's idiopathic, it is adolescent onset, and it is associated with RLD, but not with any cardiovascular abnormality. Okay. So based on this, how will you now further proceed? How would you like to investigate this patient?
Ma'am, in investigations, I would like to have a complete blood count, which will include hemoglobin, total leukocyte,
Okay, complete count. What else?
Ma'am, kidney function test, serum electrolytes, coagulation profile, ECG, 2D echo, chest X-ray, arterial blood gas analysis, spirometry, and a typed and cross-match blood. And also, ma'am, spine X-ray, thoracolumbar spine X-ray in the AP view to calculate the Cobb's angle.
Okay. Now we'll take up each of these one at a time. Routine investigations, all right. Why do you want a chest X-ray done? What do you want to see?
To see any evidence of parenchymal lung disease, and to see if the trachea is in the midline.
Okay. Why do you want an ECG done?
Ma'am, to rule out any right axis deviation or right ventricular hypertrophy.
Or
any
any other
conduction
things?
abnormality, any conduction abnormality.
Or if there's a DCMP, you can have changes? Dilated cardiomyopathy?
Yes, ma'am.
You'll have chamber enlargements.
Yes,
You
ma'am.
can have, okay. In 2D echo, how do you diagnose pulmonary arterial hypertension?
Ma'am, the mean pulmonary arterial pressure more than 25 millimeter of mercury is suggestive of pulmonary hypertension.
Okay. And how much of pulmonary artery systolic pressure is pH? More than how much?
Ma'am, more than
20. More than 20. Okay, that's all right. And why do you want an ABG done?
Ma'am, to baseline ABG to see if there's any hypoxia or hypercapnia.
Okay. If there is hypoxia and hypercarbia in this patient, what does that signify?
Ma'am, that the disease is more severe and there is more restrictive lung disease.
Yeah, usually you expect that the Cobb's angle would be more than
100
approximating 100 degree by this time.
Yes.
Okay. So you said this was a right-sided kyphoscoliotic spine. Just one more thing. Is there a difference, anything which a right versus a left scoliosis can convey?
Ma'am, a left-sided scoliosis is associated with more congenital anomalies and with congenital comorbidities. So it has a poor prognosis as compared to the right side.
Correct. And usually you expect a right-sided or a left-sided scoliosis, thoracic spine?
Normally it is right-sided.
Because it's idiopathic, it's common. Okay.
Yes.
So any other investigation you want? No. Right. Now, what are the anesthetic concerns that you will have when you decide to take up this patient for anesthesia? Just enumerate.
Ma'am, prolonged surgery done in prone positioning, and ma'am, blood loss, temperature regulation, and ma'am, spinal cord injury, maintenance of mean arterial pressure and postoperative vision loss.
Okay. So why does postoperative vision loss occur in these patients? Why are you apprehensive about that?
Ma'am, it can occur either because of the compression of the ischemia of the optic nerve, which is called ischemic optic neuropathy, or it can be because of compression of the central retinal artery, both of which can cause postoperative vision loss.
Okay. So what are the risk factors for ischemic optic neuropathy?
Ma'am, if there is hypotension, which can be controlled or because of increased blood loss, or there can be because of prolonged surgery. And if
more
there
than
is
how many hours usually is a risk factor?
Ma'am, more than 3 hours, ma'am.
6 hours. Anything else?
And ma'am, existing preoperative anemia that can cause ischemic optic neuropathy.
Is it related to the volume of blood loss?
Yes, ma'am. Increased blood loss if
more than how much?
More than 40 to 45% of blood loss, then it can cause ischemic optic neuropathy.
You know everything. You just have to be guided a little, right? Good. And you said that these patients also have, it's done in the prone position. So what are your risks with prone position? Why are you apprehensive?
Ma'am, from head to toe, they can be compression of the eye, so it can cause postoperative vision loss.
You said that. Anything else?
Ma'am, macroglossia, because of the prone positioning and gravitational effect, they can be macroglossia. The dislodgement of the tube or kinking of the tube, endotracheal tube. Then, ma'am, as we go down, there can be nerve injuries related to the traction or compression of the brachial plexus. Then, as we go down, ma'am, the thoracic bolsters, if they exceed into the, if they displace into the axillary area, it can cause again brachial plexus injury. Then, ma'am, abdomen has to be kept free to avoid pressures on the abdomen and to decrease the blood loss, intraoperative blood loss. Also, adequate padding in the iliac crest area to avoid any injury to the genitalia. Then, padding in the boning prominences.
Okay. Why do these patients have more blood loss? How can you manage the blood loss intraoperatively? What will you take care to prevent excessive blood loss?
Ma'am, I will avoid hypertension. I will avoid hypoxia, maintain deep lane of anesthesia, avoid hypothermia, and use as the surgeon to use local vasoconstrictors like bone wax or fibrin glue. And also, ma'am, I can use antifibrinolytic agents like tranexamic acid in the dose of 10 milligram per kg as a bolus, followed by infusion 1 milligram per kg per hour. And during positioning,
anything to
care
do? Yes. During positioning,
abdomen to be kept free, ma'am, to avoid engorgement of the epidural veins, which can cause further blood loss.
yes, by raising the IM. Okay.
And ma'am, controlled hypotension, I can keeping in mind the mean arterial pressure to be more than 70 millimeter of mercury.
Why not less than that? You take it to 60 or 50, the blood loss will be even lesser.
Ma'am, it has a more chance of developing spinal cord ischemia and causing injury to the spinal cord. So I would like to keep the mean arterial pressure above 70.
How do you think you are going to monitor for intraoperative spinal cord injury? Is there anything you can do?
Ma'am, I can do a wake-up test. During the pre-op period, I will explain the child and the patients and the parents about the wake-up test. So intraoperatively, I can do a wake-up test, or ma'am, they can be neurophysiologic monitoring like somatosensory evoked potential and motor.
So have you ever done a wake-up test or seen it being done?
No, ma'am.
Okay, have you used evoked potentials?
No, ma'am.
No. So, okay, just for theoretical aspect, when you do a wake-up test, how do you do it? What are the precautions that you take, or how do you go ahead do it theoretically? You've explained it to the child. Now,
yes,
how will you
ma'am.
modify your technique? What will you do?
Ma'am, immediately after induction, I will not, once the effect of neuromuscular blockade wears off, I will not repeat the muscle relaxant and maintain my anesthesia on oxygen and air and 50% of oxygen and nitrous oxide mixture along with sevoflurane, volatile anesthetic agent. And once I have to do the wake-up test, I will lighten the plane of anesthesia so that the patient is just drowsy,
if you
but
are,
arousable.
just a moment, if you're not using muscle relaxants, do you need to supplement with higher doses of anything else?
Ma'am,
you're giving oxygen, nitrous oxide, sevoflurane. Now, anything with your opioid, will you have to change?
Yes, ma'am. Ma'am, opioid infusion, I'll have to start a higher dose of opioid
Higher
infusion.
dose of opioids. Okay.
Yes.
So then what will happen when you're trying to check, you have stopped your muscle relaxant, and then you ask the patient to?
Ma'am, wiggle the toes. First, I'll ask him to squeeze my hand. If he does that, then I'll ask him to wiggle the toes. If he's able to do that, then immediately after that, I'll deepen the plane of anesthesia and resume the surgery.
Okay. What are the disadvantages or problems of doing this wake-up test?
Ma'am, it is very uncomfortable for the patient. Despite the counseling, the patient intraoperatively is very wary of it. And the patient is very uncomfortable. There can be sudden dislodgement of the IV lines and the monitors.
Yes.
And the patient can have postoperatively recall of the intraoperative events.
And when he takes this deep spontaneous respiration with an open surgical field, maybe the veins are open, what is the risk?
Ma'am, there can be embolism also.
Venous air embolism. Okay.
Venous air embolism.
Okay. So you haven't used evoked potentials, but supposing you had, then which ones are used for spinal cord integrity testing?
Ma'am, somatosensory evoked potentials and motor evoked potentials.
Can you use muscle relaxants when you are using evoked potentials?
No, ma'am, when you are using motor evoked potentials, we cannot use muscle relaxants.
And SSEPs?
Hello?
Hello. And when you are using SSEPs, somatosensory?
And use muscle relaxant.
Okay. Do your inhalational agents affect evoked potentials?
Hello?
Hello, I can't hear you, Shreya. Sujali, I can't hear Shreya.
Ma'am, can you hear me now?
You keep freezing intermittently.
Ma'am.
Okay, so your inhalational agents, do they interfere with evoked potentials?
Yes, ma'am. The somatosensory work potentials, ma'am, all the volatile agents, they affect the somatosensory work potentials.
So if you have to use evoke potentials, what anesthetic technique would you use?
A TIVA and an opioid infusion.
TIVA. All right.
Yes,
so now, since we are not going to do evoke potentials, given this patient that you have, what will be your anesthetic plan? We have discussed the anesthetic considerations also. So now how will you go ahead with the anesthesia for this corrective spine surgery?
Ma'am, I would like to undergo general anesthesia with controlled ventilation during induction, followed by maintenance with oxygen per 50% oxygen nitrous mixture along with the low dose volatile anesthetic sevoflurane. And during extubation, if the surgery is uneventful, then with adequate reversal of neuromuscular blockade, I will extubate my patient.
What are the chances that you will be able to extubate and not have to do a mechanical ventilation in your patient? Is there a risk factor for post-op ventilation?
Yes, ma'am. Yes, ma'am. In the post-op ventilation, for the post-op pulmonary complications, if the vital capacity would have been less than 35% of the normal, or there would have been evidence of right-sided heart failure, or any congenital heart disease, or any association with neuromuscular disorders, then these are the patient factors. And if there were any surgical factors, like if there was blood loss of more than 30 ml per kg, or there was any injury to the thoracic contents during the surgery, then I would not like to extubate my patient.
Right. So your patient doesn't have any of these risk factors. So if the surgery is uneventful, you hope you'll be able to extubate. What will be your post-operative goals?
Ma'am, maintain analgesia, adequate analgesia, maintain adequate oxygenation, and ma'am, any to see if there's any bleeding or any coagulation abnormality. Or they can be.
How will you provide analgesia? Do you expect the post-op pain to be severe in this case?
Yes, ma'am. They can, because it will be a prolonged surgery, and there will be a long incision, big incision. So
and it's a spine surgery. So what will be your technique?
Spine surgery. Ma'am, multimodal analgesia would be the technique I would like to go in for. Using injection paracetamol 1 gram intravenously 6 hourly, then NSAIDs in intravenous diclofenac 1 mg per kg, IV 8 hourly. And ma'am, if the respiratory function is adequate, then opioid infusion in the dose of 0.5 to 2 microgram per kg per hour. For the next, yes, fentanyl.
Okay. Is there any kind of analgesic equipment you can use with your opioids which will provide excellent analgesia?
Ma'am, patient-controlled analgesia can be used for pain management, post-operative pain management.
Okay. Why would you like to maintain the temperature in the post-op for this patient? Do you think intraoperative hypothermia would be there? Why?
Yes, ma'am, because it's a prolonged surgery, and there will be infusion of crystalloids and the blood products. So it can lead to hypothermia in these patients.
Okay. If you had all modalities, is there something you can do to manage one was preventing the blood loss? Is there some way you can cut down on the need of blood transfusions in these patients?
Ma'am, there are certain techniques like autologous blood transfusion techniques, wherein there are 3 techniques. We can ask for preoperative autologous blood donation. We can ask for intraoperative acute, isovolumic hemodilution, and cell salvage technique.
Okay. So out of these, if you were to do autologous blood donation, when should it be done before surgery?
Ma'am, it should be started ideally 1 month before the surgery, and 1 to 2 donations should be made. However, the last donation should not be more than 72 hours prior to the surgery.
Okay. And would you like to start something for the patient when you're drawing out blood a month prior? Any supplements?
Ma'am.
Should they be put on iron therapy?
Yes, ma'am. Iron therapy.
Okay. So we've taken the patient till post-operative. Just 2-3 things I'd like to point out here. Now, she's done well in the case in the terms of that she knows everything. She was able to relate whenever asked, and I was able to extract the answers. This is how it is going to be most of the times in the exam. In the exam, it never comes out the way like you have crammed up answers and you're presenting in cases. So this is actually most probably how your vivas are going to go. Be prepared for that. She kept her cool, she kept her presence of mind, which is good. I also want to point out that just because you're talking about kyphoscoliosis doesn't mean you'll keep talking about that only. We had a lot of tangential questions in between. Some she knew, when she didn't know, she had the presence of mind to say that she did not know, and she saved her time. Regarding kyphoscoliosis, what we have covered is its definition. You need to know about its anatomical classification, about its causes, the difference between progressive, non-progressive, which we have not covered right now. Please read up. Then you talked about its complications in terms of restrictive lung disease, which you should know in details. PFTs you should know. Cardiac manifestations of kyphoscoliosis in both idiopathic and non-idiopathic you need to know. You need to know about all the anesthetic concerns and how your technique has to be modified with all. Blood conservation, blood replacement, massive blood loss. These are tangential vivas again, which happen with kyphoscoliosis. Pain relief is a huge issue for these patients, and rest of the complications also we covered up. And with that, I think I'd like to hand over to Dr. Sujali. She'll be taking you through all the presentation aspect of the same.
Thank you, ma'am.
Thank you, Sujali.
Okay, thank you, ma'am. We have almost covered all the points, but we have covered almost all the points, but I'll still like to summarize the case. So to start with, so what do we mean by kyphoscoliosis? So it's basically a combination of two deformities occurring in the patient, that is kyphosis and scoliosis. Kyphosis is exaggerated bowing of the back, giving it a humpback appearance, mostly in the thoracic region. And scoliosis is lateral deviation of the vertical line of the spine more than 10 degrees, along with rotation of the vertebra within the curve. So the prevalence is around 0.5 to 15% in the general population, milder forms being more common, and the most curves occur towards the right side. That is, scoliosis is mostly towards the right side, and it is more common in females. And it can be classified depending on the location of the curve and the etiology. So depending on the location of the curve, we classify kyphoscoliosis as either thoracic, occurring in the thoracic region, lumbar, thoracolumbar, and there might be two primary curves, maybe thoracic and the lumbar curve, and a rare form also cervical scoliosis may also be seen. And based on etiology, the classification as we classify as idiopathic, congenital, or non-idiopathic. And under idiopathic, we have in the infantile type, which occurs at birth to 3 years of age, juvenile, that is 4 to 10 years of age, adolescent 10 years to skeletal maturity, that is up to 15 to 16 years of age, and congenital may be associated with vertebral or rib malformations like fused ribs, fused vertebra. So, and it can be associated with syringomyelia and meningomyelocele. And neuromuscular type may be neuropathic or myopathic. The neuropathic type may be associated with cerebral palsy, spinal cord injury, or poliomyelitis, meningomyelocele, and spinal muscular atrophy. The myopathic type mostly occurs with muscular dystrophies like Duchenne muscular dystrophy, and it can be because of trauma also, following surgery, or because of traumatic fracture of the spine, or it can be post surgery or post radiation. And it is also associated with certain conditions like neurofibromatosis and mesenchymal disorders like Marfan syndrome, osteogenesis imperfecta, and arthrogryposis. Now, how do we assess a patient with kyphoscoliosis? So when we ask the patient to stand and we observe the patient from the back, we will see the soldiers are asymmetrical. One soldier is higher than the other. Then the soldier blades will be prominent, either one or both the soldier blades. And there will be a visible curve of the spine. And the hips and the waist will be asymmetrical. One will be higher and the other will be at the lower level. And on asking the patient to bend forward, that is, we do an Adams forward bending test. We ask the patient to place the palms together and bend forward to try to touch the toes. And we can see an upper back hump and a hump on the lower back on the concave side of the spine. So kyphoscoliosis affects mainly the respiratory and the cardiovascular system. So why does these changes occur? So mainly this is because of the abnormality in the thoracic cage, because of abnormality in the curvature of the spine. So there is reduction in the chest wall compliance, which may cause restrictive lung disease. So this we will see a decrease in the lung volumes on spirometry and other pulmonary function test. There will be a decrease in the vital capacity, functional reserve capacity, total lung capacity, inspiratory capacity, and expiratory reserve volume. But the FEV1 and FVC alone, they are decreased, but the ratio remains normal or maybe slightly increased. There will be subsequently, because of the restrictive lung disease and the change in the thoracic cage, there will be a ventilation perfusion mismatch leading to arterial hypoxemia and ultimately carbon dioxide retention and also respiratory failure in severe cases. So mostly the alveolar growth is not affected in patients with adolescent type, but in early onset type of kyphoscoliosis, there will be a decrease in the alveolar growth also. So this will contribute to the dysfunction, respiratory dysfunction more. So effect on the cardiovascular system, because of the change in the shape of the mediastinum and also the restrictive lung disease, there will be changes in the cardiovascular system. Initially, there will be the cardiac filling may be affected on exertion. Then because of the chronic hypoxemia due to restrictive lung disease, there will be an increase in the peripheral pulmonary vascular resistance, leading to pulmonary artery hypertension and ultimately right heart failure. And in patients with Duchenne muscular dystrophy, that is kyphoscoliosis due to myopathy, there may be a cardiomyopathy involved. And in patients with Marfan syndrome, there might be aortic or mitral insufficiency. So how do we measure the degree of kyphoscoliosis? Basically, we try to measure the degree of scoliosis using the Cobb's method, that is Lippmann-Cobb method. And in this, we take an erect X-ray anteroposterior view of the thoracolumbar spine. And the uppermost and the lowermost vertebra, which are most severely tilted towards the concavity, those vertebra are chosen, and then we draw horizontal lines from the upper border of the upper vertebra and the lower border of the lower vertebra. Then we draw perpendicular lines from these two horizontal lines towards each other. So the point where they intersect makes an angle known as the Cobb's angle. So this helps us in assessing the degree of the curvature of the spine, and also it helps us in prognosticating the cases, and it guides us in treatment. So depending on the Cobb's angle, when it is if it is more than 10 degrees, we consider the patient to have scoliosis. If it is less than 10 degrees, then it is known as spinal asymmetry. So when the patient has a curvature of 20 to 40 degrees, we consider these patients for bracing. And when they have a curvature of more than 40 degrees, these patients are considered for surgical intervention. These patients start having a when the angle is more than 65 degrees, these patients have significant decrease in the lung volumes, and when they have a curvature of more than 100 degrees, significant respiratory impairment occurs, and these patients complain of dyspnea, maybe on exertion initially, and then it progresses to severe types of dyspnea. Then when the angle is more than 120 degrees, these patients have alveolar hypoventilation, chronic respiratory failure, along with cardiovascular dysfunction. Now, how do we assess the severity of these patients? So depending on the, one is depending on the corpse angle, as I have discussed just now. Then another is depending on the number of vertebrae involved. Then more the number of vertebrae involved, more severe will be the disease. And other factors are more careful at the location of the curve, and also loss of normal thoracic kyphosis. And these patients with neuromuscular type of scoliosis will have more severe disease. Now, treatment is based on the corpse angle. That is, as I've already mentioned, patients with corpse angle of less than 15 degrees, they are advised for the follow-up visits to monitor the progression of disease. And with 20 to 40 degrees, they are considered for bracing, traction, or plaster. And when they have an angle of more than 40 degrees in the lumbar spine and more than 50 degrees in the thoracic spine, we consider them for surgical intervention. Now, what are the surgical approaches in these patients? They can be considered for posterior approach and instrumentation. That is, posterior fusion is used with various instruments, which may be laminar hooks, pedicle screws, or facet screws or wires. And patients in the growing stage, that is before they attain skeletal maturity, they may be considered for growing rods like magnetic adjustment rods, vertical expandable titanium ribs. And patients may also be considered for anterior approach and instrumentation, that is the same decortication, discectomy, and anterior fusion with use of various types of instruments can be done. Or they can also be considered for combined anterior and posterior approach. The anterior approach has more post-operative morbidities. Now, preoperative evaluation of these patients, during the history taking, we try to assess the functional capacity of these patients by asking about the exercise tolerance, breathlessness, or any presence of dyspnea. We take history of cough, wheeze, or frequent chest infections to rule out any parenchymal lung disease, like associated obstructive pathology, or any other chest problems. And we try to rule out any cardiac condition by taking the history of chest pain, palpitation, history of syncope, orthopnea, or any paroxysmal nocturnal dyspnea. And a detailed history of any history suggesting any neurological deficit has to be taken in these patients. On physical examination, in the respiratory system, we see whether the patient has any tachypnea, any wheeze or cough, and bedside PFTs like breath holding time, single breath count, which can be done. We try to rule out any the degree of respiratory dysfunction. And in the cardiovascular system, we assess the functional capacity and we look for signs of any right-sided heart failure like edema, raised AVP, or hepatomegaly. And on sculpture, we look for loud P2 in the second heart sound to rule out pulmonary artery hypertension, mid systolic click, or late systolic murmur to rule out any mitral valve prolapse, which may be seen in patients with Marfan syndrome. On skin examination, we see any cafe or spots, which may be seen in patients with neurofibromatosis or tuft of hair in cases of meningomyelin. And in the airway examination, there might be restricted neck movement if there is involvement of the cervical spine. And patients may have a high arch palate, may be seen in Marfan syndrome, large tongue in cases of Duchenne muscular dystrophy. And a detailed neurological assessment to rule out any pre-existing neurological deficit is important. Now, investigations, we do routine complete blood count, KFT with serum electrolytes, and liver function tests may be done depending on the case. And coagulation studies, chest X-ray to rule out any parenchymal lung disease, ECG and echocardiogram to rule out pulmonary artery hypertension, signs of heart right heart failure, dilated cardiomyopathy, inducing muscular dystrophy, and mitral valve prolapse. And pulmonary function test, spirometry will show a decrease in the FEV1, inspiratory normal. There is normal FEV1 by FVC. And we do a baseline arterial blood gas to see the degree of respiratory dysfunction, if there is any hypoxemia or there is any retention of carbon dioxide, or we see the alveolar arterial gradient, which may be increased in these patients. And we do the X-ray of the cervical spine to see any cervical spine involvement. Preoperative preparation of these patients. First, we have to optimize these patients because these cases are not emergency cases. So we have time to optimize these patients. So we have to optimize the nutritional status. If there is any anemia, we correct anemia. Then we optimize the pulmonary condition, like we teach the patient breathing exercises, preoperative incentive spirometry, then bronchodilators if the patient has any reactive airway disease, and antibiotic therapy if the patient has any pulmonary infection. We hydrate the patient adequately, and written informed consent is taken, and we explain about the procedure and the post-operative complications which may occur, and the need for post-operative ventilation in these patients are explained. Then we also explain to the patient and the parents about wake-up test if we are planning to do a wake-up test intraoperatively. Then blood grouping and cross-matching, and adequate cross-match blood has to be kept ready. In these cases, we have to notify the intensive care unit about the case and the need for post-operative monitoring or post-operative ventilation in these patients. Then we ensure advice about adequate preoperative preparation, that is keeping the patient ill orally for at least 6 hours. Adequate anxiolysis and gastric ulcer prophylaxis is given to these patients. Now, in the operation theater, after application of standard anesthesia monitoring, that is NIBP, ECG, pulse oximetry, capnography, and temperature monitoring, then we also use monitor the urine output. Then invasive blood monitoring, BP monitoring is a must in these cases. CBP monitoring is optional depending on the extent of the surgery and the cardiorespiratory function of the patient. Then ABG monitoring, base neuromuscular monitoring, and neurophysiological monitoring like motor evoked potentials and sensory evoked potentials are also used in these cases. And blood loss monitoring is important in these cases because we expect more blood loss in these cases. Now, anesthetic technique depends on whether we are going to do a wake-up test or we are going to use other neurophysiologic monitoring. Now, pre-medication in these patients, we give antipsychotic because we are either going to put the patient in lateral position or prone position. And benzodiazepine, that is, we usually use injection midazolam in these cases. Induction with fentanyl, propofol, and intermediate acting non-depolarizing muscle relaxant. Then we intubate the patients with armored ET tube, which is used for patients when we are considering them for prone positioning. And these patients may also require a double lumen tube when they are planning for an anterior approach or a thoracoscopic procedure. And we maintain these patients on controlled mechanical ventilation with total intravenous anesthesia technique if we are considering for neurophysiologic monitoring, like with high dose fentanyl and propofol infusion, or if or other times after a wake-up test, we can put the patient on oxygen nitrous oxide or inhaled anesthetic plus fentanyl and atracurium infusion. Succinylcholine is avoided in patients with myopathies. Now, intraoperative concerns in these cases are possible injury to the neural structures, prone positioning, prolonged surgery, blood loss, hypothermia, and the risk of venous air embolism. Now, concerns with prone positioning. During positioning, there might be accidental dislodgement of the endotracheal tube, IV lines, and monitoring lines. Then these patients are prone to eye complications, so adequate padding of the eyes has to be done. These patients may have corneal abrasions, conjunctival and periorbital edema. Post-operative visual loss is an important concern in these patients because of ischemic optic neuropathy and central retinal artery occlusion. And because of excessive flexion of the neck during positioning, there might be obstruction to the venous and lymphatic drainage of the head. Now, and because of inappropriate posturing, there might be compression of the abdomen, leading to impaired ventilation and also increased bleeding from the operative side. And another important concern during prone positioning is venous air embolism, and these patients may have neuropathies post-operatively because of excessive traction or compression of this nerve because of inappropriate posturing. Now, another important concern in this surgery is injury to the spinal cord or nerve roots. This may occur because of direct contusion of the cord during surgical exposure, contusion by instruments like hooks, wires, or pedicle screw, or because of spinal cord distraction and reduction in the spinal cord blood flow, because of hypotension, or because of instrumentation, or because of injury, vascular injury during the surgery. Spinal cord monitoring can be done. The use of a wake-up test, which is considered gold standard, or use of neurophysiological monitoring like somatosensory evok potentials and motor evok potentials, or an ankle clonus test. Now, how do we do a wake-up test? Wake-up test is done to test the integrity of the spinal motor pathways. We explain the procedure to the patient prior to the surgery. Then before we do the test, we have to switch off the inhalational agent and the muscle relaxant, and we maintain the patient on opioids and propofol. And we first ask the patient to grip the hand to ensure that the patient can follow commands, and then we ask the patient to move the leg or toes. Then during the procedure, we have to prepare to restrain any unwanted movements, because the patient may move suddenly, leading to dislodgement of endotracheal tube and other instruments during the procedure. And the disadvantage of this test is we cannot detect isolated nerve root injury or any sensory deficit, and the results can be influenced by anesthetics and depend on the cognitive integrity of the patient also. Now, neurophysiological monitoring, somatosensory evok potentials. We do this to evaluate the posterior or sensory portion of the cord. Stimulation of a peripheral nerve is done, mostly the posterior tibial nerve, and the response is recorded from the scalp. So when there is increase in the latency, that is from the stimulus to the impulse, the period, if there is more than 10% to 15% increase in the latency and decrease in the amplitude, that is the height of the response, if there is decrease in of more than 50%, then the test is considered to be significant. And muscle activity disturbance is eliminated by the use of neuromuscular blockers during this test, and it is affected by hypotension, hypothermia, hypocarbia, hypoxemia, anemia, and anesthetics. Now, motor evok potentials, it is done to assess the integrity of the spinal motor pathways, that is the anterior column of the spinal cord. There, electric and magnetic transcranial stimulation is done, and thus response is recorded as a peripheral nerve impulse or electromyographic signals or actual limb movements. This test is sensitive to the use of neuromuscular blockers. So anesthetic agents which have effect on motor evok potentials, all the inhalational anesthetics affect MEPs and SSEPs. Propofol has a lesser effect on both the MEPs and the SSEPs, and fentanyl has minimal effect. So we use propofol and fentanyl during these procedures. Now, what do we do when we see a significant result on use of neurophysiological monitor? First, we have to consider a reversal of surgical manipulation. Whatever was done, we ask the surgeon to reverse the manipulation because this is mostly caused by the surgical manipulation. And we prepare the patient for a wake-up test. We discontinue control hypotension if it is being used. We try to increase the mean arterial pressure to more than 90 millimeter mercury. Then we increase the hematocrit and we adjust the ventilatory parameters, increase the FiO2 and maintain normocarbia. And if MEP and SSCP changes are not reversed, then we perform a wake-up test on this patient. And if neurological deficit is confirmed, then a spinal cord injury protocol is to be started. We give injection methylprednisolone. And another important concern during this surgery is blood loss. So the average blood loss in this surgery may range from 600 to 2,500 ml, and that is about 15 to 25 ml per kg. So we can use various techniques to reduce the blood loss. First is we have to avoid light anesthesia, hypertension or hypercapnia. Then we ask the patient to maintain surgical hemostasis by use of bone wax and other hemostatic agents, and maybe use of vasoconstrictors. Then proper positioning also helps us by avoiding the abdominal compression in prone position and decrease in the venous pressure in the surgical site. Then we can use deliberate controlled hypotensive anesthesia and other pharmacological agents like antifibrinolytics, tranexamic acid, and aminocapric acid. Controlled hypotensive anesthesia. This can be done in young healthy patients to maintain a blood pressure of mean arterial pressure of 60 to 65 millimeter mercury. So invasive blood pressure monitoring and urine output monitoring along with EVG monitoring is a prerequisite for this controlled hypotensive anesthesia. We can go for high dose inhalational agents and vasodilators like sodium nitroprusside, nitroglycerin, and other ganglionic blocking agents like trimethophan, beta-adrenergic blockers like esmolol or labetalol infusion, AC inhibitor like captopril, and alpha-2 agonist like dexmedetomidine. Then this controlled hypotensive anesthesia should be used with caution because decrease in the spinal cord blood flow increases the chance of spinal cord damage. Now, other measures by which we can decrease homologous blood transfusion is autologous blood transfusion by going for preoperative autologous blood donation, acute normovolemic hemodilution, and blood salvage techniques. Now, important concerning this procedure is hypothermia because of the long duration of surgery and transfusion of blood products. So, coagulation will lead to increased wound infection, delayed recovery, and also change in the acid-base status of the patient. So, we can prevent this by temperature monitoring and use of warm fluids, warming blankets, warm irrigation solutions. And post-operative concern in this patient is mainly a good pain management. Post-operative ventilation and pulmonary care may be required in these patients, and bleeding and coagulation abnormalities are usually seen, and neurological monitoring is also important in the post-operative period. Now, for post-operative pain management, we can go for parenteral opioids. It can be a patient-controlled analgesia or a nurse-controlled analgesia in younger patients, which may be PCA alone with intermittent boluses or continuous infusion. And we can use paracetamol in the infusion. Then NSAIDs will help us in decreasing the opioid requirement. But this will be used with caution because NSAIDs like ketorolac have been shown to impair the wound healing. Then epidural infusion with opioids or plus minus local anesthetics. Local anesthetics has to be used with caution because they may interfere with neurological testing. Then intrathecal opiates can be used, like during the procedure, we can ask the surgeon to give morphine 2 to 5 microgram per kg in the intrathecal space. Then local anesthetic, skin infiltration. Now, predictors of post-operative ventilatory support. patients having severe restrictive lung disease with a preoperative vital capacity of less than 35%, and patients having preoperative hypoxemia with a PaO2 of less than 60 millimeter mercury and carbon dioxide retention, PaCO2 of more than 50 millimeter mercury, and patients having cardiac abnormalities or associated right heart failure, and patients with pre-existing neuromuscular diseases. These patients may require postoperative mechanical ventilation support. And surgical factors like increase in blood loss or approach, and patients in which there is surgical invasion to the thoracic cavity, these patients may need postoperative ventilatory support. Pulmonary care in the postoperative period, adequate analgesia is a must, and we have to teach the patient incentive spirometry and ask the patient to do coughing and deep breathing exercises, and bronchodilator therapy, patient has any obstructive component, and elective mechanical ventilation or transition to NIV may be tried in patients who have neuromuscular type of kyphoscoliosis. So to conclude, a careful preoperative assessment of cardiorespiratory function and neurological deficit is important in these patients, and intraoperative concerns include monitoring spinal cord integrity, prone positioning, prolonged surgery, and excessive blood loss, and aggressive postoperative control and respiratory care go a long way in postoperative outcome of these patients. That's all. Thank you.
Are there any questions for any of us?
I can't hear you, ma'am.
Okay. Are there any questions for us?
We can't hear you, ma'am.
Can you hear me now?
No.
Yeah, yes, ma'am. Yes, ma'am.
Now?
Yes, ma'am. Yeah, or audible, ma'am.
Okay, so in the chat box, I couldn't see any questions. I had put in a few comments prior to this presentation that they need to be aware of the rare circumstances when a one lung ventilation may be required in certain anterior lateral approaches, which Dr. Sujali just mentioned. The second thing I had forwarded was that calculation of Cobb's angle and Adams forward test needed to be known, which again, Dr. Sujali has covered. So if there are no other questions, I guess, then we can wrap it up.
Ma'am, there's a question in the chat box.
Yeah. One.
I would, hello, Dr. Asha.
Yes. Dr.
Hi, I'm Dr. Namita.
Yeah,
I would just like to mention that the postgraduate should know about such a patient coming for for an incident surgery.
Yes, that I wanted to
Which is
make a
very
comment.
important because
Yes.
very often we get these patients for incident surgery.
Yes.
So they should know how to manage that. If you can just mention that.
Yes. So actually the case allotted for this discussion was for a corrective spinal surgery. So that's what we focused on. But all postgraduates should be ready that even if your viva is going towards a corrective surgery for the spine, midway also you can be asked what will you do for a coincidental surgery. And in that, what we are trying to assess you for will always be whether you will be able to do a sentinel neuraxial block or not. If it's a GA surgery which is amenable only to a general anesthesia, let's say like a laparotomy, then the concerns remain similar to those for a scoliotic surgery, except, I mean, not things like blood loss and hypothermia. but the RLD, CHF, everything will remain the same. If it's a coincidental surgery and we are pushing you towards the questions for a sentinel axial block, we want you to know that one, the regional anesthesia, sentinel axial specifically, is technically challenging in these patients because there's a curve of the spine, there's a rotation of the spine. The spine normally rotates towards the opposite side of the convexity. Remember that. The vertebral space is narrowed. It is wider laterally towards the curve. Second, even if you do manage to insert your needle, the effect can be patchy, can be unpredictable. It can be confined to one particular side. The third concern is that if you decide to leave in epidural catheters, if at all it works and you do decide to leave it in, then the post-operative sensory and motor effects of your local anesthetic will impair you from diagnosing any neurological deficits. So these are the major challenges when you get a coincidental surgery. Of course, the airway concern, the positioning concerns are also going to remain. So that is all.
Thank you.
My pleasure. Thanks.
Thank you, Asha ma'am. And thank you, Dr. Sujali, for such a wonderful presentation. Now, please play the quiz. The first question was, identify this sign on the M mode of lung ultrasound. It is a seashore sign. The option is C. Next question, please. You anesthetize a patient for elective DC cardioversion of atrial fibrillation. Which of the following has the least influence on transthoracic electrical impedance? The answer of this question is the pedal position. This position has the least impedance. Least influence on the impedance. And the winner for this is Dr. Prabhat Ranjan, postgraduate student from Dr. ABVIMS and Dr. RML Hospital. Congratulations, Prabhat. Now proceeding to the further session, we have with us Dr. Rashesh Diwan, who will be chairing the next session. Sir is at the coordinator for the National Course Director, Indian Resuscitation Council of Federation. He is affiliated with he is a medical director, Raghudeep Eye Hospital, Ahmedabad. And his areas of interest are training in resuscitation and trauma. A warm welcome to you, sir.
Thank you so much, Nidhi. I'm so overwhelmed to be with all of you today in this session. And am I audible properly?
Yes, sir, you are audible.
Yeah, good, great. And shall I proceed with the two introduction of the speakers?
Sir, just do the first introduction now and then second one later.
Okay. To the participants and audience and listeners, let me tell you the topics selected for this session, which I'm fortunate to moderate, are wonderful topics for resuscitation and for emergency support to the unstable patients. And we have wonderful two very learned faculties with us. I would like to introduce first Dr. Sunil Kumar. If I keep on reading about his the affiliation and everything, I think I will take away his time. So let me tell you, he's a chief medical officer with the LN Hospital and in charge of the training of life support with Locknag Hospital. He's in charge of various kind of trainings, particularly involved with the American Heart Association's training programs also. And he's also reviewer of the Journal in Anesthesiology, Clinical Pharmacology since 2013. So almost 9 years now, General Secretary of Airway Management Foundation. He has over 300 courses on his name, where he has participated as chief instructors, particularly involving basic life support, advanced cardiac life support, and trauma courses. And most important, which appealed me the most was that he is innovative in teaching and training methods and methodology for various resuscitation programs. Dr. Sulin Kumar, thank you so much for joining with us. We'll have your presentation first, and then we'll have some question answers at the end.
Thank you very much, Team APPEC 2022, led by Dr. Mohandeep Kaur, for inviting me to this academic bonanza. I represent Team Life Support, and other key members of the team are Dr. Rakesh and Dr. S.D. Sharma. I'll be talking about the basics of ECG and few abnormalities which an anesthesiologist should know. Now, why as anesthesiologist should I know about the ECG? As I am required to evaluate the ECG during perioperative period, that's PAC, intra, post-op, or in the ICUs, or during the peri-resuscitative periods. Now, what to know in the ECG? The first and the most important thing is to differentiate whether it is normal or abnormal. And if abnormal, is it life-threatening abnormal? Right? If it is life-threatening abnormal, whether the rhythm is shockable or non-shockable. As the rhythm is shockable, we have to act immediately and proceed with giving the shock. Then we should also be able to differentiate and identify the various peri-arrest conditions. This also helps in the differential diagnosis with 5 H's and 5 T's. Abnormalities can be in the form of the rate, bradycardia, tachycardia, or premature complexes, which I'll come to them later. Rhythm, waves, segments, intervals, axes, and if we combine them together, this tells us about the arrhythmias, hypertrophy, coronary artery disease, and other things. First requirement is have a clear understanding of the normal. Now, what is an ECG? ECG is electrocardiogram, or the graphic display of the electrical activity of the heart, and the equipment used to measure this is known as electrocardiograph. Every area of the myocardium is a potential pacemaker. Normal pacemaker is the SA node situated in the right atrium, and the normal pacemaker activity is 60 to 100. Impulse starts from the SA node and reaches the via interatrial tracts to the AV node. If SA node fails to take over as a pacemaker, the AV node takes over as a pacemaker, and the pacemaker rate is 40 to 60. Then from the AV node, the impulse travels by the bundle of hairs and the Purkinje systems and spreads to whole of the myocardium. SA node fails to take over as a pacemaker, the AV node takes over the pacemaker, then the myocardium or Purkinje system takes over as a pacemaker, and the rate is 20 to 40. Now, how ECG is produced? If we correlate the different areas where the electrical activity is going in the heart with what is happening on the ECG paper, right? When the heart is completely depolarized, or there is no electrical conduction, there is a straight line, right? No discharge. Then as a node discharges and it gives rise to the P wave. The P wave has got two components. First component, we say this is the right atrial depolarization. The second is the left atrial depolarization. Now, after the artery is depolarized, the impulse has reached the AV junction. The speed of conduction in the AV junction is very less, so that even the electrodes on the surface are not able to pick up any line, right? It gives rise to the almost a straight line that is known as the PR segment. Then impulse from the AV junction goes via the bundle of hairs to the Purkinje system and gives rise to the QRS complex. Now, both of the ventricles are depolarized. After that, there's again electrical silence. And then ventricles are repolarized. And that gives rise to the T wave. Sometimes after the T wave, you see a small wave, positive wave, that is in the U wave, particularly if in patients with the heart rate is slow. This is because of the repolarization of the Purkinje system. Now there are different, on the ECG you see the waves, segments, complex and interval waves. Any positive or negative deflection from the isoelectric line is known as a wave. The wave are P, Q, R, S, T. What is segment? The isoelectric line between the waves is known as a segment, the PR and the ST segment. Combination of the waves is known as the complex, and complex in the ECG is QRS complex. Interval when we combine one wave and one segment, that is an interval. And on ECG normally you see the PR interval and the QT interval. Now if we see the ECG paper, there are big boxes and there are small boxes. This is a small box. Small box the size is 1 millimeter by 1 millimeter. On the x-axis it is a time, and the y-axis it is a voltage. The smallest square on the x-axis, right? This the x-axis, smallest square, that is time is equivalent to 0.04 seconds. And on the y-axis, the smallest square is, this is the one smallest square on the y-axis, is 0.1 millivolt. All right. Standard paper speed is 25 millimeter per second, and before we take the ECG, it is calibrated in such a way that 10 millimeter, this means two big squares on the y-axis, is equivalent to 1 millivolt. Now, how to calculate the rate? The smallest square is 0.04, right? If we take the 5 small squares, that is one big box represents 0.2 seconds. And 5 large square is equal to 1 second, right? So if we take 15 large squares, so they are going to be 3 seconds. So in the 3 seconds, or in the 15 large squares, you calculate the R waves and multiply by 20, that will give you the heart rate. If the big strip is not available, right? You see the big boxes between the two R waves. It's a very simple way to calculate the rate, because as an anesthesiologist, we're interested in bradycardia, tachycardia are normal. So if there are 3 to 5 big boxes in between the two R waves, the heart rate is normal. If it is less than 3, this is tachycardia. If it is more than 5, that is bradycardia. Now coming to the other components of the ECG. P wave. P wave, I said, it's due to the atrial depolarization. The normal duration is less than 0.12 seconds, that is 3 small squares. And the height is less than 2.5 millimeters. Again, you can say it is less than 3 small squares. It should be upright in all leads except AVR. Few abnormalities can be like when there is a right atrial hypertrophy. So what will happen? Is the first component of the P wave will be tall, right? Because the increased muscle mass. So this is tall peak, CAP pulmonale, commonly known as, best seen in the lead 2, 3, and AVF. If there is left atrial hypertrophy, it means the second component of the P wave, will be broad, and it gives rise to M-shaped P waves, right? So this is left atrial hypertrophy, this is right atrial hypertrophy. PR interval. PR interval represents the P wave and the PR segment, right? Normal duration is 0.1 to 0.2. Again, that is 3 to 5 small segments. If the PR interval is prolonged, there is something wrong in the AV junction. It can be short also. when the impulse bypasses the AV junction, because normally there is delay in the AV junction. If the impulse doesn't pass through the AV junction, right, the PR interval will be small. Like in WPW syndrome, it gives rise to a form of delta wave. Now, QRS complex, again, the three components, the Q wave represents the septal depolarization. That's a negative deflection before the R wave. Normally, it is less than small square wide or 0.04 second and less than 2 small squares deep, or it has to be less than 25% of the R wave. Large Q waves are present in the MI. R wave represents the ventricular depolarization, right? The size gradually increases from lead V1, chest lead V1 to V6. Now, S waves, again a negative wave after the R wave. It represents the depolarization of the base of ventricle. Its size decreases from as we move from V1, V2 to V5 and V6. Size of the S wave decreases. Now, QRS complex, it represents a complete ventricular depolarization. Normal duration is again less than 0.12 seconds. If it's less than 0.12 seconds, we call it a narrow QRS complex. If it's more than that, we call it a wide QRS complex. Wide QRS complex is seen in the bundle branch block, or in the ventricular region of the rhythm, or in the left ventricular hypertrophy. Now, coming to the bundle branch block. There are two types of bundle branch blocks normally, which we as an anesthesiologist should know: left bundle branch block and the right bundle branch block. Very easy way to diagnose the bundle branch block. The first and most important criteria is P wave has to be present. QRS duration is more than 0.12 seconds, right? Then if it's the left bundle branch block, if we see the V5, V6, small or absent in V1, V2, small or absent R waves followed by a deep and broad S waves. And we see V5 and V6, broad R dash pattern in V5 and V6 leads. Okay. So this is left bundle branch block. And right bundle branch block, again, P wave has to be present. Duration of the QRS complex more than 0.12 seconds, and R dash pattern in V1 and V2, right? And we see V5 and V6 is broad S wave, right? And duration is more than the R wave. So this is right bundle branch block. So very easy to diagnose. P wave has to be present. If P wave is present, QRS is wide. You look at V5 and V6. If it's R dash pattern in V5, V6, it is left bundle branch block. If it's R dash pattern in V1 and V2, it is right bundle branch block. Significance of this bundle branch block is if it's a new onset of the bundle branch block or the alternating bundle branch block. Alternating means first it was left and now it is the right or the vice versa. Then always consider the patient may be having ACS, acute coronary syndrome. In right ventricular hypertrophy, if we see V1 and V2, there's large R and small S wave. There's poor progression of the R wave from V1, V2 to V5 and V6. And this is right axis deviation. If it's a left ventricular hypertrophy, if we see V1 and V2, there are deep S waves, right? And if you combine the voltage V5, the R wave of V5 and S wave of V2, it is more than 35 millimeters. Along with it, there is left axis deviation. Then it is left ventricular hypertrophy. Now axis. Normal axis is down and to the left minus 30 to 90 degree. Very simple method of calculating the axis. You see the net deflection, the QRS in standard lead 1 and AVF. Okay, let's suppose this is the lead 1 and this is the AVF and this is the ECG. So in the lead 1, it is 5 to 7 positive. So we draw 1, 2, 3, 4, 5, 6, 7, right, on the positive side. If you lead AVF, it is negative 5, 5, 10 to 12. So if we say 1, 2, 3, 4, around this. So we draw this, join together. This is the axis of this ECG, right? So this is more than minus 30, less than minus 30, right? So this is left axis deviation. Right axis deviation is normal variance of the children, as you can see in the RVH, COPD, or WPW syndrome. Left axis is in the LVH, elevated diaphragm, or the inferior wall MI. Now coming to the ST segment. Ventricles are completely depolarized. It has not started the repolarization. Again, it gives rise to the electrical silence. That is the ST segment. As end of the S wave to the beginning of T wave. This is end of the S wave known as a J point. Right? Now, how do you recognize MI? MI, when there is more than 1 millimeter increase in 2 or more contiguous leads, that is the diagnosis of the MI, ECG diagnosis. Now, how you calculate the ST segment elevation? Right? We talk about the J point. J point is where the S wave ends and the ST segment starts. Now, what steps are? I identify the isoelectric line first, that's TP segment. Then identify the J point where the S wave ends and the T wave begins. Right? This is the J point. Add one small square more to it. Right? And mark this point. Mark this point. Then draw a line parallel to the isoelectric line at this level. Right? And calculate the millimeters in between these two lines. In this case, it is 4.5 millimeters. So 1, 2, 3, 4, 4.5 approximately. So 4.5 millimeters. Since one small segment is 0.1 millimeter. 1 millimeter, sorry. 4.5 millimeter. Right? So how do you localize AMI? In the lateral wall, the changes will be present in 1 AVL, V5, and V6. So the inferior wall MI, the changes will be in the lead 2, 3, and AVF. In septal, V1 and V2. In anterior, it is V3 and V4. Right? So this is how you localize the myocardial infarction. T wave. T wave is normally upright and the symmetrical. It represents the recovery phase, that is ventricular repolarization. It's always negative in AVR. Sometimes you can see the T wave negative in V3 and the AVN. It's normal variation. So probable causes of T waves are inversion are abnormal T waves are ischemia, infarction, ventricular hypertrophy, abnormal conduction, drugs, metabolic changes, etc. QT interval. QT interval is from when the ventricular depolarization has started, that is Q, to the end of T wave, where the ventricle has been completely repolarized. Duration normal is less than 0.44 seconds. Represents complete depolarization and repolarization of the ventricle, right? QT interval depends upon the heart rate. And this very complex formula of calculating the corrected QT, the QTC. Simple way we are to calculate the QTCs because we are only interested whether the QTC is prolonged or not. As increased QTC is, like this is, if you see the QT, 1 QT, you double the QT, right? So if you double the QT, it should fall between the two R waves. If you double the QT and it goes beyond the two R waves, that is prolonged QTC. It's a precursor of very life-threatening arrhythmia. Sometimes you must have heard in young patient, 28, 29, there is sudden cardiac arrest. Probably causes a ventricular fibrillation and they have a prolonged QTC. It runs in the genetics. The recommendation is if there's any sudden cardiac arrest in young patient, then the whole of the family, the ECG should be done to look for the prolonged QTC. So, what are the features of the hyperkalemia? We have talked about the H's and T's, right? Just remember the potassium sits under the tent of T waves. That means if the potassium is less, the tent will become flat. If the potassium is more, the height of the tent will increase. So with hypokalemia means the potassium is less, you see the broad flat T wave. You can see the U waves also. Acid depression, Q2 interval prolongation, that gives rise to the arrhythmia, right? A premature ventricular contraction, torsades, and fibrillation. In hyperkalemia, if the levels are from 5.5 to 6.5, you see the tall peak T waves, right? It's almost equivalent to the R wave. With 6.5 to 7.5, you see the loss of P waves, 7 to 8, widening of the QRS, 8 to 10, sine waves, ventricular arrhythmia, and asystole. So we have covered most of the things in the ECG. Now, what is the method of reading the ECG? The first step is check ECG standardization. Right? Paper speed 25 milliliter per second. Then calculate the rate, the rhythm. We'll be talking in detail little later. Then see the waves, segments, interval, see whether it is normal or the abnormal. Check for the axis, and on the basis of this, identify the various abnormalities in the ECG. Now we have seen a normal ECG. Now we discuss a normal ECG. We'll utilize this information in diagnosing few arrhythmias. Now, what is rhythm? Any regular recurring motion is known as the rhythm. For the heart, it is PQRST, PQRST. Okay? So any change from the normal sequence of electrical impulse is known as arrhythmia. Either heartbeat can be too fast, too slow, or it can be irregular. Rhythms can be lethal and non-lethal. Lethal means person is unresponsive, breathing absent, and there is some rhythm on the monitor, right? There's no lethal rhythms. Non-lethal rhythms, right? Non-lethal rhythm is non-cardiac arrest rhythms. Person is conscious and the pulses are present. Patient may be normal or abnormal, but pulses are present, and you see some rhythms on the monitor. Lethal rhythm can be shockable or ventricular fibrillation, pulses, ventricular tachycardia. Non-shockable are asystole and PA. In all the lethal rhythms, again, I'll repeat, person is unresponsive, pulse is absent, breathing absent, and you see something on the monitor. Non-cardiac arrest rhythm can be bradyarrhythmias, tachyarrhythmias, premature, or escape complexes. We talk about non-lethal rhythms because they can be present in the peri-arrest period, or they can be precursor to the cardiac arrest. Now, there are 5 steps in diagnosing a rhythm. The first step is you check the regularity, then rate, examine PQRS, measure the intervals, And based on this, identify the rhythm. Right? Regularity simple means is regular or irregular. Then we calculate the rate, bradycardia, tachycardia are normal. We examine the P wave. The first step is whether the P wave is present or not. If P wave is present, that means atria are being depolarized. Now, how the impulse reaches the atria? It can be either from the SA node, or there can be from the atria itself, from muscular mass of the atria, or it even can come from the AV junction. This is retrograde. Then relation of the P to QRS, is it 1:1? That means all the impulses are being transmitted to the ventricle. If not, it immediately tells us there is some block. Then morphology of the P wave. Are the P waves similar in shape? If they are similar in shape, it means they are arising from a single point. Then we measure the PR interval and the QRS interval, QRS complexes. Is it within a normal limit or not? Right? And based on this, we try to identify the rhythm. By following this system, an ACLS provider, anesthesiologist will be able to triage patient that needs immediate attention. But this system will not identify all the aberrations of the ECG. That's the job of the experts. Now, if we see this ECG, okay, we try to analyze the regularity. Is it regular? Yes, regular. The rate is regular. If we see how many big boxes are there between the two R waves, 1, 2, 3. It is between 3 to 5. That means it is normal. P wave is present. What is the ratio? 1:1. Morphology, good looking P waves. PR interval, again 3 to 5, right? 3 to 5. Normal. QRS less than 0.12 or less than 3 small segments, it is narrow. And the diagnosis is normal sinus rhythm. Why we say sinus? Because originating from the SA node following the normal conduction system, from SA node to the AV node and bundle of phase Purkinje system, right? And ventricular being depolarized. In this ECG, regularity, yes, regular. Rate, now rate is 1, 2, 3, 4, 5, 6. It is more than 5 big squares between the two RV. That means it is bradycardia. P waves present. Ratio 1:1. Morphology good, normal. PR interval normal. QRS narrow. The diagnosis is sinus bradycardia. Right. This we talk about the conduction system. From SA node, the impulse travels to the AV junction via interatrial tract. The speed of conduction in the interatrial tract is approximately 1000 millimeters per second. When the impulse reaches the AV junction or AV node, here the speed of conduction is very less. It is approximately 200 millimeters per second. Very slow. And from here, it goes to the bundle of waste and Purkinje system. Again, here the speed of conduction is very high. It is approximately 4000 millimeters per second. And as I said earlier, every area of the heart is a potential pacemaker. If any impulse starts from the myocardium, the speed of conduction in the myocardium is approximately 400 millimeters per second. Okay. So if we see this ECG, regularity, regular, yes. Rate, normal. P waves are present. The ratio, it is 1:1. Shape of the P wave, morphology of P wave, it looks good. PR interval. PR interval is prolonged. Normal is 3 to 5 small squares. So it is more than 5. QRS is narrow. So in this ECG, the abnormality is the PR interval is prolonged. And if the PR interval is prolonged, means that this problem at the AV junction. By convention, This is known as the first degree heart block. Although technically, because all the P waves are being conducted to the ventricle, technically this is not heart block by convention, but this is known as the first degree heart block. Causes can be, what is the blood, can you think what is the blood supply of the AV junction, the nerve supply of the AV junction? The blood supply is in the right coronary artery, and the nerve supply is vagus. So this can be present physiologically also in few persons like athletes where the vagal tone is strong. Right? So this can be normal variation. If we see this ECG, is it regular? Yes. Normal, prolonged, it is the same one. First degree heart block. Now if we see this ECG, regular? No. This is not regular. This is irregular. Rate. How we calculate rate when it is irregular? I said the 15 large scale, this is 3-second marker. Most of the ECG paper has got a 3-second marker. So this is 3 seconds, this is 3 seconds, which total of 6 seconds. In 6 seconds, how many R waves are there? 1, 2, 3, 4, 5, 6. There are 6 R waves, right? The rate is normal. P waves present. Ratio is not 1:1, but 1 P wave 1, 2, 3, 4, 5, 6, 7, 8. There are 8 P waves and 1, 2, 3, 4, 5, 6 R waves. So P waves are more than R waves. Morphology of P waves looks good. PR, there is no PR here, but the definition of the PR is P wave and from start of P wave to the start of QRS complex. There is no QRS complex, so no PR set, no PR interval. Absent PR interval, normal PR interval, prolonged PR interval, absent PR interval. So we can say the PR interval is variable. Somewhere it is present, somewhere it is normal, somewhere it is abnormal. QRS is narrow, right? So where is the problem in the conduction system? Can you tell me, or can you think? You can, of course, you cannot tell me. Problem is again at the AV junction, right? This type of the block is normally seen as there is right. There's some problem in the right artery, that's inferior wall MI, or if the vagal tone is strong, it can be the insecticide poisoning, right? And few drugs, beta blockers, calcium channel blockers can give rise to this type of the block. So if we see this ECG, is it regular? No. What is the rate? Rate normally when we talk is the ventricular rate. So again, this is 6 second straight. 1, 2, 3, 4, 5, 6. There are 6 R waves. The rate is normal. P waves present. Ratio not 1:1, right? More P waves than the R waves. Morphology of P wave is good. What was the PR interval? Normal. Absent, absent, normal, 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 absent. So we can say wherever the PR interval is there, it is normal, and in some places it is absent. QRS is narrow. This is known as second degree type 2 or Morbus type 2. Now, where is the problem in the conduction system? It is below the AV node, right? Because it's allowing few of the impulses to pass from here onwards, and few this is blocking. This is one of the serious blocks because below the AV junction, the nerve supply of the conduction system is by the left coronary artery. Now, how we differentiate between the type 1 and the type 2? The common features between the type 1 and the type 2, of course, the second degree, type 1 and type 2, the rate is irregular. P waves are more than R waves. Right? That's a common feature between second degree type 1 and type 2. Then we look at the PR interval. PR interval is variable in second degree type 1, and in second degree type 2, wherever the PR interval is there, it is constant. If we see this ECG, is it regular? Yes, regular. What is the rate? 1, 2, 3, 4, 5, more than 5. So this is bradycardia. P waves, they are present. Ratio, a little difficult. If we see ECG like this, what you do is take a piece of paper and mark two normal looking P waves, like this normal looking P wave, this normal looking P wave, right? You mark on the piece of paper. Then take the paper forward. You see there's increase in amplitude. The P wave is falling over here. The same distance the P wave is here. Then again increase in amplitude. P wave is falling here. Next is a P wave here, here. So 1, 2, 3, 4, 5, 6, 7, 8. There are 8 P waves and 1, 2, 3, 4, 5. There are 5 R waves. And you must notice PP is coming at a regular interval, RR is coming at a regular interval, and there is no correlation between the two. So this is complete heart block or third degree heart block. None of the impulse from the atria is being transmitted to the ventricle. If the patient is alive, pulses are present, then right, either the Purkinje system can take a bundle of his can take over as a pacemaker, right, or the myocardium can take over as a pacemaker. If the Purkinje system bundle of his takes over as a pacemaker, what will happen? What will be the QRS? QRS is going to be narrow because below this the speed of conduction is normal, 4,000 millimeter per second. If the myocardium takes over as a pacemaker, then QRS is going to be wide because the speed of conduction is very less. This is 400 millimeter per second. So QRS is wide. So these are two ECGs. In both the ECGs, PP is coming at a regular interval. RR is coming at a regular interval, right? There's no correlation between two, but in one ECG, QRS is small, another of QRS is wide. So this is originating from the bundle of his, and the myocardium has taken over as a pacemaker. Now, if these two patients come to you simultaneously together in the ECG, in the casualty, this patient has to be given priority. This patient is at a higher risk. Now we have seen 1, 2, 3, 4. 4 types of blocks. Second, the first degree heart block, that is truly speaking, that is not a heart block, is very easy to diagnose, only the PR interval is prolonged. In the rest of the 3 blocks, the common feature is P waves are more than R waves, right? So if the P waves are more than R waves, it can be either of the 3 blocks. Next step is look at RR interval. If RR interval is regular, it is straight away complete heart block. I'll repeat. If P waves are more than R waves, it can be either the 3 blocks. Next step is look at RR interval. If it's regular, it is complete heart block. If it is not regular, it can be second degree type 1 or second degree type 2. Then look at the PR interval. If the PR interval is constant everywhere, it is second degree type 2. If it is variable, then it is second degree type 1. Very easy to diagnose blocks. Condition is P waves have to be more than R waves. Look at RR interval, if regular, straight away complete heart block. If not regular, look at the PR interval. If the PR interval is constant at all the places, it's second degree type 2. If not, then it is second degree type 1. So we have covered almost all the bradyarrhythmias. if we look at this ECG, regularity, irregular, rate, tachycardia, P waves present, ratio 1:1. All right. Morphology of P waves. Different type of the P waves. There are different type of the P waves. It means they are originating from the different areas, but the QRS is narrow. So what is the diagnosis? So this is tachycardia. Agreed? Is it sinus tachycardia? No, because the shape of the P waves are different. So from where the P waves are coming? P waves are upright. They are coming from the different areas of the atria. Right? If they are coming from different, so diagnosis is multifocal atrial tachycardia. Right? Definition is 3 or more P waves that differ in polarity, shape, and size. Now, what happens in ventricular fibrillation? In ventricular fibrillation, there are different areas in both the ventricle, both the atrium. I'm sorry, atrial fibrillation. In both the area, both the atrium, there are different areas which are simultaneously discharging at a very high rate. With the net result, there is no effective atrial depolarization. Definite diagnosis of the atrial fibrillation is irregular heart rate with no definitive P wave, but you can see some activity on the baseline. Right? These are the fibrillatory waves. Sometimes the rate is so high there's almost a straight line. Diagnosis is irregular, narrow QRS complex, no definitive P wave. It is always an atrial fibrillation. Right? Now what happens in flutter? Flutter is there is single focus which is discharging at a high rate. Right? With the net result, it produces some waves, some definitive waves on the baseline. There is no isoelectric line because the rate is very high. This is atrial flutter. So if we cover all QRS complexes, you see this pattern on the baseline. This is known as sawtooth appearance. The reason is because there is single focus discharging at a high rate. This is irregular, no definitive P wave, right? This is atrial fibrillation. This is flutter. This is again irregular, narrow QRS, no definitive P wave. So this is fibrillation and this is flutter. Easy to diagnose. And this ECG, this is regular, rate more than 100, 1, 2.5, so less than 3, that is tachycardia. P waves present, ratio 1:1. PR is normal, QRS narrow. Diagnosis is sinus tachycardia. If we see this ECG, regularity, yes, regular. The rate, tachycardia. P waves, absent. PR interval, cannot make out. So there is no P wave, you are not able to make out any P wave, so no PR interval, but the QRS is narrow. So what is this? This is tachycardia, yes. Is it ventricular tachycardia? No, because the QRS is narrow. Is it atrial tachycardia? No, there's no P wave. It is sinus tachycardia? No, because there's no P wave. So what it is? A convention, we call it is a supraventricular tachycardia, right? As nodal tachycardia. Okay, we'll leave this. So how you differentiate between the sinus tachycardia and the supraventricular tachycardia is, in the sinus tachycardia, there's a, you should be able to clearly demarcate the P wave. In SVT, there's no P wave. Now, if we see this ECG, is it regular? Yes. Rate? Okay, bradycardia. P waves present. Ratio 1:1. Now morphology. You see, these are the inverted P waves. Right? PR interval. Normal PR interval was 3 to 5. So this is less than 3. It is 2.5 segments. So PR interval is small. QRS narrow. So from where this rhythm is originating? The P waves are negative. It means atria being depolarized in a retro way, right? Impulse from AV junction is going to the atria. That is producing the P wave. So this is junctional rhythm, right? So pacemaker activity of the junction is 40 to 60. This is approximately 50. The junctional rhythm. And junction is a big structure, right? If we divide the junction into 3 areas, upper, middle, and lower. If the upper portion takes over as a pacemaker, then ECG will be like this. PR interval is small because it has to travel a very small distance. If middle portion takes over as a pacemaker, right? Middle portion takes maker, the P wave will be merged with the QRS. There is no P wave. How you will differentiate this from the atrial fibrillation? In this also there is no P wave, but it is regular. In atrial fibrillation, it was irregular. Or even you can see the P wave after the QRS if the lower portion of the junction takes over. So all the 3 are the junctional rhythms. P wave can be present, but it will be inverted before the QRS or after the QRS. Or P wave is going to be merged with the QRS, right? Now, what are the premature complexes? Premature complex is when a complex, any complex, ECG complex comes earlier when it was expected, right? This is a premature complex. And what is escape? Escape is when it comes later than when it was expected. So premature complexes, escape complexes can arise from the atrium, it can be from the junction, or it can be from the ventricle, right? We see that. If it's coming from the atria, there is going to be P wave. But P wave is going to be abnormal and upright, right? If it's coming from the junction, P wave can be either absent or P wave can be present, but it's always going to be inverted. If it's coming from the ventricle, the QRS is going to be wide because the speed of conduction on the muscle mass is 400 millimeter per second. So it's wide QRS complex. So if it's this complex, this ECG, this is coming early. So this is premature atrial complex. This one, no P wave. So this is junctional, premature junctional. And this is premature ventricle complex. So if the complex is coming early, that means it is premature complex. If P wave is present and upright, then it is premature atrial complex. If there is no P wave, inverted P wave before or after the narrow QRS complex, it is premature junctional complex. And no P wave in front of the wide QRS complex, it is a premature ventricular complex. Now these 2 are the premature ventricular complexes. They are almost similar in shape. So this is means arising from a single area, unifocal. The different type of the P waves, the QRS complexes. It means they are originating from the different areas. So this is multifocal premature ventricular complexes. When alternating complex is premature ventricular complex, this is known as ventricular bigeminy. If every third is a premature complex, ventricular complex, it's known as ventricular trigeminy and so on. Bigeminy, trigeminy, quadrigeminy, and so on. If two premature complexes come together, ventricular premature complex I'm talking about, this is known as couplet. If the three come together, three premature ventricular complexes come together, is known as triplet. Now, if three or more premature ventricular complexes come together and the rate is more than 100, it is known as a run of VTAC, run of ventricular tachycardia. Right? So if you see this ECG, it's irregular, rate tachycardia, P wave we are not able to see, PR interval none, QRS complex wide, right? More than 3, this is run of VTAC, and all looks like it is almost the same. This is monomorphic ventricular tachycardia, right? We'll leave this 15 and 15. Okay. If they are a similar shape, ventricular similar shape QRS complexes, this is monomorphic. If they are a variable shape, it is polymorphic ventricular tachycardia. If we are not able to make out anything, this is total chaos on the baseline, right? No P wave, no QRS complex, nothing, just some electrical disturbances. This is ventricular fibrillation. The treatment is shock, but before you do the shock, there are certain terms and conditions. Person has to be unresponsive, pulse is absent, breathing absent. If you see this rhythm on the monitor, only then give the shock. So this is ventricular fibrillation. Right? If the SA node has taken over, failed as a pacemaker, the AV node has failed as a pacemaker, the Purkinje system has failed as a pacemaker, then the myocardium takes over as a pacemaker. The rate is 140, regular, QRS wide and disorder. This is idioventricular rhythm. Asystole, there is a straight line on the monitor and you check the all protocols. No electrical activity. Or it's less than 6 per minute. This is asystole. This is TCP pacemaker rhythm. I will leave it. So, as a healthcare provider, you should be able to diagnose the lethal rhythms immediately. You should not waste time, and if required, give the electrical treatment immediately. Now, again, coming back to suggested method for reading ECG, standardization and rate. Now we know the rhythm. See for the waves and intervals. Check for the axis, and on basis of this, identify the arrhythmias. Plan and monitor the management. Remember, ECG simply measures changes in voltage over time. Right? Knowledge of normal and abnormal ECG allows identification of the variation in the ECG and helps the anesthesiologist to manage the clinical condition of the patient. Thank you.
Thank you so much, Dr. Sunil Arora. Very elaborately, you explained how to interpret an ECG. And most important is that I know you are very much involved with the resuscitation and various resuscitation guidelines. Everybody is aware that whether it's an Indian Resuscitation Council Federation or an American guidelines or any of the international guidelines, the training is more focus and emphasis is on the identification of the ECG reader and interpretation. And most important is to prevent the cardiac arrest. For that, you need to identify the unstable patient and life-threatening rhythm. You very elaborately helped us, educated us to diagnose the ECG pattern. The lesson is, if you diagnose and if you are very knowledgeable with the theory, you can make your strategy in 15-20 seconds, identifying the life-threatening rhythm and manage so that you can prevent the cardiac arrest. Very well done. I don't see any question in the question answers box, but Nidhi, do we have time or I generate the question?
So there is as such no question in the chat box. You can ask if you want, sir.
Okay. The question, as an anesthetist, I have seen many times in young individuals with ASF1 with no cardiac element or history, a junctional rhythm on the ECG. Not very frequently, but few times I have seen. And the P wave suddenly disappears. and just you are watching in another minute or 1 minute and a half, gradually the P wave separates out from the ECG. This is what I have very frequently seen during anesthesia, and there is no history. So can you elaborate that if you can, if you wish to, or we'll go to the next. That's a very frequent benign junctional rhythm I have seen.
Yes, sir, that do happens. And exact reason is not known why it happens. But as far as the patient condition is stable, we don't have to do anything.
Yeah, we don't do anything. And second is about the various kinds of blocks you narrated, particularly second degree type 1, type 2. One of them is life-threatening. Can you elaborate particularly maybe type 2 or 1?
Yes, second degree type 2 because the ischemia is below the AV junction.
Yes.
Even the major portion of the ventricle is also involved, supplied by the left coronary artery. So
Correct.
we have to really, as you rightly said, nowadays the trend is early diagnosis and suspect which patient are at the high risk and which patient can go into cardiac arrest or complete heart block.
Yeah, suppose you find it in the pre-operative assessment, you need to work with that, particularly if it is an elective procedure. That could be a dangerous patient for us on during anesthesia.
That's a dangerous block.
Yes, that's a dangerous block. That's what I wanted you to reinforce. Not many participants are there. Nidhi, we can go for the next lecture. Thank you so much, Dr. Sunil Arora. Very, very rightly you elaborated the ECG understanding. Probably I thought I learned a lot from your lecture. Thank you so much for a wonderful.
Thank you, sir. Thank you very much.
And now the next young speaker we have is Dr. Jyoti Gupta from Kolkata. She is a specialist grade person with the Chittaranjan National Cancer Institute, Kolkata, West Bengal. And her special interest is in onco anesthesia, regional anesthesia, and palliative care. I do not want to waste our time, but the important message, probably what I foresee is we learn the diagnosing life-threatening rhythms from Dr. Sunil Arora's lecture. Now she's going to highlight us how to manage those life-threatening conditions to prevent the cardiac arrest. Dr. Jyoti, over to you.
Good afternoon, everyone. My name is Dr. Jyoti Gupta, and today I'll discuss antiarrhythmic drugs. Antiarrhythmic drugs are divided into 4 classes. Class 1 is sodium channel blocker. Class 2 are beta blockers. Class 3 is potassium channel blocker. And class 4 are the calcium channel blocker. But there are several pitfalls to this classification, as some drugs do not fall into any class. And some drugs do fall into more than one class. And the use of the class does not define by the classification. In one class, 2 drugs can be used for 2 different arrhythmias. First, we'll discuss amiodarone. Amiodarone is a class 3 antiarrhythmics. It's a potassium channel blocker, and it acts on the phase 3. It prolongs the phase 3 of the cardiac action potential. It slows the conduction rate and prolongs the refractory period of the SA node and the AV node. It also acts on sodium channel, calcium channel, and beta receptors. Its onset of action varies after one dose. It's 1 to 30 minutes. The oral dose, after the oral dose, the onset of action is 2 to 3 days. And the therapeutic effect lasts for 1 to 3 hours after a single IV dose. 96% of the drug is protein bound, and it is eliminated primarily by the liver. The terminal half-life of the drug also varies from 9 to 100 days if the patient is taking on a chronic basis. And after one single dose, the half-life varies for 3 to 80 hours. It is available in IV preparations and the oral preparations. Among IV preparation, the most common preparation is 150 mg ampule available, most commonly in our OTs and ICUs. Vials available in the market are 150 mg, 450 mg, and 900 mg vials. The IV preparation contains polysorbate 80 and benzyl alcohol. 100 mg and 200 mg tablet are also available in the market. In stable ventricular tachycardia, we can give 150 mg IV bolus over 10 minutes and can be repeated after 10 minutes of 150 mg IV bolus. After the bolus dose, 1 mg per minute IV infusion should be started for first 6 hours. Then the dose is reduced to 0.5 mg per minute for next 18 hours. The total dose in 24 hours should not exceed more than 2.2 grams. According to the ACLS guideline, in ventricular fibrillation or pulseless ventricular tachycardia, if the patient is not responding to the cardioversion, then after the third shock delivery, we can use amiodarone. In amiodarone, we have to give 300 mg IV or IO push as a first dose, and the second dose can be delivered at 150 mg IV or IO push. If the patient have hemodynamically stable ventricular arrhythmias, we can also use oral tablets. It's 800 to 1600 mg orally OD for 1 to 3 weeks until response is there, and then the dose is gradually tapered off to the maintenance dose of 200 to 400 mg orally. In pediatric patient for pulseless ventricular tachycardia or ventricular fibrillation, we can give 5 mg per kg IV or IO rapid bolus, not exceeding more than 300 mg, and can be repeated twice to a maximum of 15 mg per kg during the acute treatment. In supraventricular tachycardia, 5 mg per kg IV should be given over 1 hour initially and should be followed by 5 mg per kg per day for the next 47 hours. In atrial fibrillation, 600 800 mg per day in divided doses until a total of 10 grams has been given. And we can also give higher initial dosing or IV dosing if the patient is hemodynamically unstable. And the maintenance dose is 200 mg per day. It is recommended to start dosing at a lower end of the dosing range because the elderly patient may be predisposed to the toxicity. Amiodarone should be diluted in 5% dextrose and should be given using 0.22 micron filter to prevent precipitate from reaching the patient. For infusion of longer than 1 hour, the concentration of 2 mg per ml should not be exceeded unless there is a central venous catheter in place. Amiodarone has numerous side effects, especially if it is taken on a chronic basis. Hypotension is one of the most common side effects, and it is also present if the patient is taking on acute basis, along with bradycardia, CHF, heart arrest, sinus node dysfunction, flushing, QT interval prolongation. Pulmonary toxicity, pulmonary inflammation, or fibrosis are also found if the patient is taking amiodarone on a chronic basis. Along with that, ARDS, bronchospasm, interstitial pneumonitis, severe respiratory complications, apnea. Corneal microdeposits are found in up to 90% of the patients if the patient is taking amiodarone for more than 6 months. Along with some patients have visual disturbances, optic neuropathy, and neuritis. Nausea, constipation, abdominal pain, abnormal salivation are GI complaints. The structure of amiodarone is similar to the thyroxine and it also contains iodine. So sometimes in patient it causes hypothyroidism as per Wolff-Chalkes effect, and in some patient it also called hyperthyroidism based on Jod-Bezdo phenomena. It also increases the liver enzyme but rarely causes jaundice, hepatomegaly, and hepatitis. It also causes light sensitive blue discoloration of the skin, sometimes called ceruloderma. These patients should avoid exposure to the sun and should always use sunscreen. The condition can improve upon cessation, but the skin will not come to the normal levels. Other complications are peripheral neuropathies, epididymitis, and gynecomastia. The drug is contraindicated if it is a known hypersensitivity, the patient of cardiogenic shock, prolonged QT interval, sinus bradycardia, second or third degree AV block, and should be avoided in pregnant and breastfeeding individuals. Amidron is a potent inhibitor of the hepatic and renal metabolism of several drugs. It inhibits metabolism through several cytochrome P450 pathways. So it interacts with a lot of drugs and hamper their metabolism. So I have listed many of the drugs which whose metabolism are inhibited by the amidron, among which we have to take special consideration for digoxin and warfarin. Digoxin dose is halved when used along with amidron, as it elevates the digoxin plasma concentration level. It also hampers the metabolism of warfarin, of both the enantiomer of warfarin. So warfarin dose should be decreased if the patient is taking amidron on a chronic basis. Now coming to adenosine. Adenosine is an organic compound. It is an endogenous purine nucleoside. It is a class 5 antiarrhythmic agent. And thus the adenine molecule is attached to the ribose, and it does not act on any of the sodium channel or calcium channel or potassium channel. It acts on adrenoreceptors. There are three types of adrenoreceptor: A1, A2, and AB. A2 is further divided into A2A and A2B. So it mediates via the A1 receptors, which inhibit the adenyl cyclase. So it decreases the CAMP, which causes increase in the efflux of potassium via inward rectifier potassium channel, and it inhibits the calcium current. Adenosine also cause vasodilatation, but it causes vasodilatation in only the normal arteries, not in the arteries where atherosclerosis is present. So that's why in some patients it causes coronary steal phenomena. It has a very short half-life, less than 10 seconds, and it is predominantly eliminated in the urine as uric acid. Adenosine metabolism convert into two components: adenosine monophosphate and inosine. Adenosine monophosphates are converted to ATP and consumed, and inosine is further converted to uric acid and excreted in urine. IV preparations available in the market are 3 mg per ml preparations are available with 1 ml or 2 ml ampule. Sometimes there is vial available of 4 ml and 10 ml. In supraventricular tachycardia or paroxysmal supraventricular tachycardia, it is used especially with the re-entrant Walsh-Parkinson-White syndrome, in which we give bolus dose of 6 mg, which slows the AV nodal conduction. Second repeat dose can be given after 1 to 2 mg, and the second dose is higher dose, that is 12 mg. It causes transient AV block and cardiovert and abnormal rhythm. It is also used in stress testing as an adjunct. The dosage is 0.14 mg per kg per minute, and it is administered for 4 to 6 minutes. It also acts as an anti-inflammatory agent, so dermatologists use as a topical agent. Adenosine dose should be reduced by half in case of congestive heart failure, myocardial infarction, shock, hypoxia, chronic liver disease or chronic kidney disease, and elderly patients. Most of its side effects are because of its vasodilatory properties, cause flushing, headache, chest pressure, shortness of breath, nausea, rapid arterial hypertension, coronary vascular steal, and undesirable AV block. It is contraindicated in second or third degree AV block, sinus node disease like sixth sinus syndrome or symptomatic bradycardia, and known hypersensitivity to adenosine. It is also contraindicated in asthmatic patients. Dipyridamole potentiates the action of adenosine, and methylxanthine act as competitive antagonists of adenosine and can blunt its pharmacological effect. So, higher dose of adenosine is required in patient taking methylxanthine. Beta blockers. Beta blockers acts on the beta receptor of the adrenoreceptors, beta 1, beta 2. Beta blockers are class 2 antiarrhythmics. Beta blockers can be both cardioselective or non-selective. Cardioselective means they act on only beta 1 receptors. Non-selective, they act on both beta 1 and beta 2 receptor. Beta 2 receptor blocker can cause vasoconstriction. So that's why they are non-selective. And beta 1 receptors only acts on heart. So that's why they are cardioselective. They are the competitive antagonists to the beta receptor and indirectly prevent calcium entry into the myocardial cells. It decreases the slope of phase 4. So slows the conduction velocity, slow automaticity of SA node and prolongs the refractory period. So briefly, we'll discuss some of the beta blockers. These beta blockers are used as an antiarrhythmics. Metoprolol is a cardioselective beta blocker and most commonly used for atrial fibrillation and flutter. It also causes suppression of pre-atrial contraction and pre-ventricular contraction. It also suppresses the ventricular tachycardia. Other uses of metoprolol are stable angina, acute coronary syndrome, post-MI patient, and it is a second line of drug for heart failure patient. Esmolol is available in IV preparation only. It is also a cardioselective beta blocker. It is used in rate control for atrial fibrillation and atrial flutter and in acute supraventricular tachycardia. It has a very short half-life, so we can use for the acute treatment only. We also use esmolol during intra hypertension and stress response. Acebutolol and are the true drugs with the intrinsic sympathomimetic activity. So they are the partial agonists to the beta receptors also. So these drugs are used where the beta blocker indications are limited by its side effects. But it causes inappropriate sinus tachycardia because it also causes vasodilatation. Atenolol, propranolol, carvedilol, and labetalol, they do not have any antiarrhythmic action, but they are the beta blockers which are used for many other things like stable angina, hypertension, tremor, migraine, hyperthyroidism, and heart failure. The side effects of beta blockers for the cardiac side effects are sinus bradycardia, hypotension, AV block, heart failure exacerbation, and transient withdrawal syndrome. Extracardiac side effects are bronchospasm. It causes severe bronchospasm and should be contraindicated in asthmatic patient. Depression, sexual dysfunction, fatigue, hypoglycemia unawareness, and hyperkalemia. The contraindication of beta blockers are asthma, severe hypotension, severe bradycardia, AV block, second degree or third degree, acute CHF, severe AV sclerosis, referred allergy to the drug, and hyperkalemia. Sotalol is one of the most common antiarrhythmic drugs. It is a non-selective competitive beta blocker. It has class 3 antiarrhythmic activities. So it also acts as a potassium channel blocker. It blocks the beta receptors, and because of the both beta receptors and the potassium channel, it leads to the dearth in the production of cyclic adenosine monophosphate. So it slows down the heart rate and decreases the inotropic state of the heart. So eventually leading to decreasing the force of contraction and potentially stroke volume. It is used in ventricular tachycardia with a dose of 100 mg or 1.5 mg per kg over 5 minutes. In hemodynamically stable patient of ventricular fibrillation and flutter, we can start oral dose of 80 mg BD and can be increased 3 to 4 times. Preparation available in the market can be oral or IV. Among oral, 80 mg, 40 mg and 160 mg tablets are available. In IV preparation, 150 mg per 10 ml vial is available. Side effects of sotalol are bradycardia, chest pain, palpitation, dorsity points, syncope, heart failure. It also causes fatigue, dizziness, lightheadedness, headache, dyspnea, asthma, nausea, vomiting, appetite disorder. It can cause rash. On chronic use, it can cause myopathies, extreme pain and back pain, also weight gain. It can cause vision problem also on chronic basis. Contraindication of sotalol is sinus bradycardia, sick sinus syndrome, second or third degree AV block without if the patient is not on pacemaker. Congenital or acquired long QT syndromes if the QT interval is more than 450 milliseconds. Cardiogenic shock, decompensated heart failure, hypokalemia and hypomagnesemia. Whenever you start giving sotalol to the patient, we should always check potassium and magnesium level because it causes severe hypokalemia and hypomagnesemia. Bronchial asthma or related bronchospastic condition, and then known hypersensitivity to the drug. Thank you so much, everyone.
Jyoti, very nicely, 3 emergency medicines drugs you described very well. You're lucky you have a couple of questions in the chat box. Dr. Pankaj has asked a question. How the dose of adenosine dependent on IV source?
Actually, sir, as I have already mentioned that adenosine has a very short half-life. So whenever they give adenosine, we try to give proximal to the heart, but preferably the more proximal it is, the better will be. And we attach a previous stopcock and we attach 1 syringe containing adenosine in a one outlet and the 10 ml bolus or 20 ml bolus to the flush. And the moment we give, we raise the hand so that adenosine should reach the heart early as possible. If the IV line we have, it's peripheral or distal, then the higher dose may be required because it will take more 10 seconds or more than 10 seconds to reach the heart. So higher dose can be required if the line is there.
Yeah, that explains that the half-life is very, very short in seconds. In fact, it's not even a minute. So yes. We need to be giving by simultaneously with the 3-way stopcock, pushing 20 ml saline together. If it is a central line, then it serves the purpose. If you are doing through the central line, and then only simple 10 ml flush can work. That happens in ICU. Everybody's knowledge, adenosine is, she very rightly mentioned that it cardio words mainly working at the AV level, right?
Yes.
Now, it sometimes, if you have experienced it, patient can collapse in that particular 10 seconds, and you should be ready with the resuscitation. They recover very fast, but say sometimes I've seen they collapse, they lose the responsiveness, and you should be ready with the resuscitation. Actually, we call it a chemical cardio version when we use adenosine. One question I have for you. You mentioned you add polysorbate 80 with amiodarone. Why the commercial people, pharmaceutical people add these two amiodarone solution, the commercially available solution?
Sir, actually polysorbate 80 acts as an emulsifier to dilute the amiodarone in an aqueous solution. If we don't use polysorbate 80, then the shelf life of amiodarone is very short. But to increase the shelf life, we use polysorbate. But polysorbate itself has its own side effect. It causes low BP, low blood pressure, hypertension, along with amiodarone. So sometimes the preparations are available without polysorbate also.
That's the common question people ask in our courses, that you recommend so much of amiodarone, but it is cause of hypertension. So why you use particularly when you are recovering from the cardiac arrest? So that's why I raised this point. And how much time, Nidhi, we have? I think we have run out of time. Few minutes.
We still have time. If you want to discuss, we can discuss.
Okay. Dr. Pankaj has put another question. Of course, dopamine was not in a part of the lecture, but should dopamine to be given for low urine output? Would you like to answer? Or?
That is a controversial question, I think. Some people do say, yes, we use dopamine in low urine output patient in a very low dose, like 2 to 3 mites per kg per minute. But some anesthetists, I don't think so, use the low dose dopamine. So it is a controversial question, sir.
Yeah, actually, particularly when you have low urine output and normal kidneys and stable patients, probably fluid challenge is the first thing we try
Yes,
with
sir.
250 ml saline or so. And if the perfusion pressure is lower, so the hemodynamically unstable patient will try to maintain the perfusion pressure. Probably these two things, if you do it with the dopamine, will help more than presuming that dopamine has an action by increasing. It's a false sense of security, I personally believe. I mean that another category of anesthesiologists you mentioned.
Yes, sir.
Anyway, no more questions. Anything, Nidhi, you need to ask? I don't think
Nice,
there are
sir.
only 4
Well-
participants. So there may not be many questions. Most of them are the panelists. So you can go for the next session. We are just in time.
Thank you, sir, for chairing the session.
Thank
And
you so
thank
much.
you, Jyoti, for such a nice presentation.
Thank you so much, ma'am. Thank you, sir.
Internet connection. Now I welcome Dr. Anu Kapoor to chair the next session. Ma'am is the medical superintendent of Hindu Rao Hospital and North Delhi Medical College, New Delhi. Her areas of interest are airway, pediatric anesthesia, disaster management, emergency medicine, intensive care, and recently the new evolved COVID-19. Welcome to you, ma'am.
Thank you, Nidhi. So we now come with the fag end of today's session, which deals with BLS, ACLS guidelines and the IRC guidelines. So the first speaker today we have is Dr. Sangeeta Yadav. She is an associate professor at RMN Hospital and Atal Bihari Vajpayee Institute of Medical Sciences. Her main areas of interest are pediatric and obstetric anesthesia, trauma, and resuscitation. So over to Sangeeta for her talk.
Thank you, ma'am. Good evening, respected chairperson and delegates. Today I will discuss about BLS 2020 AHA guideline in adults, AED, and briefly about Indian Resuscitation Council IRC guidelines. So why BLS is important to us? Because despite important advances in prevention, sudden cardiac arrest remains a leading cause of death in many countries. About half of cardiac arrests are unwitnessed. Outcome from out-of-hospital cardiac arrest remains poor. Only about 10% of adult patients with non-traumatic cardiac arrest who are treated by EMS survive to hospital discharge. Therefore, the main focus in adult cardiac arrest events include rapid recognition, prompt provision of CPR, early defibrillation of malignant shockable rhythms, and post-return of spontaneous circulation supportive care and treatment of underlying causes. So what is chain of survival? The chain of survival shows the actions that must take place to give the cardiac arrest victim the best chance of survival. Each link is independent yet connected to the link before and after. If any link is broken, the chance of a good outcome decreases. This is in hospital cardiac arrest chain of survival, and this is out of hospital cardiac arrest chain of survival. Both constitute of 6 links. In in-hospital cardiac arrest, first link is early recognition and prevention, activation of emergency response system, high-quality CPR, and early defibrillation. This will constitute BLS. Post-cardiac arrest care and recovery will come in ACLS. In out-of-hospital cardiac arrest, first link is activation of emergency response system, then high quality CPR, early defibrillation, advanced resuscitation. Again, these come in the ACLS. This is the BLS algorithm 2020. and we will discuss in detail each step in further slides. So the first step in managing cardiac arrest victim is verify scene safety. The scene should be safe for both victim and the rescuer. So the first step in managing the cardiac arrest victim is to ensure safety of both the victim and the rescuer. The victims may be found in various scenarios, but you must be vigilant and observe whether the place is safe to resuscitate the victim or not. If the place is not safe, you might get injured during resuscitation. You should immediately start BLS if the victim is in an indoor place like gym, mall, restaurant, etc., which are safe for resuscitation. However, in scenarios where you might be at risk, like road traffic accident, you can shift the patient to footpath or make a human chain. Other scenarios where you might be at risk, like fire, electrocution, drowning, you can take the help of others, like local people, police, fire brigade personnel, or lifeguard, to shift the victim from the place of danger to a safe place. In fire, you should wait for fire to be put out and victim to be brought out to a safe place. In electric current accident, you must wait for mains to be switched off and victim to be placed in a safe place. In snow, you must remove the victim to a warm, dry place and remove his wet clothes first. Whenever possible, take whatever personal protections at the site. This may include the use of barriers like handkerchief, plastic packets, and gloves. In hospital, you should use mask, gloves, gown. So after verifying the scene safety, second step in algorithm is check for responsiveness, shout for nearby help, activate emergency response system via mobile if appropriate, get AED and emergency equipments. This we will discuss in detail in further slides. So once the victim is at safe place, immediately check for responsiveness. Face the victim and tap his shoulder and shout, "Are you okay?" in a language that victim is likely to understand. If victim is responsive, he will answer, move or moan. If not responsive, shout for nearby help to activate emergency medical system. And if you are alone, you can activate EMS via mobile phone. While checking responsiveness, do not approach victim from back. Don't shake victim hard because it may increase a possible cervical spine injury. So when the victim is unresponsive, you should immediately activate emergency response system. In out of hospital cardiac arrest, you can dial 102, 108, even 100 number. In hospital cardiac arrest, you can activate a specific hospital code or a rapid response team can be activated. Give all available details regarding victim, location, and ask them to bring AED and emergency equipment. This is very important. Don't put down phone till they ask you to do so. So third step in algorithm is look for no breathing or only gasping and check pulse simultaneously. Is pulse definitely felt within 10 seconds? Briefly about the pulse check and breathing. Pulse check and breathing should be assessed simultaneously within 5 to 10 seconds. Check for breathing by scanning the victim's chest for rise and fall. Agonal gasps are not normal breathing. They are the signs of cardiac arrest. How to check carotid pulse? Locate the trachea on the side closest to you using 2 or 3 fingers. Slide these 2 or 3 fingers into the groove between the trachea and the muscles at the side of the neck. And we should feel for the pulse for at least 5 but not more than 10 seconds. and 1 second is 1001. If no pulse, begin CPR starting with the chest compression. So we covered the algorithm till the third step. On the third step, when we are look for breathing and simultaneously pulse check, there can be three situations. If there is a normal breathing and pulse is felt, then we should monitor the patient until emergency responders arrive. If there is no normal breathing but pulse is present, then we should provide only the rescue breathing, 1 breath every 6 seconds or 10 breaths per minute. And we should check pulse every 2 minutes. If no pulse, start CPR immediately. If possible, opioid overdose, administer naloxone if available as per protocol. So when we'll assess the respiration and pulse simultaneously, the third situation can be there can be no breathing or only gasping and no pulse is felt. In that situation, immediately start CPR, perform 30 compression and 2 breaths in 30:2 ratio and use AED as soon as it is available. So very briefly about high quality chest compression. You should position victim on a firm flat surface. Example floor, backboard. Compression to ventilation ratio should be 30:2. Compression rate is 100 to 120 per minute. Compression depth should be 5 to 6 centimeter. Allow chest to recoil after each compression. It allows the blood to flow into the heart. This is very important. And interruption in chest compression should be minimal. It should be less than 10 seconds. So we have to push hard and push fast. For effective chest compression, arms should be straight, elbows locked, shoulders should be directly over your hands. Place your heel of one hand in the center of the victim's chest on the lower half of the sternum and other hand on the top of the first, so that hands are overlapped and parallel. Pressure should be applied through heels only. Fingers should be free of chest wall. Rhythmic application of compression should be there. Avoid pressing xiphoid process. Entire upper body weight is used to apply force. Avoid leaning on chest during relaxation. So after 30 compression, we have to give 2 breaths. For breaths to be effective, the victim's airway must be open. 2 methods for opening the airway are head tilt, chin lift and jaw thrust. In an unconscious patient, there will be upper airway obstruction by the tongue, which always has a tendency to fall backward. This will cause airway obstruction. By head tilt, chin lift maneuver, we will open this open airway. For this, place one hand on victim's forehead and push with your palm to tilt the head back. Place the finger of other hand under the bony part of the lower jaw near the chin. Lift the jaw to bring the chin forward. Head tilt stretches the anterior neck muscles. Lift tongue away from the posterior pharyngeal wall and epiglottis away from laryngeal inlet. Chin lift stretches the structures more and pulls mandible and tongue forward. If neck injury suspected, give jaw thrust. If jaw thrust fails, we can give head tilt. When we suspect cervical spine injury, jaw thrust should be used. Jaw thrust should be used without head extension. In this, position yourself at victim's head. Place one hand on each side of victim head. Place your fingers under the angle of victim's lower jaw and lift with both hands, displacing the jaw forward. If victim lips close, push the lower lip with your thumb to open the lips. Breaths can be given by mouth-to-mouth rescue breathing, mouth-to-barrier device like pocket mask, or with a bag and mask. Deliver each breath over 1 second. Give sufficient tidal volume to produce visible chest rise. Avoid excessive ventilation and use compression to ventilation ratio of 30:2, 30 compression and 2 breath. Barrier device for giving breaths are pocket mask and bag and mask devices. For mouth-to-mask breaths, we can use pocket mask. Pocket mask usually have a one-way valve that diverts exhaled air, blood, or bodily fluid away from the rescuer. The one-way valve allows the rescuer's breath to enter the victim's mouth and nose and diverts the victim's exhaled air away from the rescuer. They are available in different sizes. For use, place yourself at the victim's side. Place the pocket mask on the victim's face using the bridge of the nose as a guide for correct positioning. Seal the pocket mask against the face. Use your hand that is closer to the top of the victim head. Place your index and thumb along the top edge of the mask. Place the thumb of your other hand along the bottom edge of the mask. Place the remaining fingers of your second hand along the bony margin of the jaw and lift the jaw. And deliver each breath over 1 second, enough to make the victim's chest rise. We can use bag and mask device if available to provide positive pressure ventilation to a victim who is either not breathing or not breathing normally. The device consists of a bag attached to the face mask. This is a self-inflating bag attached to the face mask, and it can be used with or without oxygen. Face masks are available in a variety of sizes. For proper fit, the mask should extend from the bridge of the nose to just above the lower edge of the chin. It should cover the nose and mouth and make sure the mask does not apply the pressure to eyes. To use, position yourself directly above the victim's head. Place the mask on victim's face using the bridge of the nose as a guide for correct positioning. Use E and C clamp technique to hold the mask in place while you lift the jaw to hold the airway open. Squeeze the bag to give breaths while watching for the chest rise. Deliver one breath over 1 second. So we should perform these cycles of 30:2 ratio, 30 compression and 2 breaths until AED arrive. As soon as AED is available, we should check the rhythm, whether it is shockable or non-shockable. If rhythm is shockable, give one shock, resume CPR immediately for 2 minutes. We should continue CPR until ALS provider takes over or victim starts to move. If rhythm is non-shockable, resume CPR immediately for 2 minutes. We should continue CPR until ALS provider takes over or victim starts to move. Let's discuss very briefly about AED or defibrillator. AED is automated external defibrillator. In recent guidelines, emphasis is given on early defibrillation because it increases the chances of survival from cardiac arrest that is caused by an abnormal or irregular heart rhythm. The AED identify abnormal heart rhythm as shockable or non-shockable. Shockable rhythms are treated with defibrillation. The shock stops the abnormal rhythm. This resets the heart electrical system so as a normal heart rhythm can return. AED is a lightweight portable computerized device that can identify an abnormal heart rhythm and analyze whether shock is required and deliver the shock if required. So what are the steps for operating an AED? Open the carrying case of AED, power on the AED, follow AED prompt as a guide to next step, attach AED pad to the victim's bare chest. If AED advises a shock, it will let you to clear victim and then deliver a shock. Loudly state clear victim message and look to be sure. Even oxygen should be kept a certain distance away. Press shock button. If no shock is needed, immediately resume CPR starting with chest compressions. Most common position of pad is anterolateral, one directly below the right collarbone, other pad to the side of the left nipple with the top edge of 7 to 8 centimeter below the armpit. Other position can be anteroposterior. Place one AED pad on the left side of the chest between victim's left side of the breastbone and left nipple, and place other pad on the left side of the victim's back next to the spine. Few special scenario for AED to be kept in mind are implanted defibrillator or pacemaker. Do not apply AED pad directly over these implanted devices because they may block the delivery of shock to heart. If there is a transdermal medication patch, do not apply AED pad directly over these medication patch. We should remove these patch and wipe the area before AED pad attachment. We should switch the provider if available about every 2 minutes to avoid fatigue. Healthcare provider continue effective chest compressions or CPR until return of spontaneous circulation, arrival of advanced team, rescuer is exhausted. Let's discuss about choking. So what is choking? Choking is foreign body in airway leading to airway obstruction. It can be mild airway obstruction or severe airway obstruction. In mild airway obstruction, there will be good air exchange and patient can cough forcefully. While in severe airway obstruction, the victim will clutch the throat with the thumb and finger like this, and this is known as the universal choking sign. He may be unable to speak or cry. There may be poor or no air exchange. Cough can be weak, ineffective, or no cough. There can be high-pitched noise while inhaling or no noise. There can be increased respiratory difficulty or bluish discoloration of lips or skin because of cyanosis. These are all the signs of severe airway obstruction. So how to relieve choking in responsive adult or child? By giving abdominal thrust or chest thrust. Chest thrust are given in pregnant and obese victim. So how to relieve choking in responsive victim? Stand behind the choking victim. Wrap your arms around the victim waist. Place the fist of one hand in the middle of the victim's abdomen above the navel. Hold your fist with the other hand and exert pressure into the victim's belly up towards his chest. And we should continue this maneuver till the obstruction is relieved. And when the obstruction is relieved, monitor the victim, and this maneuver is known as Heimlich maneuver. How to relieve choking in an unconscious victim? Shout for help. If help available, activate EMS. If alone, activate EMS after 2 minutes of CPR. Lower the victim to ground. Begin CPR starting with the chest compressions. No pulse check. Look inside in mouth each time when airway is opened for the breath for visible foreign body. Few words about IRC. IRC is Indian Resuscitation Council. They give BCLS guideline. BCLS is Basic Cardiopulmonary Life Support. It is an algorithmic structured plan for management of victims of cardiopulmonary arrest outside the hospital. It will be applicable to trained medics and paramedics who are present at or called to the site of casualty. The optimal outcome of a victim with cardiopulmonary arrest will depend on the core links of early recognition and activation, early high-quality cardiopulmonary resuscitation, early defibrillation, and early transfer to a medical facility. BCLS also emphasizes on the quality check of various steps of resuscitation. These are the 4 core links in adult BCLS. First is early recognition and activation of EMS. Second is early high quality CPR. Third is early defibrillation. And fourth is early transfer. This is the BCLS algorithm. It is same as AHA BLS algorithm with a few differences which we will discuss in the next slide. Few differences are in BCLS there is a 4 core links, while in BLS there is a 6 links in chain of survival. In BCLS, 1 breath is given in 5 seconds with pulse, while in BLS, 1 breath is given in 6 seconds. The compression rate is 120 per minute in BCLS, while in BLS it is 100 to 120 per minute. Method to identify the site of chest compression is different in BCLS. For this, palpate the lower border of the rib and trace it to the middle of the rib cage, the Ziffy sternum. Put 2 fingers of one hand on Ziffy sternum and the heel of the other hand next to the 2 fingers over the sternum. This is the point of chest compression. While in BLS, it is the lower half of the sternum in middle of the chest. For pulse check in BCLS, first we have to locate the thyroid cartilage or Adam's apple in front and middle of the neck with 2 fingers, and slide these fingers laterally in the groove between the trachea and neck muscle to feel the carotid pulse. In BLS, pulse check can be done with the 2 or 3 fingers in between the trachea and the neck muscles. So let's quickly revise our BLS steps. First step is the verify scene safety. The patient with the electric current, switch off the main, shift the patient to the side. Check for responsiveness by tapping on the shoulder and say loudly, "Are you okay?" If the patient is unresponsive, immediately activate EMS by dialing 102 or 108. After the simultaneous assessment of the pulse and breathing, carotid pulse should be checked within 5 to 10 seconds. And simultaneously, we have to assess for abnormal or no breathing. If there is no pulse or there is no breathing or abnormal breathing, immediately start chest compression. 30 compression should given. 30 compression and 2 ventilation should be given. 2 rescue breaths should be given, 1 breath over 1 second. And while giving breath, we should look for visible chest rise. After giving 2 breaths, immediately start chest compression 30 chest compression. So this cycle should be continued 30:2 ratio till AED arrives. Whenever AED arrives, switch on the AED, attach the pads, and this is important. While attaching the pad, chest compression should be continued. When AED analyzing the rhythm, we should leave the victim. If it is a shockable rhythm, we'll give shock. So we should not touch the victim at 2 points: when AED analyzing the rhythm and when shock is being given. Immediately after giving shock in shockable rhythm, we should resume CPR starting with the chest compression. Thank you.
Dr. Sangeeta, there are quite a few questions for you in the chat box.
Yes, ma'am.
So can we take them up right now? How
Yes,
to give
ma'am.
CPR in a chest trauma patient?
Yes.
Dr. Jagrati would like to know that. How to give CPR in a chest trauma patient?
Yes, ma'am. The CPR in chest trauma patient will be different from the normal patient because the main causes of arrest, they are the reversible, like hypovolemia, hypoxia, tension pneumothorax. So immediately we have to give the attention on the reversible causes of arrest. First correct these, then we can continue our BLS. But priority should be given other signs.
Okay, the next question is how to give breaths in a cervical spine injury patient. This
Yes,
is asked by
cervical spine
Shruti.
Yes, ma'am. In cervical spine injury, as I have told in my PPT also, we should give jaw thrust only. We should ventilate the patient by giving jaw thrust. If it fails, then we can give head tilt. But primarily, we'll do the jaw thrust.
And maybe what about the manual inline stabilization?
Yes, ma'am. With manual inline stabilization, we should first do that. If it fails, then we'll give head tilt. But we can give, it's not an absolute contraindication.
Yeah. And Another question for you is how to operate an AED if there is a pacemaker in situ.
Yes, if this also I've covered in my PPT. If the patient is having a pacemaker, we should avoid directly putting the pad on the pacemaker. It should be away from the pacemaker.
I think that's all the questions that they are, and we can now go on to the next speaker.
Yes, ma'am.
Next speaker is Dr. Jyoti Singh. She is an associate professor at RML Hospital and Atal Bihari Vajpayee Institute of Medical Sciences. Her special interests are pediatric and obstetric anesthesia, trauma, and resuscitation. So over to Jyoti for your talk, please.
Thank you, ma'am.
Hello everyone, you were learning about the basic life support till now. My presentation will deal with advanced life support. What is advanced cardiac life support? It is the continuation of basic life support, and basic life support is the base for advanced cardiac life support. If combination of both the basic life support and advanced cardiac life support in an organized manner is given to the patient, then good results are expected. And advanced cardiac life support is the systemic approach to assessment and management of cardiopulmonary emergencies. It is the resuscitation effort aimed at restoring spontaneous circulation and retaining intact neurological functions. ACLS guidelines were first published in 1974 by the American Heart Association, and they were updated every 5 years, and the latest update was in 2020. These are the Advanced Cardiac Life Support American Heart Association guidelines for in-hospital cardiac arrest and outside hospital cardiac arrest. This is the new link, the recovery link, which is added for the in-hospital cardiac arrest and outside hospital cardiac arrest in 2020 guidelines. In hospital cardiac arrest, chain of survival says that there should be early recognition and try to prevent the cause for cardiac arrest. Then activation of emergency response system is done. Then high quality CPR is given to the patient, and defibrillation is attached and shock is delivered if the rhythm is shockable and shock is required. Then if the patient returns to the spontaneous circulation, then the post-cardiac arrest care is given to the patient, and this is the recovery link which is newly added to the chain. And if the arrest is taking place outside the hospital, then activation of emergency response system is done, high quality CPR is given, and defibrillation is done with the AED, and advanced resuscitation is done in the ambulance. If the ambulance is having advanced cardiac life support in it, then post cardiac arrest care is provided to the patient, and this is the recovery phase which is newly added to this link also. This is the circular algorithm of adult cardiac arrest, indicates that the process of cardiac life support is continuous and should not be interrupted in between. While doing the chest compression, monitoring of quality of CPR is done, rhythm assessment is done, drug therapy is given, and advanced airway is considered, and treatment of reversible causes are done simultaneously. The reversible causes for adult cardiac arrest are 5H and 5Ts. 5H are hypovolemia, hypoxemia, hydrogen ion, acidosis, hypo or hyperkalemia, hypothermia. Tension, and Ts are tension pneumothorax, cardiac tamponade, toxins, pulmonary or coronary thrombosis. Now we come to the detailed cardiac arrest algorithm of adult. As soon as you receive a patient who is not responsive and pulse is absent, you immediately start the chest compressions. The chest compression should be of good quality. You should push hard and fast, and minimum interruption should be there in between the compressions, and you should avoid excessive ventilation and change compressor every 2 minutes or earlier if the compressor is fatigued, and the quality of compressions are assessed with a capnography. If the CO2 levels are decreasing, then you should reassess your quality of compression and try to improve that. And while giving the compressions, you should give oxygen to the patient, attach monitor and defibrillator, and assess the rhythm, if the rhythm is shockable or not. First, we will see when the rhythm is shockable, what should be done. When the rhythm is shockable, you should deliver a shock to the patient with a defibrillator, which can be biphasic or monophasic. With a biphasic defibrillator, you give the initial dose of 120 to 200 joules or whatever is recommended by the manufacturer. And with a monophasic defibrillator, you deliver 360 joules and continue with your chest compressions. And while giving the chest compressions, you look for the intravenous or intraosseous excess. Intraosseous is considered when intravenous excess is not found. And reassess the rhythm if it is shockable or non-shockable. If the rhythm is shockable, this time while doing the chest compressions, you give epinephrine 1 mg every 4 minutes to the patient, and you should consider for the advanced airway. And capnography is done to assess the quality of chest compressions. And again assess the rhythm if it is shockable or non-shockable after 2 minutes of chest compression. Yes, if it is shockable, then you should deliver a shock to the patient, and this time you give amiodarone, the first dose of 300 mg bolus and the second dose of 150 mg bolus or lignocaine 1 to 1.5 mg per kg. And then you reassess the rhythm. If it is shockable, then again you deliver a shock and epinephrine 1 mg every 4 minutes is given. Then compressions are done for 2 minutes. Then again the rhythm is assessed. If it is shockable, then shock is delivered and amiodarone second dose is given 150 mg, and this process is continued. But if any time in between the rhythm becomes non-shockable, then you should start compressions and continue with your compressions, chest compressions, and give epinephrine 1 mg every 3 to 5 minutes and try to treat the cause for cardiac arrest. What should be done when the rhythm is non-shockable? If the rhythm is non-shockable, give epinephrine as soon as possible and continue with your chest compressions. While doing the chest compressions, look for IV or intraosseous access and give epinephrine every 4 minutes to the patient. And advanced airways should be considered in the patient, and capnography monitoring is done. And after 2 minutes of chest compression, reassessment of the rhythm is done, if it is shockable or non-shockable. If again it is non-shockable, then chest compressions are continued and try to find out the cause for cardiac arrest. And if it is reversible, try to reverse the cause for cardiac arrest. Then after 2 minutes, reassess the rhythm if it is shockable or non-shockable. And if it is again non-shockable this time and no signs of return of spontaneous circulation is seen, then continue with CPR and consider appropriateness of continued resuscitation. But if the return of spontaneous circulation is seen, then post-cardiac arrest care is delivered to the patient. At any time in between, if the rhythm becomes shockable, then you should deliver the shock to the patient and restart the chest compressions again. This is the new algorithm of cardiac arrest in pregnant patients, which is added in 2020 update of American Heart Association Advanced Cardiac Life Support Guidelines. It shows that BLS and ACLS should be continued, which is high quality CPR with relief of aortocaval compression through left lateral uterine replacement is done. Defibrillation when indicated is done, and other ACLS interventions are also done, like epinephrine. Then you should assemble maternal cardiac arrest team. which includes obstetrician, neonatologist, emergency people, anesthesiologist, intensive care team, and cardiac arrest team. And then you should consider the etiology of arrest. In pregnant patients, the arrest can be due to anesthetic complications, bleeding, cardiovascular complications, any allergy to the drugs, or some emboli, maybe fever or general non-obstetric causes. We have already seen the 5H and 5Ts. And hypertension can also be a cause of cardiac arrest in pregnant patients. So we should try to find out the cause and try to treat them. And we should perform the maternal interventions and the obstetric interventions in a pregnant patient. In maternal interventions, perform airway management, administer 100% oxygen, and we should avoid excessive ventilation. You should place a IV above diaphragm, and if the patient is receiving IV magnesium, stop and give calcium chloride or gluconate. And you should continue with your basic life support and advanced cardiac life support in the patient, which I have already told. The high quality CPR, defibrillation is given, and the other interventions of advanced cardiac life support is also given to the patient. In performing the obstetric interventions, you should provide continuous lateral uterine displacement to the patient and detach fetal monitors. Prepare for perimortem cesarean delivery. If no return of spontaneous circulation in 5 minutes is seen, then consider immediate perimortem cesarean delivery and deliver the neonate to the neonatal team. This is also a new algorithm added to 2020 guidelines of AHA, which is opioid-associated emergencies. If you suspect a patient with opioid poisoning, you should check for responsiveness, shout for nearby help, activate the emergency response system, and get naloxone and an AED if available. Standard resuscitation measures should take priority over naloxone administration with focus on high quality CPR. So you assess the patient. Is the person breathing normally or not? Yes, the suspected person for opioid poisoning is breathing normally. Then you should try to prevent further deterioration of the person. Tap and shout, open the airway and reposition the person. Consider naloxone. Transport the patient to the hospital and keep assessing for the patient for normal breathing and responsiveness. And at any point of time the patients become unresponsive, then you should follow your ACLS and BLS guidelines. But if the suspected opioid poisoning person is not breathing normally, then you assess the pulse. It should be assessed within 10 seconds. And if the pulse is present, then support ventilation is given to the patient and naloxone is also given to the patient. But if no pulse is there in the patient, then immediately follow your ACLS and BLS guidelines. What should be done when the adult is having a bradyarrhythmia? So you should assess appropriateness for clinical conditions, and if heart rate is typically less than 50 per minute and bradyarrhythmia is there, then identify and treat underlying cause of bradyarrhythmia. And you should maintain patent airway and assist breathing if necessary, and oxygen is given to the patient if the patient is hypoxemic, and cardiac monitors are attached to identify the rhythm, and blood pressure monitoring is done and oximetry is done. IV access is taken and 12 lead ECG is done if it is available, but don't delay the therapy for 12 lead ECG, and consider possible hypoxemic and toxicologic causes and try to treat them. If persistence of bradyarrhythmias causing hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, acute heart failure, Then you should give first dose bolus of atropine of 1 mg, and you should repeat every 4 minutes, and maximum dose of 3 mg atropine is given to the patient. But if the atropine is ineffective, then transcutaneous pacing is done or dopamine infusion is given 5 to 20 micrograms per kg per minute, and if patient recovers, then titrate to the responsiveness and taper slowly. Or you can give epinephrine 2 to 10 micrograms per minute and titrate to the patient's response. And then you should consider for expert consultation and transvenous pacing. But if these signs are not present, then you should monitor and observe the patient if any further deterioration is taking place. If patient is having tachyarrhythmias, then assess appropriateness for clinical condition, and if the heart rate is typically more than 150 per minute and tachyarrhythmias are present, then identify and treat the underlying cause for tachyarrhythmias, and try to maintain patent airway and assist breathing of the patient if it is necessary. Oxygen is given if the patient is hypoxemic, and cardiac monitors are attached to identify the rhythm, and blood pressure monitoring is also done. IV access is taken and 12 lead ECG is done if it is available. And if the persistent tachyarrhythmia is causing hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, acute heart rate, heart failure, then synchronized cardioversion is considered and sedation is given, and adenosine is also considered for the treatment. If it is refractory, then underlying cause is considered and need to increase energy level for next cardioversion. An addition of antiarrhythmic drugs is done and expert consultation is taken. But persistent tachyarrhythmia is not causing any of these signs and symptoms, then wide QRS complex is there. We have to see if it is more than or equal to 0.12 seconds. Yes, if it is there, then consider adenosine only if regular and monomorphic, antiarrhythmic infusion, then expert consultation is taken. And if refractory, then consider for underlying cause and need to increase energy levels of cardioversion, and addition of antiarrhythmic drugs is done and expert consultation is taken. But if no wide QRS, then vagal maneuvers are done. If regular, then adenosine is also given. If the rhythm is regular, then beta blocker or calcium channel blockers can be given and consider for an expert opinion. Now we come to the adult post-cardiac arrest care algorithm. So when we see the return of spontaneous circulation, which means blood pressure and pulse are recordable, and there is increase in EtCO2 equal to or more than 40 mmHg seen, and waveforms of arterial BP seen if arterial catheter is in situ, then we should manage airway. Early placement of endotracheal tube is considered, and respiratory parameters are managed, in which we start 10 breaths per minute, and SpO2 is maintained between 92 to 98%, and PaCO2 is kept between 35 to 45 mmHg. Then hemodynamic parameters are managed. Systolic blood pressure is kept at more than 90 mmHg, and mean arterial pressure is kept at more than 65 mmHg. And 12 lead ECG is done in the initial stabilization phase of post-cardiac arrest care algorithm. In continued management of a patient of post-cardiac arrest care, we should consider for emergent cardiac interventions if stem 1 present, unstable cardiogenic shock is assessed if it is there, mechanical circulatory support is given if it is required. Then we assess the patient if patient follows commands or not. If patient follows command and the patient is awake, other critical care management is done. And if patient is not following the command, then targeted temperature management is given to the patient. We obtain a brain CT, EEG monitoring is done for the patient, and other critical care management is done for the patient. We evaluate and treat rapidly reversible etiologies and involve expert consultation for continued management of the patient. When should advanced cardiac life support resuscitation should be terminated? So when arrest not witnessed, no bystander CPR is given, and no return of spontaneous circulation before transport of the patient to the hospital is seen, and no shock was delivered before transport. Then if all criteria are present, all these, then consider termination of the resuscitation. If any criteria are missing, continue resuscitation and transport the patient to the hospital. This is the neuroprognostication chart added new to the 2020 guidelines. In neuroprognostication, supportive care and serial neurological evaluation is done within 72 hours after cardiac arrest. Why we are doing this neuroprognostication? So it is done to assess whether patient might regain meaningful consciousness or not. There are various structural and functional tests which are done in neuroprognostication, and structural test involves the CT and MRI, while the functional test involves the somatosensory evoked potentials, the EEG, the serum NSE, the neuron specific analysis, and certain clinical examinations. Functional tests are more specific, but they can be altered due to some founders present like hypothermia, benzodiazepines, and opioids. Here is a quick review. What is new in 2020 AHA ACLS guidelines? The sixth link in the chain of survival is added. Re-emphasis on early initiation of CPR is done. Enhanced algorithms and visual aids are there in the new guidelines, and emphasis is on early epinephrine, and IV access is preferred over intraosseous access, and return of spontaneous circulation, emphasis on optimum oxygenation and blood pressure is given. And there is a new link which is added, the recovery link in the chain of survival, which is support and assessment of cognitive, physical, and psychological needs. And neuroprognostication diagram is added in the new guidelines. And debriefing of hospital and lay rescuers is done in the new guidelines, and new algorithms which we have discussed, the pregnancy algorithm and the opioid associated emergency algorithms are added in the new AHA guidelines. These are some differences between 2015 and 2020 AHA ACLS guidelines. In 2015, one breath was given every 5 to 6 seconds when we were ventilating a patient with bag and mask device, and one breath every 6 seconds with advanced airway. But in 2020 guidelines, one breath every 6 seconds with or without advanced airway was given. In bradycardia, in 2015, atropine dose was 0.5 mg and dopamine was 2 to 20 micrograms per kg per minute. But in 2020 guidelines, atropine dose is changed to 1 mg and dopamine is 5 to 20 micrograms per kg per minute. In tachycardia, in synchronized cardioversion, if the patient was having narrow QRS complex regular rhythm, then 50 to 100 joules was given. With narrow QRS complex irregular rhythm, 120 to 200 joules was given. And if the patient is having wide QRS complex regular rhythm, 100 joules was given. And wide QRS complex irregular rhythm defibrillation dose was not synchronized. But in 2020 guidelines, it is recommended to follow specific level of energy as recommended by device. And if white QRS complex irregular rhythm, defibrillation dose is not synchronized. Post-cardiac arrest care, titrate oxygen saturation to 94% or more. In 2020, it is said titrate oxygen saturation to 92 to 98%. In adult chain of survival, 5 links in both in-hospital cardiac arrest and outside hospital cardiac arrest was there in 2015, and in 2020, 6 links in both in-hospital and outside hospital cardiac arrest is there, and the recovery link is the 6th link which is added to the chain of survival. In 2015, IV and intraosseous access both were equal, but in 2020 guidelines, IV access is preferred over intraosseous access. Indian Resuscitation Council developed the new guidelines of CCLS, the Comprehensive Cardiopulmonary Life Support. These guidelines were developed considering the need for a universally acceptable practice guidelines for India. The Indian Resuscitation Council became an official member of European Resuscitation Council in 2020. Of the CCLS consists the 5 links. The first is early recognition and management of pre-arrest condition, then early recognition and activation of code blue, then early high quality CPR is recommended and early defibrillation is recommended. And the 5th link is early comprehensive life support and post-resuscitation care is provided to the patient. This is the CCLS algorithm showing when you see a patient who is not responsive or fainted, then you should ensure a safe place and shift the patient to a safe place. You should be safe and the patient should be safe. Then check for the response, tap on the shoulders from front and ask loudly, "Hello, are you all right?" If the patient is responsive, then monitor the patient and assess the cause and manage. And if the patient is not responsive, activate code blue and local team is informed, get defibrillator and crash card and check breathing while palpating carotid pulse, and this is performed within 5 to 10 seconds. If normal breathing with definite carotid pulse is present, then keep on assessing the patient every 2 minutes and assess the cause and try to manage it. And abnormal or no breathing with definite carotid pulse is present, then provide 1 breath every 5 seconds using bag mask ventilation and reassess every 2 minutes. Assess cause and manage. And if the normal breathing with definite carotid pulse returns, then keep on reassessing the patient every 2 minutes and try to treat the cause. If abnormal or no breathing without definite carotid pulse is present, then start cycle of 30 chest compressions and 2 breaths. 5 cycles of 30 chest compressions and 2 breaths is given. Then you should check carotid pulse with it should be done within 5 to 10 seconds. If pulse is absent, you continue with the 5 cycles of 30 chest compressions and 2 breaths. If the pulse returns, pulse is present, and if the abnormal or no breathing with definite carotid pulse is there, then you should again provide 1 breath every 5 seconds using bag mask ventilation and keep on assessing the patient and try to treat the cause. Now your defibrillator is available. So we attach the defibrillator to the patient and the rhythm is analyzed. While attaching the pads, don't stop chest compressions. And while analyzing the rhythm, don't touch the patient. And if the rhythm is shockable, one shock with defibrillation start with 120 joules and escalate to 200 joules. And if AED is available, then it selects the shock by itself. If the rhythm is non-shockable, then shock is not given and CPR is resumed. 5 cycles of 30 chest compressions and 2 breaths are given, and we should ensure high quality CPR. Simultaneously, during cycles of CPR, ensure the following. The venous access and airway and drugs are given. IV or intraosseous access is taken. It is recommended in the CCLS that 3 attempts of IV access is taken, but if it is not possible, then intraosseous access is considered. And definitive airway is considered, and 1 mg of adrenaline is given and repeat every 3 to 5 minutes. Antiarrhythmics are given for VT and VF. Amiodarone 300 mg IV bolus is given as a first dose, and second dose of 150 mg is given, and reversible causes are sorted out and treated. And if patient revives with signs of circulation, then post resuscitation care is given to the patient. These are some differences between the ACLS guidelines by American Heart Association and the CCLS guidelines by Indian Resuscitation Council. ACLS guidelines recommend 100 to 120 chest compressions per minute, while CCLS guidelines recommend 100 chest compressions per minute. Depth is 5 centimeters according to ACLS guidelines, and CCLS guidelines recommend depth 5 to 6 centimeters. Pulse check is same for the ACLS and CCLS guidelines, 5 to 10 seconds. And breath in ACLS guidelines is given 1 breath every 6 seconds, while in CCLS guidelines 1 breath every 5 seconds is given. IV is preferred over intraosseous access according to the ACLS guidelines. CCLS guidelines recommend 3 attempts of IV access. If it is not possible, then intraosseous access is taken. Saturation is kept between 92 to 98% in ACLS guidelines. In CCLS, saturation is kept 95% or more. Temperature according to the ACLS guidelines is 32 to 36 degrees Celsius, and according to the CCLS guidelines, temperature should not be more than 36 degrees Celsius. In adult chain of survival, there are 6 links in ACLS guidelines, while in CCLS guidelines, there are 5 links in chain of survival. These are some of my references. Thank you.
Thank you, Dr. Jyoti, for covering it up so well. And your charts where you brought in the differences between the 2015 and 2020 guidelines and the ACLS guidelines and IRC guidelines are very good, because this is something that all PGs, whether it's MD or DNB, they're always asked, whether it's in a table viva or it's in a theory question, they can't clear their exam without this very important topic. You've covered it very well. Now, there were a few questions for Dr. Sangeeta which have been answered in your lecture, and Sangeeta has answered it herself also, about CPR in pregnancy. Anything else you want to add on to that? Either of the two?
Yes, ma'am, there is a question. Is there any time limit for resuscitation? So, ma'am, there is no definitive time limit for the resuscitation, but there are some conditions in which we should stop the resuscitation.
You brought it out in your lecture.
Yes, ma'am, like return of spontaneous circulation, ma'am. Then if the compressor is fatigued or the final help arrives, or ma'am, in the condition of rigor mortis. If patient achieves the rigor mortis, then resuscitation process should be stopped, ma'am.
Another question which normally is asked is any limit of shocks? He wants to answer, or should I clarify? Carry on.
Ma'am, I think mine is same key, like same for the resuscitation, like when we are stopping it, when rigor mortis is there, then shock should also be stopped in the same conditions.
There is no limit for the for the number of shocks that can be given.
Yes.
A lot of people have this concept that there's a number of limit. There's no limit for the number of shocks that can be given. Talking about the maternal collapse and CPR, there's a very important role of perimortem cesarean. And I must
ma'am.
emphasize that we have managed to save at least 2-3 patients by performing perimortem cesarean immediately. And because at that stage is the maternal life which is more important. The fetal rights start after the delivery, but we were lucky that most of the kids also survived. So it gives a very good outcome, and it's very helpful in taking care of it helps in the CPR and resuscitation of a mother.
Yes, ma'am.
And I think Dr. Diwan wants to say something.
Thank you so much, Dr. Anu Kapoor. I was just very much interested in this situation, so I was very keenly listening what the lectures were wonderfully done. About the point which was raised before the last question was stopping the resuscitation. If you are in hospital and doing in comprehensive care, and if you have an ECG which shows electrical activity, you should continue resuscitation. There's no limit for the defibrillation. There's no limit for adrenaline and amiodarone and anything. But by that time, you always find out the reversible cause of cardiac arrest and try to treat the cause of the cardiac arrest. So, but stopping sometimes in an individual where either we write do not resuscitate, we don't do, as well as in ICU, sometimes we have to take a social decision rather than based on science. Suppose there is a straight line, we have to convince the family members, we take confidence of them, and then we can discontinue the resuscitation. But if you scientifically, logically, ethically, if you find any electrical activity still going on, it could be pulseless electrical activity, you should not discontinue resuscitation.
Yeah, when you get a straight line, another way of doing
Yeah,
is
then
increase
you
the
have
gain. Increase
Yes.
the gain to see whether it's actually a straight line or there is some little bit of electrical activity.
That's right.
That's
There is
something
always
you
a
must-
straight line protocol for this.
Yeah.
Connections and everything.
Can I add, ma'am, a small little thing?
Please.
Good evening, ma'am. At this hospital only, we have revived a patient with around 2 hours of resuscitation. The rhythm was always VF, VT, and we keep on doing the resuscitation. So after 2 hours, we revived one patient.
If I tell my experience in 2002 during the riots in Gujarat, we had a BSF fellow just on the border of our hospital collapsed. We immediately pulled him in. He had cardiac arrest. We resuscitated for almost 80 minutes and almost 22 defibrillations done. We revived him, put on all the support, shifted to the UN Meta cardiology unit. We did the PAMI. This man survived and walked off the hospital after 18 days. So we should not lose hope till you find the electrical activity. That is what I wanted to end. 2 hours is quite a good period. It's an example you are setting.
And another
Unless
thing
you are
which-
fully tired or you don't want to get a cardiac yourself. Then it's
Yes.
a different issue. Then it is not safety. Safety comes in
Another
the
thing
picture.
which I want to emphasize in your presentation, Dr. Jyoti, was in your in-hospital resuscitation.
Yes,
The
ma'am.
role of the team the team leader and each member, it should be very clear. The instruction should be very clear and loud. They should be repeated by the person who is going to follow the orders. It should
Yes.
again be repeated when the orders have been followed, so that there's no confusion in anybody's mind. You know, that closed loop communication is very important.
Yes, ma'am.
So I think, Akhilesh, you want to add something? This is one of your pet topics also.
One little thing, as ma'am has said, that there is a closed loop communication. And when we talk about closed loop communication, there are 4 links to it. One is you repeat whatever is said. Suppose we give 1 mg epinephrine diluted in 10 ml normosaline followed by 20 ml push. So a person repeats, okay, giving 1 mg epinephrine diluted in so and so. Then once the procedure is done, it is again told that, okay, this procedure is done and 1 mg epinephrine is given. So
Yep.
here it completes the loop.
Yes.
True. And the person who documented writes also the order.
There has to be a record keeper also.
Yeah.
Everything has to be documented
That's-
with time.
He completes the team.
Yes. If there are no more questions, I think we can hand it over to the organizers now. Maybe.
Thank you, ma'am.
Thank you, ma'am. Thank you, sir.
Thank you, ma'am, for chairing the session, and thank you, Dr. Jyoti and Sangeeta, for clearing our doubts and covering such an important topic for us. It was a pleasure having you all with us. And now I will announce the winner for the yesterday's day end quiz. It is Dr. Praveen RS from ABV IMS and Dr. RML Hospital. Congratulations to you, Praveen. And now the delegates, the day end quiz and the feedback forms, they have been sent to you in your email, and the link is activated just now. So just do it at the as the earliest, because the link is closed in some time.
And first,
The earliest one to give the answers will be the winner. And see you all tomorrow at 8 a.m. sharp for the next session. Thank you. तो बढ़िया आंसर देख सही दिलवा मैंने क्या